Hello friends, Namaste from India. A very good morning, good afternoon and good evening to all of you who have joined us today from different parts of the world. Ending tuberculosis and AIDS is not just a public health goal, but essentially a human rights imperative, as we all know. Death is an ultimate truth for all of us mortal beings. But as of this moment, we can save lives today. No one needs to die of either TB or AIDS. The day we give up is the day we die. Welcome to AIDS 2024 affiliated independent event on the theme No Time to Die. Find all people with TB and HIV. Treat all of them, save lives, and stop the spread of both. Even one TB or AIDS death is a death too many. We have the tools to find all TB and HIV, treat all of them with effective medicines, and prevent any further transmission of both of them. We have communities that have demonstrated from the front lines how people-centered, rights-based, and gender-transformative approaches are critical to help save lives. Despite progress in the fight against TB and AIDS, we must have the courage to admit that we are failing too. Every person who gets newly infected with TB or HIV is a missed opportunity to do better in stopping the spread of infection. Every person who's not aware of her, his, their TB or HIV status is another missed opportunity to do better in finding all people in people-centered, rights-based, and gender-transformative manner and link them to the care pathway. Every TB or AIDS death is a grim reminder of our collective failure to avert it. If we are to end AIDS, we have to ensure that along with the 100-100-100 target, that is, 100% of people with HIV know their status, 100% of people with HIV are on life-saving antiretroviral therapy, and 100% of them are virally suppressed. We also have to ensure that no one suffers or dies of TB. We must ensure that 100% people with HIV know their TB status on an ongoing basis. 100% of those with active TB disease are treated with medicines that work on them. And 100% of them are using a full range of appropriate combination prevention options to stop further spread of TB and HIV infections. Friends, this AIDS 2024 affiliated independent event is being co-hosted together by a number of organizations. CAPRISA, Center for AIDS Program of Research in South Africa, UNAIDS Asia Pacific, AVAC, International Community of Women Living with HIV, Global Network of People Living with HIV, or what we call GNP+, Y+ Global, Y Peer Asia Pacific, Society for AIDS in Africa, which is the official secretariat of International Conference on AIDS and STIs in Africa, which is called ICASA. Zimbabwe National Network of People Living with HIV, APCOM, Prevention Access Campaign, National Coalition of People Living with HIV in India, AIDS Society of India, Ivorian Network of People Living with HIV, or RIP+ in Ivory Coast, Botswana Network on Ethics, Law and HIV/AIDS, or BONELA as we call it, National Empowerment Network of People Living with HIV/AIDS in Kenya, or NEPHAK, MPLUS Foundation Thailand, America's TB Coalition, TB People Global, TB People Nepal, TB People Zimbabwe, TB People India, TB People Botswana, Humana People to People India, Rekat, Peduli Foundation Indonesia, Pahal Foundation, Cheyutha, People's Health Organization, Health TV Online Nepal, Asia Pacific Cities Alliance for Health and Development or APCAT, Asia Pacific Media Alliance for Health and Development, Union Southeast Asia Trust, Global AMR Media Alliance or GAMA, and CNS. So we have 35 organizations who have joined hands in the spirit of partnership to jointly co-host today's event. Special thanks to Team Humana People to People India for hosting an in-person meet of this session in Delhi, India. India has the highest TB burden worldwide, and Delhi state has the highest TB rate among all the states in India. To set the stage, we have amongst us Dr. Tara Singh Bam, who has helped us further and deepen our own understanding in breaking the disease silos and call for stronger local actions for integrated and socially just health and development on the ground. Dr. Bam is Asia Pacific Tobacco Control Director for Vital Strategies. He is also the Board Director of Asia Pacific Cities Alliance for Health and Development or APCAT, and he is former Asia Pacific Director of International Union Against Tuberculosis and Lung Disease or the Union. We welcome Dr. Bam as chairperson of today's opening session of Setting the Stage. Over to you, sir.
Thank you, Shobha and Bobby, for organizing this excellent events. And you, CNS, as a family, coordinating, working with the many partners around the world. I think this is a really great event. As a media, as a community, I would say that the service-oriented people, the CNS and the whole teams. I have been noticing this, this organization working for a long time in building the public health, the efforts around the world, and also on very specific topics like tuberculosis, HIV, and there are many others. So with this, I think thanks Shobha for highlighting the key points here. No one wants to die with TB or HIV or any disease. That's what we want. But what is happening, the reality is people are still dying. Millions of people dying with TB and HIV and many other non-communicable disease as well. So why this is happening? So I think as you mentioned, now we have also the technology there, we have a science, we have the people. I don't think that there is a big gap of the resources in terms of the funding, also in terms of human resources. It's all up to the settings. And but the things is still not improving. People are still dying of TB and many other diseases as well. So how to really change this whole dynamics? What are the gaps? Where do we focus? Do we focus in Geneva, or do we focus in Newark, or do we focus in New Delhi, or do we focus where? Or we focus more mainly within the donors, the community, or we focus in policy makers at the national level, at the global level, or we just only talk within the UN Assembly, WHO Assembly, or all these things. It's happening around the world. And if you look at all the things, I think the global community is spending millions of dollars just to organizing these meetings at the global level. So, but at the same time, we talk about there is a funding gap to buy the medicine, for example, for a remote village in Nepal. But at the same time, the people gather from Nepal and from other countries in Geneva is spending already more than $100,000. We have to really look at how to make an effective utilization of the resources and how to really implement the plans at the local levels, and how to translate the global knowledge into action at the local levels, and who are the key people really to tackle these issues at the community levels. So I think this is one of the really wonderful examples that we have here. Is now the people who are suffering with TB or suffered with TB, now they are also part of this, the alliance, parts of this mission of eliminating tuberculosis. So that is a great thing, but we need to sustain this. That is not it's not enough. We need to sustain this, the efforts at the community level. We need to really find the locals, the problems, and identify the local solutions. There are many people working on the grounds, and how can we make them more accountable from the policy perspective, for example? The mayors at the city level, the district, the head, the political bodies, they are there. Their mission also to build really the healthy community in their jurisdiction. We need to really engage them and make them accountable and work, for TB elimination or HIV control or any other disease prevention. So I think it's really important to have these. The issues needs to be tackled. And one of the big issues I think we need to discuss here is it's not only how to make effective utilization of the resources. Yeah, in my opinion, I don't think there is a big funding gap, but it's not effectively utilized. So that is the big question that needs to be also addressed and discussed, and also recommend to the relevant policymakers as well. So that is something, Soba, I would like to highlight. Over to you. Anything that I need to take further? Please let me know. Soba?
Hello, hello. Yes, Dr. Tara Singh Bam, thank you so much for these words. Sorry, my light is probably a bit difficult, but yes, your words are so right. Like this is really important, and I will like to remind people that Dr. Tara Singh Bam had said last year that we have heard these statements many a times that these areas are difficult to reach. For example, hills or mountainous areas in low and middle income countries. But what should we do? Should we flatten them? So the point here is to ensure that all health and development services reach people with equity. So with these words, I will like to move forward, and let me invite Alberto Colorado. Alberto Colorado is a Mexican sociologist, TB and HIV/AIDS activist, and international public health consultant with more than 30 years of professional experience. He's the executive director of America's TB Coalition and the Regional Tuberculosis Social Observatory, a global TB community advisory board emeritus member, and a former vice chair of Human Rights Reference Group for the Global Fund to Fight AIDS, TB, and Malaria, and has served on several WHO Stop TB Partnership working groups. So, Alberto, you are most welcome. Thank you so much. You are one amongst us. You are a host as well as a guest. Thanks a lot. Dr. Tara Singh Bam's opening and remarks has really set the stage, and now the mantle is on your hands. Thank you.
Thank you, Brother Bobby. This is wonderful. And I'm very happy how we started this conversation. Is that we need to look into more a critical point of view of what is going on between TB and HIV communities. So here is in the afternoon. I know in India is very early, but I think it's a good way to see what is going to happen with this HIV TB marathon of speeches and conferences. And I like the tone that we started, because usually I'm very careful how to address these issues because we're very sensitive. But as our friends mentioned, this is a difficult. Where should we start to work? So I prepared some slides in order to show you what has been happening around. I don't know, Bobby, if you have it, or I can share it from here.
Yes, you can share it from there. Yeah.
Okay, hold on. And I thought this is a great great way to show you what is going on. And as you can see, when one of the HIV/AIDS and the AIDS conference, we some of you know this beautiful lady and David Bryden there. We were talking about what is happening in the world with the AIDS, TB, and diabetes integration. You can add other diseases that is part of this endemics of TB and HIV. And as you can see, we are together, but back to back and looking to the different directions. As I mentioned, Dr. Tara, where should we focus? But unfortunately, we are not facing each other. So this is one of my main concerns for a long time. I've been an AIDS activist for a long time, since the beginning of the epidemic. And so for me, I think it's very, very important to start with that conversation. And let's see if I can move it from here. Okay. So how we see this interactions between several diseases that we call now syndemics. We know that tuberculosis and syndemics are the HIV/AIDS and their social determination, not only determinants of health that everybody is talking about, are indicators of inequity and limitation of the right to life, dignity, and health for all affected communities. Because we belong to the same communities affected by HIV, TB, and diabetes, we also face stigma and discrimination, as well as challenges from cancer, viral hepatitis, sexually transmitted infections, and others, including those tuberculosis extrapulmonar, that extrapulmonar tuberculosis is often not seen in our area because we are so much focused on the public health of not infecting others. That means only focus on pulmonary tuberculosis. But we know, and especially for the HIV/AIDS community, need to be very careful because there is a Mycobacterium bovis who is unfortunately affecting a lot of that community. I've seen in some Latin American countries the increase of the peritonitis infections plus meningitis TB among HIV/AIDS communities. But because we are not prepared to see it, and also because we are not focusing that, we are being affected by those extrapulmonary TB, especially in the HIV/AIDS communities. And stigma and discrimination are prevalent in TB and HIV communities, mostly from the same key affected populations, such as migrants, indigenous groups, people in prisons, alcohol and drug users, women, children, LGBTQ plus communities, among others. As you can see here, over the year, I used to have a black hair. Over the years, I have spoken at several international, national, regional conferences, emphasizing the importance of collaboration between HIV and TB communities. Despite the repetitive nature of my message, I feel that more needs to be done. It is critical for HIV communities, and I'm glad that several HIV communities are here, that we need to take a meaningful action to prevent, treat, and reduce TB-related deaths in their communities. By doing so, they will not only positively impact their own communities, but also contribute to the global effort to end TB. We have long been promoting the prioritization of establishing effective TB HIV collaborative mechanisms. Our advocacy efforts have been centered on reducing the burden of TB in individuals with HIV and AIDS. Also has been our focus to decrease the burden of HIV in patients with tuberculosis through collaborative activities. However, we feel that besides of collaborative efforts, we need to shift our focus from TB to HIV and approach it from the HIV standpoint, because it appears that the level of dedication from the HIV communities is not equivalent. For instance, I just reviewed the World AIDS report, and TB is only mentioned only 20 times, mostly in relation to the Global Fund to fight AIDS, TB, and malaria, and also in the bibliography. Unfortunately, there is some piece of how to work together, but not taken seriously that I will think they needed to take. We know that from the TB perspective, tuberculosis carries with the urgency to address HIV as TB, the leading cause of death among people with AIDS, HIV and AIDS. Various resources and global agreements, including the NTB strategy, the Sustainable Development Goals, and the TB declaration from the recent in the UN high-level meeting on TB are on the table. We have the tools, like our friends mentioned. We have the tools, we have the strategy with the pillars, we have the vision, but what is happening? Why we are not talking about? So there is it was a high-level meeting here. You can see my hat, and I was very happy to be seated by the administrator of the AIDS government in Mexico. We were facing each other, and so at least we have some connections there, trying to address the issue of TB and HIV. But we can see, unfortunately, how is in the Americas. If you see the numbers in India and Asia and other countries, we see that we have a few like numbers of TB. The statistics are not reflecting what is suffering our communities in Latin America. But also there is a stigma about our region, because we have the burden of only the 3% of TB along the world. But unfortunately, that means that we really are not a priority, but also we can use it as an example that we can, if we have few cases, at least we can reach on time the elimination of tuberculosis in our area. So it's how we focus. And I don't see the international organization, including Global Fund, the USAID, really focusing on our community. That's what our main concern. As you can see, thousands of people with TB and HIV, and there is a 32% of current in people with HIV, and the majority of cases are in those 7 countries. So we know where the problems, so we need to tackle. And unfortunately, as you can see, only 23% of TB HIV cases were taking the treatment, preventive treatment, and only 19% of people with TB HIV die. So that does not need to be happened. So we call the governments, international organizations, and communities. We did this a long time ago, but we updated it. TB and HIV communities, we joined together with governments, and we come out with these 5 points that you can see also, and I think you're gonna see it along the whole marathon of presentations, how we can at least address these issues from several points of view. We need the participation of everybody, but especially, like I said, we need to focus also from ask the HIV community to help us in that piece of preventive treatment, finding cases, and with that effort, I think we're going to have a better way, better view, and less death of those communities who are being suffering and affected by tuberculosis. So I left you that points to just to see it later. And with that, I would say thank you very much for the invitation. I welcome everybody to follow all the speeches that our great speakers are going to be here in this marathon of TB and HIV. And I hope to see all of you again in the next UN high-level meeting of TB. Thank you.
Thank you so much, Alberto. Really inspiring always. You have been a personal inspiration also in HIV and TB and health access and rights. So thanks a lot for joining us this morning.
Yeah, I'm trying to stop it.
Yeah, all right. Okay. So anyways, so now let me move on and welcome another person who has done inspiring work is Dr. Imran Pambudi in the region. Dr. Imran Pambudi has led the National TB program. Dr. Tara Singh Bam, who earlier spoke, as we all know, he has championed, has demonstrated how local actions can really make a huge difference in lives of people, because it's often a same human being who is impacted by so many other health and development challenges, and local actions are so critical to advance progress on a range of SDGs, so not just about NTB. So Dr. Imran Pambudi is now the director of infectious diseases at the Ministry of Health in Indonesia. So welcome, Dr. Imran Pambudi. Thanks a lot for your inspiring work, and we look forward to hearing from you.
Yeah, good morning, Bobby. Can you hear my voice clearly?
Yes, sir. Loud and clear. Thank you.
Okay, thank you. So, good morning, ladies and gentlemen. A very good morning from Jakarta. So, as the global community gathers, I'm honored to share Indonesia experience at this meeting. So, today I will talk about our commitment and the collaborative effort we have undertaken to tackle major public health challenges like tuberculosis, HIV, and hepatitis. Our story extends beyond our borders, calling on the world to join us in these critical global health battles. This meeting is more than just a place for discussions. It's a strong reaffirmation of our dedication to fight the widespread diseases that impacts millions across our country. Our participation here shows our united determination to meet these challenges with relentless energy and creative solutions, ensuring that every Indonesian gets the healthcare they need. And also, this gathering highlights our commitment to united approach, making sure our combined efforts to fight these diseases are as true as and effective as possible. So to give context, firstly, let me underscore that Indonesia continues to tackle with a significant burden of tuberculosis, ranking as the second highest burden country globally. In 2023 alone, our TB incidence reached approximately 1.1 million cases. Adding to this burden, to the co-infection rate of TB and HIV presents a compounded challenge, with about 24,000 incidents reported last year. Despite these daunting figures, our rigorous effort have led to a notable expansion of integrated testing and treatment facilities. Currently, there are over 2,100 TB and HIV collaborative sites spread across our vast archipelago, and each equipped to manage the complexities of this dual infection. Hepatitis similarly prevent further complicates Indonesia public health landscape. Our latest data indicates a significant prevalence of hepatitis B and C across the nation, underscoring the need for a robust and integrated response. Specifically, hepatitis B affects approximately 7.1% of our population, and it's translating to about 19.5 4 million Indonesians. These figures highlight the critical necessity to integrate hepatitis management within the existing framework established for TB and HIV, and ensuring that our strategies are comprehensive and address the full spectrum of viral infections affecting our citizens. One of the key strategies in our fight against these diseases has been the optimization of molecular testing. So the utilization of PCR technology across TB, HIV, and hepatitis program has not only streamlined diagnostics, but also enhanced the efficiency of our national health services. By harnessing this technology, we have improved the accuracy and speed of diagnosis, which is critical for effective disease management and control. As of the latest data, there are 217 health facilities equipped with gene expert machine that are now used jointly for TB, HIV, and hepatitis testing. And this deployment represents a substantial increase from previous years, showcasing our commitment to leveraging existing technologies to expand our diagnostic capabilities significantly. And these facilities now serve as a critical nodes in our health network, offering comprehensive testing that covers 3 of the most challenging infectious diseases in our public health landscape. However, despite these technological advances, we continue to face significant challenges, notably the integration of service across different health domains and the reduction of stigma associated with these diseases remain substantial hurdles. Furthermore, the persistent stigma associated with TB, HIV, and hepatitis poses a severe barrier to effective disease management. Stigma discourages individuals from seeking testing and adhering to treatment, leading to underreported cases and increased disease transmission. To counteract this, we are making concerted effort to enhance our supply chain mechanism, ensuring the uninterrupted availability of essential diagnostic and medications. This effort, including streamlining procurement processing, improving logistic management, and ensuring that all health facilities are consistently stocked with the necessary supplies. Additionally, we are significantly expanding community engagement and education program aimed at dismantling the stigma surrounding these diseases. By increasing awareness and understanding through media campaign and collaboration with local leaders and influencers, we aim to shift public perception to seek and continue essential treatment. So as integral part of our strategy to improve disease management and reporting accuracy involves the integration of our recording and reporting system, which has been verticalized. And also, we are linking this effort with BPJS, National Universal Health Coverage System. And this connection aims to bridge any remaining gaps in disease reporting and management. By leveraging BPJS extensive reach of work, we can enhance access to diagnostic and treatment, ensuring that more individuals receive timely and appropriate care. This integration not only supports the national agenda for health equity, but also strengthens our overall public health infrastructure, making it more resilient against the challenges posed by TB, HIV, and hepatitis. Looking ahead, the integration of digital health technologies holds promising potential for enhancing service delivery. Telemedicine and mobile health applications are poised to revolutionize our approach, particularly in reaching remote and underserved populations. The implementation of digital tools will not only support better data management, but also improve patient follow-up and adherence to treatment protocols across TB, HIV, and hepatitis care. In closing, while the challenges are significant, the extensive network of TB and HIV collaboration sites, along with the strategic use of using gene expert machine across diseases, underscores a national response that is both robust and adaptive. As we continue to innovate and integrate, our collective efforts are crucial for shaping a healthier future for all Indonesians. Our journey toward health equity is far from over. We still need to strengthen our healthcare systems, enhance our community outreach program, sustainable financing, and also ensure that every Indonesian has access to essential health services. I firmly believe that with our combined effort, we can reach the goal of eliminating these diseases by 2030 in alignment with the Sustainable Development Goals. As we move forward, let us keep pushing the boundaries of what is possible in public health, striving for a nation where health equity is not just an aspiration, but it is a reality. Together, we will continue to build on the process we have made, tackling its challenges with resolve and resourcefulness. Thank you once again for standing together in this vital effort. Let's remain steadfast in our mission, harness the power of our collective action, and transform our aspirations into tangible outcomes for the health and well-being of all. Good morning. Thanks from Indonesia. Bobby, back to you.
Thank you so much, Dr. Pambudi, for your words and also the reminder that our journey, our efforts for health equity are far from over. It is and let us hope that your words come true, that no person in Indonesia or other places needs to suffer unnecessarily, and also compliment you for deploying the latest technologies for multi-disease platform diagnostics on the ground, which is really so important, one of the very key essential steps forward. Thank you so much, Dr. Pambudi, for joining us and your words of inspiration and showing us some light. Thanks a lot, Dr. Pambudi. Moving on, we have amongst us another person from Vietnam, a real personal inspiration, Dr. Nguyen Binh Hoa. Dr. Nguyen Binh Hoa, as many of us will be very familiar with, has been part of the research team that has demonstrated in the recent past that if we screen everyone regardless of symptoms for tuberculosis in high burden settings, we can drastically reduce the TB incidence. The TB incidence fell by over 70%, I think, in the last 4 years. Dr. Binh Hoa, welcome. Please correct me if I have quoted your scientific outcomes wrong, but you have been a real inspiration to influence governments and policymakers to screen everyone, to find all TB, as Dr. Tara Singh Bam has repeatedly said, to treat all of them, and of course, prevent all the transmission of TB and HIV both. So welcome, Dr. Binh Hoa. Dr. Binh Hoa.
Yeah, thank you very much for the introduction.
Sir. Thank you, thank you, Dr. Hoa. Come, welcome.
Yeah, so for my presentation, may I share my screen?
Yes, sir, please do. Dr. Binh Hoa is the Deputy Director of the National TB Program in Vietnam and also the Vice Chair of the National Lung Hospital in Vietnam. Over to you, Dr. Hoa.
Yeah, when we minute, I will share screen.
So while Dr. Hoa is sharing his screen, let me read out a comment which has come from Dr. Zafar that Alberto, you remind me of the statement, bacteria and virus have joined hands, but have we? Very important comment, Dr. Irshad, that have we, have even the programs, TB, HIV, nutrition, so many other, things which influence our NTB and NAIDS programs, have they joined hands? So over to you, Dr. Hoa. I think we can see your screen.
Yeah. Good morning, everyone. Before I begin, I would like to thank the organizer for the invitation to speak at this event. I have a pleasure to sharing some of the Vietnam effort to NTB and achieve sustained epidemic control for HIV with you today. My name is Nguyễn Bình Hòa. I am the Vice Manager of the Vietnam National TB Program and Vice Director of the National Lung Hospital. So you can see in screen the incident, new and relapsed TB case notified and HIV positive TB incident estimate for Vietnam. Vietnam is one of the 30 high burden country, ranking 11 among high TB incident and also 11 among the high MDR TB incident. In the year 2022, there were about 172,000 persons who developed active TB, including 4,300 persons living with HIV. With respect to the total HIV burden, the estimated number of prevalent case is 242,000, representing about 0.24% of the population. Each year, about 30 million individuals are newly diagnosed with HIV. Most of them concentrate among men who have sex with men, female sex worker, and a person who inject drugs. Among the key population, the estimated prevalence is 15 to 33 times higher than the general population. Both TB and HIV remain a key driver of the avoidable mortality in Vietnam, with about 19,000 individuals dying of either disease each year. The mortality number includes 11,000 HIV negative persons with TB, 2,600 persons with TB HIV co-infection, and 5,300 all-cause mortality besides TB among persons living with HIV. That represent a mortality rate of 20 per 100,000 population, which is 3 times the rate of death from the traffic accident. Nevertheless, the silver lining is over the past decade, the number of people dying from TB or HIV are steadily decline in Vietnam. The decline in mortality is in large part driven by the government of Vietnam prioritizing and scale up of the national TB program and the Vietnam Administration for AIDS Control or VAC, thanks for the support of the major funder such as PEPFAR and the Global Fund. This has resulted in national expansion of the TB care network to reach the treatment coverage of 59% and treatment success rate of 89%. However, TB remains a catastrophic lie even with 63 to 98 is 63% among the sensitive TB and 98% among the MDR TB suffering the catastrophic cost and a case fatality ratio of 8%. In terms of the progress towards the 95, the VAC had achieved 89 of HIV positive persons know their status. 73 of those have initiated on ART, and 72% of persons on ART have achieved virus load suppression. The major political success in the recent past has been the transition of the financing for both disease to Vietnam Social Health Insurance Scheme, which now cover about 93% of persons living with HIV and about 87% of the antiretrovirus. With both the NTP and VAC have had recent success in progressing towards the national target in their respective disease. There remain gap in the bi-direction integration of the service. For example, 1 in 6 persons with TB are still not tested for HIV. 1 in 4 are not initiated for ART right away, and only half of eligible persons living with HIV are provided TB preventive therapy. Conversely, TB-related target with HIV program could be more ambitious, as illustrated by the PEPFAR fiscal year 25 target for TB prevalence of 5,124. In addition, both programs also face additional complexity from the policy chain and epidemic shift. Specifically, the TB continue to monitor and support the transition of TB financing to social health insurance in order to sustain quality of care at the subnational level. At the same time, with the goal of ending TB by the year 2035, the NTP is implementing resource-intensive strategy such as community-based active TB case finding and novel public-private mixed model, locally evaluating new diagnostic tool and regimen for rapid programmatic introduction, and exploring TB-sensitive and TB-specific social protection and support mechanism for elimination of the catastrophic cost. Meanwhile, the HIV epidemic is undergoing a dramatic shift from the commercial sex worker and person who inject drug towards the people have a both sex, so that HIV control strategy have to fundamentally change with respect to active case detection, community engagement, advocacy, and social mobilization and public health response. One of the core areas of the opportunity is the evaluation of C-reactive protein assay, or CRP, for TB screening in person living with HIV, which will also help to fill a global evidence gap. Supported by the USDC, NTP and the FIS compare the CRP to chest X-ray in asthmatic person newly diagnosed with HIV and found similar sensitive to X-ray, but substantially lower specificity. Similarly, the NTP is launching several studies on the second generation of the Fujifilm TB LAM assay with and without a novel urine concentration device for the diagnosis of TB in person living with HIV and HIV negative individual. Additional local evidence will also be generated for novel TB infection tests such as SD biosensor, TB feron interferon gamma release assay, and the ultra-short 1HP regimen for TB phyllolysis. The most anticipated new tool for secondary prevention of TB is the M72 vaccine. Vietnam is one of the 7 countries to participate in this important phase 3 clinical trial that will allow the recruitment in August or September this year. However, as the vaccine efficacy is about only 50%, it will be important to begin conducting study in the social science to evaluate the acceptability and develop communication strategy to advert the vaccine resistance and observed during the COVID-19. This is particularly important with the demographic shift in HIV towards the male sex with male, who will require tailored outreach and engagement. In conclusion, I want to leave you with 4 key takeaways from our effort to end TB and achieve sustainable epidemic control HIV. First, ending TB and achieving sustained epidemic control for HIV must remain top of mind priority for equitable development. Second, there continue to be a key area of opportunity in program implementation and performance for TB and HIV, especially in prevention, and it is critical to recognize that their challenge will be separate by shifting dynamic and major externality such as pandemic. Therefore, TB and HIV program have to continue to evolve and optimize by evaluating and rapidly introducing new tools and treatment into routine programming. Lastly, the introduction of new tools and even as TB vaccine can sustainability advance prevention of TB and HIV negative individual and people living with AIDS. But in the limited vaccine efficacy, advocacy and social science research on acceptability are urgently needed and must commence right away. Once again, I want to thank the organizer for this important event and thank you all for your attention. Thank you.
Thank you so much, Dr. Bin Hoa. This is really very important for all of us to acknowledge right in the beginning that while we wait for the safe and effective vaccines to prevent TB, if they become available, if and when they become available, we should be really ready to roll them out equitably and make sure vaccination happens and not just vaccines sit on the shelves. But as of now, as of today, we really need to deploy all the tools and technologies and people-centered approaches which we have to make sure that we find all TB and HIV, treat all of them, and ensure we stop the spread of both of them and save lives. We have amongst us Dr. Guy Marks. So let me move on for further. So Dr. Guy Marks, welcome. Dr. Guy Marks is probably is known already to all of us. He is the president and executive director of International Union Against Tuberculosis and Lung Disease, the Union. And as we all know, a very respected respiratory physician and expert and scientist at the UNSW and now also in the Burnet Institute in Australia. Welcome, Dr. Guy Marks, and our personal inspiration and force when it comes to find all TB. Dr. Guy Marks was perhaps, when I look back, I think Dr. Guy Marks' voice is the strongest for finding all TB regardless of symptoms in high burden settings. I really wish if all the governments had listened to his voice much stronger and much early on, but let us hope that more action happens on what Dr. Guy Marks has to say. Dr. Guy Marks, welcome. Thanks a lot for joining us.
Thank you very much, Bobby. Can you hear me okay and see the slide?
Yes, sir. We can hear you loud and clear. Thanks.
Okay, good. And thank you for those kind words. It's good to see so many familiar faces. Well, actually, I can't see the faces, but I can see the names. It's good to see so many familiar names online. And now I can see Tara's face, which is nice. And thank you, Hua, for that presentation. One of the disadvantages of seeing so many familiar faces is that many of you have seen what I'm going to say before. But many of you have not, I guess. And I hope that I've tried to at least introduce this with some perspective on the TB HIV interaction. But I don't profess to be an expert on HIV, and I'm mainly going to talk about TB elimination, and the reason I'm going to do that will become apparent in a few moments. I've just really got one introductory slide to make some comments about HIV and TB. And most of this will be fairly familiar and obvious to you, but obviously in countries with a high burden of TB, TB is an important comorbidity for people living with HIV. Actually, and I preface that by saying in countries with a high burden of TB. In countries where TB has already been eliminated, in fact, TB is not an important comorbidity for people living with HIV, including the country where I'm speaking to you from at the moment. But it is in many of the high countries around the world and countries that are represented here. For people who have HIV, TB is a very important problem. In countries with a low or modest burden of HIV, which of course is most of Asia, but it does not apply to Southern Africa, for example, but for most of Asia, HIV is not actually a major driver of TB at a population level. Most people who develop TB don't have HIV. And to put it another way, if we eliminated HIV and did nothing about TB, we would have no real impact on the epidemiology of TB in countries. So this is not a symmetrical problem. And the reason for this is that TB, unlike HIV, that the mode of transmission of TB and HIV are dramatically different, as everybody in this room knows. TB is an airborne infection, and hence people living with HIV are at risk of acquiring TB infection and consequently TB disease from anybody in their community, not just from people who also have HIV or people who share the risk factors for HIV. So it's not related to injecting drug use or commercial sex work or men who have sex with men. It's from anybody in the community with whom they share an airspace, a room, a building, whatever. They can become infected with TB and go on to get TB. And that's the reason for the second dot point above. We know very well that people with HIV and TB infection are protected from developing TB by antiretroviral therapy, reducing their viral load and improving their immune status, by tuberculosis preventive therapy. We'll also, if they have TB infection, we'll also protect them. But generally, the evidence suggests that that protection does not last very long after the completion of TB treatment. So if you give TPT for 36 months, then it lasts for 36 months plus a bit more. If you give it for 6 months or 3 months, then it lasts for 6 months or 3 months plus a bit more. It only lasts during the time the TPT is actually administered and then until reinfection occurs. And so clearly the third dot point is key to protecting people with HIV from developing TB, and that is preventing them from being reinfected with TB. And ultimately, the key to ending TB as a problem for people living with HIV is ending TB for everyone. You can't just end it in people living with HIV. It's just not feasible. You have to end it for everyone to end it for anybody. So that's why in the rest of this talk, I'm going to talk mainly about just ending TB. And as everybody's familiar with this map, and as I've said a few times recently, instead of just looking at this map as saying, well, this is where the problem is and this is where we need to focus, the way I look at this map now is as an indication of massive inequality, injustice, and failure. If we have all these light-coloured areas like North America, Western and Northern Europe, and high-income parts of Asia Pacific region, then there's no reason why we can't have light-coloured areas throughout the rest of the world. There's no technical reason why we can't achieve this. And we've had the tools, we've had the capacity, but we have not done it in the last 50 years. In Asia, TB it's a very heterogeneous region in all of these sort of respects. Some of them are directly related to TB and some are indirectly related, economic, political, and demographic characteristics. But in my view, and looking at that map that we saw before, our key goal at the moment must be to convert the high and moderate burden countries to low burden countries. Achieving this goal would achieve really substantial health gain. It is achievable and it benefits everybody in the era where there's migration, trade, and travel. So, if we can convert all of these dark green areas to light green areas, we will save a lot of suffering and a lot of lives. And we will also actually, as a side benefit, relieve the current low burden countries of the burden of screening and managing patients who come from those countries to low burden countries. So there's a lot of reason to focus on this as our goal, converting high and moderate burden countries to low burden countries. The epidemiology of TB in high burden countries is that everybody is at risk of being infected everywhere all the time. It's interesting that if you live in Australia or North America or Europe, it's very obvious both to members of the general public and to clinicians and public health workers that TB is an infectious disease, and that unless you acquired the disease overseas when you were visiting or living in a high burden country, it's obvious that most people who develop TB in my country develop it as a result of contact with a known case of tuberculosis. They know that they were infected, and we know that they were infected by somebody who had TB. If you live in India or Pakistan or Vietnam or the Philippines, everybody is being infected everywhere all the time. So nobody can tell that a particular episode of contact was responsible for their episode of TB. It appears to everybody. So everybody is exposed. And that means that it's not obvious to people that it's the infection that's causing the disease. And there was famous epidemiologists in the non-communicable disease field who made this observation about smoking and lung cancer, that if everybody in the world smokes, or everybody in your location smokes, then it appears that smoking is not the cause of lung cancer. It appears that something else is causing lung cancer, maybe genetic factors, other risk factors. If everybody is exposed to a risk factor, then you can't see the association with the risk factor. But of course, we all know from a lot of research, and we've known for 160 years that TB is caused only by infection with the organism, by exposure to an infection with TB. The problem is that people can't see it in high burden settings. Most people who develop TB do so within a few months of being exposed and infected. This is the case in high burden countries. In low burden countries, it's different. Most cases occur due to reactivation of remotely acquired TB infection, but we estimate that something between 60 and 80%, or maybe even more, of TB that occurs in high burden countries occurs fairly soon after, at least within 2 years of exposure. And that means that there will be a rapid benefit in terms of reduced risk of TB at a population level if you reduce the risk of exposure. Most people with infectious pulmonary TB do not have symptoms, possibly, but certainly more than 50%, and in some studies, 70% of people with infectious pulmonary TB do not have any symptoms. And then additionally, of those who do have symptoms, many do not seek care because they don't regard it as significant, or they can't get to care. So if they don't have symptoms, they don't seek care, or they can't access care, then they are not going to get a diagnosis and treatment. And it's not having symptoms that is the most important driver. And as I mentioned earlier, TPT does not really have a durable protective effect due to the high risk of reinfection. The other thing I just want to highlight, and I know there's a lot on this slide, and I'll just briefly, I'm not going to go through it in detail, but I want to briefly get you to think about the two different ways in which we deal with TB in populations. One is that we provide clinical care for people who have respiratory symptoms. And some of those people who have respiratory symptoms have TB. Many, of course, do not. They have cough, fever, weight loss, breathlessness, maybe hemoptysis, and they have other causes of TB, other causes of those symptoms like pneumonia or lung cancer or bronchiectasis or some other cancer. And so the purpose of clinical care is actually not mainly to deal with TB, it's to deal with the range of different problems that cause those symptoms, diagnose them and treat them. So we're managing people with respiratory symptoms or extrapulmonary symptoms, and we're trying to diagnose whatever is the problem, including but not limited to TB. And the approach to achieving this is health system strengthening, universal health coverage, effective primary care, and ability to find whatever is wrong with people in health facilities. The limitation of this is that it's not relevant to ending TB in high burden settings. In high burden settings, this approach will find, as I've alluded to in the previous slide, only a small minority of patients with TB who are continuing to transmit the disease, because most of them are not symptomatic and not presenting for care. So it will be beneficial to the patients who are sick and who present for care, and it will prevent some of them from dying, but it will not accelerate the end of TB. If we want to end TB, which also, by the way, reduces suffering due to TB, then we need to stop transmission of TB in the community. And to stop transmission of TB in the community, we need to find all people who have infectious TB that are transmitting it to everybody. And there are a range of strategies that we can reduce, which I've sort of listed here, which might lead to a reduction in transmission, and therefore we will reduce the incidence of TB and ultimately reduce the prevalence of TB. So both of these are actually important. We cannot replace clinical care by mass screening, but we also cannot achieve the end of TB by giving clinical care. And we need to do both in order to deal with the problem of TB for the foreseeable future. So many of you have seen this slide before, and I don't want to dwell on it, but It just re-emphasizes that somehow we need to break this chain of transmission, that ultimately people get infected, they get active disease. By far the main source of infection is people with active disease. And so this cycle is what maintains the epidemic of tuberculosis. And the strategy for ending TB must be to break this cycle. And here I've highlighted a number of interventions that potentially could break this cycle, either alone or in combination. The ones I've shown here in orange don't actually exist. They're potential, but a vaccine either to prevent infection or to prevent disease in people who have infection would be useful, but none of them is actually proven to be effective or in the market. The ones I've shown here in this light blue color are effective interventions, but they have a limited impact. They will not themselves end TB. They are what is currently basically responsible for the gradual decline in TB incidence that we're currently seeing. These two interventions have both been shown to be effective in rapidly decreasing the incidence of TB. Although the evidence for this mass treatment of TB infection is much more limited, mainly comes from the studies done by George Comstock in Alaska about 50 years ago. There are no other good trials of mass treatment of TB infection that exist. And then our study in Vietnam, which I'll remind you about in a few moments, was about finding and treating all people with infectious TB, which had a dramatic impact on the subsequent incidence. This proof of concept study we did in Vietnam, in a remote rural province in Vietnam, just to highlight 3 results slides that, again, many of you have seen. First of all, by reducing the prevalence, in this case, compared to baseline, reduced the prevalence by 72%, and compared to the control group, reduced the prevalence by 44%. This was a mass screening using, in this case, expert sputum screening of the entire adult population. The consequence of reducing the prevalence was a reduction in the risk of transmission of infection. And here you can see that in the villages where we did screening and were able to reduce the risk of transmission, children acquired TB infection at half the rate that they did in the control villages. So showing that transmission have reduced. And in this slide, showing that new cases of TB, newly diagnosed or incident cases of TB, fell by 57%. So this 57% reduction were not people that we found and treated, diagnosed and treated. These were people who never developed TB, who were prevented from developing TB, and they were prevented from developing TB because we had reduced the number of people with TB in the population to whom they were exposed. So we reduced the risk of transmission and rapidly reduced the incidence of TB. So what do they mean? We need to find and treat nearly all people with infectious TB to prevent infection of others and break the chain of transmission. The key features of what I believe is necessary in population screening to end TB is to find all or nearly all the cases, and most of the cases do not exist in high-risk groups. While people in high-risk groups have more TB, most people are not in high-risk groups, and therefore most cases of TB are not in high-risk groups. So you need to screen everyone. Since most people with infectious TB do not have symptoms, there is no point in asking about symptoms. The first screening test needs to be a sensitive test, and that is either radiology or a molecular screening test. clearly, there's no point in finding people with TB if they don't get treatment. So one of the failures in many settings has been the linkage from diagnosis to treatment. And we need, as a part of this program, to ensure that all people that you find with TB are linked to appropriate and effective therapy. And you need to sustain it for long enough. TB is a slow disease. It's not like COVID. With COVID, you only needed to do this for two weeks, and the disease could be eliminated in a population, because if there's been no transmission for 2 weeks, then the disease disappears, as happened with SARS-1. But TB is not like that. It's a slower disease. It takes a year or more, and you need to do this. You need to sustain this intervention probably for 5 to 10 years. And the other important point to note, which many people don't seem to recognise about screening for TB, the main beneficiaries of screening for TB are not actually the people that you find with TB, many of whom have no symptoms and will never have symptoms, will self-cure. The main beneficiaries are the people who would otherwise have been infected and get TB. So a person who has no symptoms of TB and will self-cure may actually infect somebody else who will die due to that infection. So if you can prevent that person who is not symptomatic but is infectious from infecting other people, you will save lives. And the index of success should be on the impact on incidence, not the number of cases found or the yield. So just to conclude with the slide that I started with, TB is an important comorbidity for people living with HIV. I think, except in sub-Saharan Africa, ending HIV will not end TB. TB is an airborne infection, to remind you, and therefore everybody living with HIV, people living with HIV are at risk of TB infection from everybody in their community who has TB, not just people who are in so-called vulnerable groups. And that the key really to ending TB for people with HIV is preventing them from being reinfected, and also antiretroviral therapy in the meantime. So I'll finish at that point, and thank you very much for your attention.
Yeah, thank you so much, Dr. Guy Marks. It is always an inspiration, and to open the meeting with you, you set the stage, and thanks a lot for the previous speakers as well. This is really so important for all of us to be reminded that we really need to find all TB, as Dr. Guy Marks and the evidence has shown. Dr. Bin Hua has also shown this, reiterated the same thing. We need to find all TB cases, link them to care without any delay, and make sure and handhold them, support them so that they're cured and prevent all further transmission. Thanks a lot, Dr. Guy Marks, also for reminding us that it's not just about ending TB among people living with HIV who are at high risk, but in the population at a much broader level. We need to think out of the box and out of the silos. Thanks again, sir. We now move on before I move on, I think we should read out a comment. There are a few comments in the chat box. Dr. Joshi has said, also reiterated what I just said, that mostly they are doing passive case finding with very little active case finding, and with nowhere close to what evidence shows and what Dr. Guy Marks has just presented. And Dr. K. Neaton has also presented that we need a whole new approach than what we are doing right now. So true. Moving on, let us now listen to another inspiring force in our lives, but also for all those who have been involved with TB and lung diseases. Dr. Paula Fujiwara. Dr. Puri Fujiwara, as we all know, has been at very senior positions in so many organizations, including the union. She was also the chairperson of Task Force of the Global Plan to End TB 2023 to 2030, which is a very well thought of and costed plan to end TB. It's available on the website of the Stop TB Partnership as well as WHO. And of course, she is a noted lung health expert. Dr. Pauli Fujiwara, thanks a lot for joining us. Over to you.
Thank you, Bobby. I'll stop my video so you can concentrate on the slides themselves. So I've been asked to talk to you about the global plan to end tuberculosis 2023 to 2030. And this is about finding, treating, saving, and stopping both TB and HIV. So thank you very much for this invitation. So I'm going to talk to you about the following the next 20 minutes. Why do we need a new global plan? What are the TB risk factors? What's the money that we need? What can we do? And I want to really talk about intersectionality in this discussion. And so we can get to the end of fighting and treating and saving and stopping both of these diseases. And I'm going to, having listened to the previous speakers, I'm giving you the kind of high level view. We've already seen some successes. We've already seen some challenges, but I want to put it all together in a comprehensive way, because by doing this, this is how we'll end tuberculosis. So I'm talking to you about the global plan. So the first issue is, what is it? So unlike the WHO report, which tells you how many people with tuberculosis and how many with HIV, et cetera, this is actually a plan. This is actually a roadmap. This is an investment case, meaning what do we need to do? How much money do we need? And what happens if we don't do anything? And so this means it consists of priority actions that the global TB community has come together to talk about. This is the 6th global plan. We've had them since 2001, and this one started in 2023. So why do we have this new global plan? It's because the last one ended in 2022, December 2022. And also at the first high-level meeting on tuberculosis in 2018, the political declaration at the end said, we've had this meeting, let's see what happens in the next 5 years before we come together again and put together a plan so they can reach all the people to end tuberculosis. And the reason we're doing it for 8 years instead of 5 is because we wanted to link to the 2030 ends of the 2030 SDGs. So the plan itself is obviously divided into chapters, but I just want to talk about some of the key priority actions that we are saying are needed. First of all, we've heard people talk about patients here today, but really this is about people-centered care. And I think Bobby used that term, people-centered care. That's different from patient care. That's different from personal care. People-centered care means the person with the disease, but also all the people that are affected by it. And in this new plan, we're talking not only about this dichotomy of a person with infection and a person with disease, but all the people that have not all the people, but some people who have subclinical disease. And these are the ups and downs because it's a long-term disease. And so what happens in between in between having the infection and coming down with active disease. And also the classic things that we've discussed in the previous plans were how to avoid the costs, how to strengthen supply chains that was mentioned by the gentleman from Indonesia, how to raise the awareness, and how to increase the demand for services. TB prevention, as was mentioned by Dr. Marks, TB preventive therapy is absolutely key. And what's new in this plan, and this was mentioned by Dr. Benoit, is that the issue of new vaccines. Also, we were developing this plan in the context of the COVID-19 pandemic. So infection control started to have much more of a prominence. The other issue is that in this plan, there's much more emphasis on communities. The plan says that we should have 4 times the amount of money for communities than we've had in the past. The 6th chapter is new. We talk about universal health coverage for the first time, and also because of the issue of the COVID pandemic, putting tuberculosis as a respiratory disease, anyone can get it, as a pandemic prepared response, to put it right in the middle. In the 7th chapter, we talk about human rights. We've heard about stigma, both in the TB area and in the HIV, but also I'm going to talk to you about key vulnerable populations, of which HIV is only one. And then we're going to need, obviously, more new tools, more research and development. This is something that the tuberculosis community has fallen behind. We're not as advanced, so to speak, as the HIV community, but let's use not only the tools that we have, but the digital tools that are coming forward, and make sure that once we have the tools, they don't sit on the shelf, but to also ensure that they're accessible. And finally, we need money. And what's new here in this plan is the need for money for vaccination. So at the recent high-level meeting, this is the second high-level meeting that happened just in September of last year. The political declaration set out some indicators and what are the targets. And they went to 2027 in order to give us time to reconsider what's going on before we get to the end of the SDGs. So the first one is treatment coverage. I know we were talking about, Shobha mentioned, 100% of everybody who has TB or HIV has to be addressed. But this one talks about 90% coverage. So 45 million people with tuberculosis, which includes 4.5 million children and also people, significant number of people with drug-resistant tuberculosis. Preventive therapy has already been mentioned several times. We want to also address 45 million of these people. Most of these are going to be household contacts, but also you can see here, because we're talking about TB and HIV, to reach the 15 million people living with HIV, although as just stated by Professor Marks, the issue is that we have to keep giving this medication in order to have it work. Then the whole issue of rapid diagnostic testing, let's get away from the smear microscopy, and also catastrophic costs. We want to make sure there's 100% coverage by 2027. And then, as I mentioned, we had promoted the idea that we would have a new vaccine by 2026, but this was rethought, and they're saying, let's initiate the rollout, preferably within the next 5 years. That's still before 2030. And then also we want to have the annual funding for the prevention, the diagnosis, the treatment, the care, and that's going to be a significant amount of money. And also we're going to continue to need money for research. So when WHO has put this list out, leading from 2021 to 2025, and looking at the overlapping epidemics of tuberculosis, some of them is general tuberculosis, and then there's TB and HIV, and also the issue of drug-resistant tuberculosis. So if we look at the TB and HIV, which is the topic of our conversation today, and that's bordered in yellow, you can see that of the 30 countries where HIV is a high burden issue, 22 of them are actually in Africa. Now, the risk factors. I think in the TB community, we've always been thinking a lot about HIV infection, but when we think about the actual global estimates of incident cases that are attributable, there are 5 risk factors that we know about. The first is undernourishment, and that surpasses HIV by more than double. Second comes HIV, then alcohol use. I think we heard the first speaker talk about the use of alcohol. Smoking has never really been mentioned yet. Diabetes has been mentioned, but these are the 5 big risk factors for tuberculosis. Now, if these are mapped out, these are each of the risk factors mapped out in their own individual maps. But if you use your mind's eye, these are all risk factors for tuberculosis, and you just put one on top of the other, you can see that there's some overlap. HIV infection with alcohol use, there's some overlap there. For the undernourishment, the HIV infection, you can see that sub-Saharan Africa, in addition to HIV in the Russian Federation, but you can see that there's this overlapping here. And that means the whole need for integration. So we talked about the biological or behavioral risk factors. Obviously, we talked about all of them in the previous slides, but we also talked about, we didn't mention injecting drugs. Then the whole issue of where people are living. And I highlighted some of them in bold because some of them, this is for tuberculosis, but it actually is relevant. Some of them are relevant to people with that are in risk of HIV. As was pointed out, TB is a respiratory infection, HIV is not. So some of these things are very specific to tuberculosis, but some of them that I've highlighted in bold can be relevant to both communities. And then the whole issue of access. I put TB in parentheses because the access issue is an access issue for many different people. Here we have migrant workers, the women with gender disparity, et cetera, but there's also some key groups. These are people, whether you have TB or HIV, often have limited access to services. So having said what the global plan is including, and also the risk factors, how much money do we need starting last year up to 2030? So the first message to convey is that tuberculosis is a great return on investment. For example, for every dollar that you invest, your returns up to the year of up to 2050, that's the part in gray, is $40. But if you look at low and middle income countries and you invest in tuberculosis, you get a $59 return on investment. So how much do we need? We have costed this out. As I said, these plans are actually, we've taken data, tried to look to see how we can see how much money that is needed. And all the numbers, the actual percentage, the percentages or the numbers may be different because of what happened at the high level meeting. The percentages are relatively the same. Most of it's going to be needed for TB prevention and care. But what's new in this plan, as I mentioned, is the whole onset, hopefully, of TB vaccinations. So we're going to need around $53 billion. In total, we're going to need about $250 billion. But in order to reach the end, we're also going to continue to need research and development. And how do we break that down? What do we need? We need medicines. We need vaccines, as I just mentioned, diagnostics, but also the basic research has to continue. So if we look at this graph in terms of the years starting 2023 up to 2030, you can see along the horizontal axis, you can see these lines here. And this is for diagnosis, treatment, prevention, health systems, and enablers and program costs. Those are practically relatively the same. You can see a little bit of a rise in 2026 because that's when we thought we would have new vaccines. But the big new cost in this plan is the cost of vaccinations. You can see this is huge yellow block starting here in 2026 is probably going to start later. Now, if we don't do anything, if we do what we're doing now, we're not gonna end tuberculosis. If we use the current tools, we'll do a little better, but we need new tools. If we don't do anything, the costs are going to exceed $1 trillion, almost unimaginable, a way of thinking about money, where we have 43 million more people with tuberculosis and 6.6 million more deaths, which for a totally curable disease, this is unacceptable. So what is it that we can do, you and the audience can do? The first, obviously, that's been mentioned several times is advocacy. We need to have the ambition to end tuberculosis and HIV, and we need to link it with those other risk factors that I mentioned. And then when you make the plan, it should be fully costed. It's not like the problem with TB is that so many times we go, how much money are we being given? And then we'll make a plan around that. We have to be ambitious and say, what is it that we actually need? And then to remember to integrate it with some of the other risk factors that impinge on tuberculosis. And this means active engagement in country TB, HIV, and also the joint National Strategic Plan development. Having said that, we need to also look at what is relevant to the particular country because the risk factors are not the same in each country. And this means periodic screening as testing for all people that we have risk factors. It may be an issue of, in this case, Africa, where we have a lot of HIV. It may be another risk factor that we need to look at, smoking, for example, in Indonesia, to look at that. And also, let's not use the old tools anymore. Don't use the old regimens. And also the issue of X-ray. X-ray in the past was a big tool, and then it kind of faded away. But now it is becoming an important tool again. It has become portable. You have machine readings of X-ray. You have these new molecular tests. We have new treatments. So this is what we have to do. And also the issue of elimination of preventive therapy hesitancy. In the TB world, there's this hesitancy to take preventive therapy, but this also has to stop. Stigma is jointly in the TB and HIV community. And also, once we have the tools, we have to make sure that there's a rights-based approach to make sure that people have access to them. Let me end with a discussion about TB infection as an example. So I showed you this map earlier, and this is, you see where the HIV is concentrated in sub-Saharan Africa. So the global plan, if you read one of the chapters, we did modeling for 4 different areas of the world. We looked at Indonesia because of the whole private sector issue. We looked at the Ukraine and Uzbekistan because of the the risk of smoking, etc. And then we also looked at Africa for the HIV. So if we look, they did this modeling. They said, where should a country invest its money? So here's the baseline. You see that in that orange line on top. They said, should we put it in improving diagnosis? Should we put it in upstream symptomatic case finding? Should we put more emphasis in preventive therapy? Or should we put emphasis into mass vaccination? They even looked at this model where they put it with subclinical disease, which I mentioned earlier, which is a new thing in this proposal. But in Africa, in Kenya was used as an example. There's a very strong use of preventive therapy. There's a very strong effect because of the issue of HIV. Now, as pointed out, do we need to give preventive therapy forever? That's another philosophical question. But the other issue is that TB can be ended without actually going into the subclinical case detection. So this is a specificity for an area like Kenya. And also the vaccine coverage. Because preventive therapy because you have preventive therapy, vaccine can be a preventive or a treatment kind of vaccine. And because of the strong role of preventive therapy, vaccine coverage in a place like Africa, you only need 40% vaccine coverage. A place like Indonesia, you need something more like 60%. So to end, find, treat, save, and stop. So what we need to look at is universal health coverage, which is part of this new global plan. We used to have an all of government and all of society approach, and it has to be people-centered. Again, not patient, not person, but people-centered. And this means everyone that's affected by tuberculosis, HIV, and the other risk factors, and also to really increase the role of community. The key message I want to mention here is that we need to embrace all these linkages. We need to that means you need to think broadly, but also, as I give in the last example, you need to tailor it to specific needs of the community that you're in. So if we do all those things, we can follow up on our World TBD message from 2023 and 24. Yes, we can end tuberculosis. Thank you.
Thank you so much, Dr. Paula. Find, treat, save, and stop. So true. And people-centered ways and rights-based ways. Thank you so much for giving us such an in-depth overview of what the global plan has in store. We really hope that governments really work on this. It's a TB investment. It's a smart investment. It is a huge return on investment. So thanks a lot for underlining that as well. It's a very important presentation and really has set the stage. Thanks a lot. Dr. Tara Singh Bam, any final thoughts before we move on to the next session?
Thanks, Bobby. And I think it's really great, the presentation that we have heard from all the 5 speakers this morning. The key line here is we need to find all and treat all, and also, they do the high-level advocacy at the various level, at the global level, at the national level, and the sub-national levels. And one of the points that Dr. Imran, he pointed out from Indonesia, is the local, the actions are needed. So finally, what we need, by doing all the things, to make it happen, we need the local action on the community level, action at the city level, province level, and the national levels. So we need to, work together and find the new ways. And as Paula just mentioned, if we do what we are doing currently, we are not going to reach our goals and the targets. We need to do differently. We need to really translate all the global the plans and action into the local. So that's something. Bobby, I would like to highlight. Over to you.
Yeah. And let's not forget smoking, because we always forget to think about smoking. And I know that, Tara, that's very important to you.
Yeah, true. So, yes, all the risk factors, including smoking.
So true. So true. Thank you so much, Paula. Thank you, Tara. Thank you, everyone. And I would like to read out a comment from one of the participants. And the comment is that she thanks Dr. Paula, Dr. Tara, and everyone. And risk factors may be in the same human being. And so local actions and integrated are so, an integrated response is so important at the local level, which is so true. Whether it is HIV, diabetes, tobacco use, as Dr. Paula just pointed it out, or other malnutrition is the biggest risk factor for tuberculosis, but definitely that is also, and so many others. So thanks a lot for participants for pointing this out. And now we move on to the next session. Welcome on board. And the next session will be, you will be hearing a lot of reality checks from Asia Pacific countries on the ground, and a lot of community voices as well on where are we on 100 for TB and HIV. As the Shobha had earlier mentioned, that we need to find all people, 100% people with TB and HIV. We should offer them the best of treatments and stop the further spread of both. Dr. Paula had also mentioned this. We need to find, treat, stop, and of course, save lives. So in people-centered ways. So over to you, Kalpana Charya. Kalpana Charya is a very dear friend of ours, but also a very respected journalist and editor here in the region. And she's editor-in-chief of Health TV Online Nepal. Kalpana is also on the board of Global Antimicrobial Resistance Media Alliance, or GAMA, and also on the Asia Pacific Media Alliance for Health and Development, APCAT Media. She has been the former president of the Nepal Health Journalists Forum. Welcome, Kalpana, and we look forward to this session steered by you. Over to you.
Thank you, Bobby. Thank you so much for this great opportunity, and want to welcome you all as a co-host too. Yes, it's really a great event on HIV and tuberculosis. We all know that TB is a curable and preventable disease. We already discussed on that. And yet, more than 10 million people fall ill with it every year, and more than 1.3 million people die. I think several factors contributes to these ongoing issues, as Dr. Tara earlier said. We have the tools to find all TB and HIV, treat all of them with effective medicines, and prevent and further transmission of both of them, TB and HIV. So if we have solutions, I saw here latest WHO global report, which Bobby had already written here. 10.6 million people suffered from TB disease. Why? This is a big question. 1.3 million people were newly infected with HIV. Why? 1.3 million people died of TB. Why? And 630,000 people died of AIDS-related illness. Why? And lastly, 167,000 people died of TB among those who were co-infected with HIV. Why? Now, time to raise question. I think why, and why? Why we are not in track to combating TB and HIV? Where is the gap? Where is the huge gap? Even though we are doing our best, we said that. Now we need to think out of box, I think. And hope today we will discuss on it on whole day. Bobby, I would move forward for our session. Our first session, our session theme is 100% people with TB and HIV, offer them effective treatment and stop further spread of both. So we will discuss on this topic. For this, I would like to call Dr. Samantha Tinse, Municipal Health Officer, Bantayan Municipality, Cebu, Philippines. We will discuss on best practices and reality check on 100 for TB and HIV. Over to you, Dr. Samantha.
Kalpana, perhaps we can move forward as Dr. Samantha, we're waiting for her to come online. Thanks.
Okay, we have with us Dr. Anjali from Thailand. Over to you, Dr. Anjali.
Thank you very much. So can I share my slides?
Yes, please.
Okay.
Thank you, Dr. Anjali, for joining us. Dr. Anjali is the director of HIV NAT in Thailand, which has done such pioneering work on research related to TB and HIV. Welcome, Dr. Anjali.
Okay, thank you very much for your kind introduction and also the opportunity to share the data from Thailand. So I just focus on the situation for HIV and TB in Thailand. So just look at the situation and implementation to NS in our country. So we start from at the beginning from the condom of 100% until we scale up the ART treatment in 2008, 2006, and then we have the guideline to say that so we can start ART in any CD4 cell count in 2014, and we implement PrEP and PEP and for the high-risk population, and introduce the U=U strategy to try to reduce stigma. So we try to end AIDS by 2030, but in reality, just look at this data. So for the HIV treatment cascade, as you can see here, so we for the first 95, so we have just only 90% of PL-HIV diagnosed and know their status, and the second 95, so just only 90% the patient who have known their status and take ART treatment. And for the third one, so almost close to 100%. So so they have a viral loss. So almost 98% have viral loss less than 1,000 copy. So now almost 90% we have DTT transition in 2022. So when we look at the data of TB, we still be at the high TB endemic country, and with about 9% of HIV positive in this population, and just only 88% they were on ART. But we think that maybe because of so right now we screen TB for all HIV patients, but in fact it's not really 100% as we planned, and just only 88% on ART, maybe because of they have died before they start ART. So look at the TB program in Thailand, as you can see here. So TB death, so it is almost lower than the global target. So like a TB death reduction just only 12%, and TB incident rate just only 5% reduction, and catastrophic cost just only 30% reduction. So we need to do more to improve the outcome of TB. As you can see here, so the country have very slowly declining of TB cases in the country. So we implement early TB diagnosis, early TB treatment, but I think we don't do good thing for the TB prevention. So we have to scale up the TB prevention, not just for people living with HIV, but for also other high risk of TB population. And the outcome of treatment, so we are still lower than the target. Just recently, in 2022, is about the cure rate, the treatment success rate is just only 80%, and we still have almost 10% of mortality rate. This is not just HIV, but for the entire TB population. So, and if you look at the new diagnosis case, so we still have almost 52% present at the late December, or CD4 cell counts less than 50 copy, less than 200. So I think, so maybe because of the stigma still high, so they didn't want to come to check their HIV early. So with this, so we can expect that the TB cases will be higher as well, which is the high risk of TB infection. So as again, so the death rate is not, so almost 50% of our death rate is from AIDS-related deaths. And it's still over that, so almost totally it's almost 10,000 deaths per year. Is still over the target. And the majority of AIDS-related deaths is from tuberculosis, is almost 26%, as you can see here. And even though we have the guidelines since 2021, 2022 to include the TB molecular, including the urine lab testing, but the uptake of the urine lab and TB molecular is still lower than we expected. And also we try to improve the TPT implementation, starting from the people living with HIV first. So still slow, and just last year we overcoming challenges by engage all the experts, all stakeholders to have the high level of meeting together, and came up with the solution that, so we would go with like a treat TPT for all new HIV infected patients who received ART for less than 12 months. So actually we want to go to for everyone, but still have so many resistance on that. So why we just go with the first step with all new HIV should receive TPT if they don't have TB symptom. And also for those with CD4 greater than 200 and receive the ART longer than 12 months, so then they can have an option of IGRA and TST testing. And after that is we developed the clinical practice guideline tuberculosis preventive treatment in 2023, but focus more on people living with HIV. So, and we also have another important meeting again with all the society in Thailand to update the TPT and to support for the TPT program. And for the urine lab, so starting from 2021, and we have the pilot program using urine lab, and then in 2023, so it's already included in the national package. It means that all the Thai citizens can get this for free. So we focus on the PLHIV, CD4 less than 100, or all inpatient. They should receive urine lab to assist the early TB diagnosis, especially among those who cannot produce enough sputum. And so the country have national quality improvement program to reduce AIDS-related death this year. So another one is that we focus on TB, HIV, and TPT on this. And we map. So we are mapping the hotspot for a high mortality rate area in the country and try to focus this as a priority. And we developed the ECHO program or the community, the extension community health outcomes program, just for each region, so they can do by their own. So the topic of learning is about OI management, the rapid ART or same ART, the adherence, the TB HIV and TBT. Also a big topic for this program. And we try to scale up the early the screening for TB. So all new HIV patients, they need to have chest X-ray done before ART treatment, and also scale up molecular testing like a gene expert and also urine lab, and promote the rapid ART or same-day ART. So this, I think, so if we can do this, so we think that the combined with the TPT, so the TB cases in this population will be reduced significantly. So, but as I was saying that the uptake of the TPT in the country still very low. We need more room to improvement on this program. Just still less than 1% of our PL-HIV receive the TPT. This is in a real situation. And so, so the way forward is that, so we would like to scale up the ECHO program and to raise awareness of TB, HIV, and urine lab and the TPT, and also capacity building and the guideline, and promote urine lab to assist TB diagnosis and develop dashboard for a monitoring system. And also just this year, the division of TB, they have like a portable chest X-ray, and we try to bring in like the portable the CD4 cell count to just to improve the treatment for HIV and TB program. So I just like to end with this, agree that so we should improve the case finding, treat TB early, and prevent not just starting ART early, but also with the TPT and other such as the smoking, and also I think the improved nutrition for all the people in the country. And I'd like to thank you for your attention, and special thanks to Dr. Cyrus Noise from Division of AIDS and for all the data. Thank you very much.
Thank you, Anjali. Thank you so much for your insightful overview. Yes, prevention is always better than the treatment. It's true. Likewise, I would like to call Sok Chomerun, Executive Director, Khana Khmer HIV/AIDS NGO Alliance Cambodia. Over to you, Sok.
Thank you so much, Kapana and Bobby. Can I share my slide?
Yeah.
Okay. Can you see it now?
Yes, yes.
Okay, so first, thanks a lot to be part of this important event, talking about AIDS 2024, especially best practice and reality check on 100 for TB and HIV. So again, I just would like to say we are so pleased to be engaged in this response from HIV and TB. And this is my organization, my HIV and your Alliance. Currently, we implement the project through our strategic plan that we have for 2024 to 2030, and we have MOU signed with MOH, and we have staff that support implementation, and CANA is one of the accredited partner of the Frontline Aid and also an affiliate organization of AP, which hosted by APCASA based in Bangkok. So our work is focused on four strategic goals to achieve our vision and mission, looking from contributing to HIV, TB, and strengthening health system that address NCD, viral hepatitis, and achieving UAC. And second, our strategic goal for the next 7 years is looking at address climate change, One Health issue, pandemic preparedness, prevention, and response, which looking at how we can better having a strong and effective human resilience and developing sustainable community and organizational strengthening. Third, we're looking at strengthening organizational and technical capacity of civil society, including ourselves, and last but not least, promote diversity, right, and gender equity. So this is where we work. Currently, we work in 15 provinces, which have both HIV burden and TB burden across Cambodia of the 25. And before I move to our intervention, I just want to share with you, this is a snapshot of Cambodia concerning to the 395 achievement by the end of 2022. Right now, the first 95, we are at 86%, and the second 95, we are at 99%, and the third 95, we are at 98%. Our overall HIV prevalence among adult population age 15 to 49, based on AM 2023, we are now at 0.5%. However, we have very a big concern among key population, especially sex worker, MSM, transgender, people who use drug, and people injecting drug. As you can see, their percentage is still very high compared to general population. So our intervention that contribute to achieving the national target through implementing what we call branded package for HIV prevention among key population. For example, for STI is for our MSM program, where Sreisra is for our branded package intervention for transgender population, and as for Smart Girl is our branded prevention package intervention for female sex worker. And we work from 1 to 14 intervention, from finding people to providing information, commodity, as well as supporting them to understand their risk, and then supporting them to do the test, offer tests on site, and then putting them in treatment as early as possible. In addition to that, we also building enabling environment to make sure that those key population still can access to services without any stigmatization, discrimination, but importantly, gain a public support and a partnership. And this is just on some a snapshot of activity that we still providing ongoing with different model, from physical outreach to virtual outreach, to offer HIV self-test, to offer community prep, and to also increase chat line, increase a talk show, increase communication, so people can still access information and services where they are, who they are, and at any time that they need the services. You can see we contact them through mobile phone. We do a talk show so that people can connect, can provide information where they want to get services, how they get services, and who can support them, etc. We support them to access services on site, meeting with our lay counselor, our outreach worker, but also meeting our health service provider at ART clinic for confirmation and also for enrolling into treatment. We also offer oral HIV cell test and also offer PrEP on-site where they are. And before moving to TB, I just would like to share with you, this is the situation of TB in Cambodia and how CANA, as one of civil society, engaged in TB response. So Cambodia used to be one of the 30 TB high burden country, but fortunately we transitioned from this list for the period 2021 to 2025, although we are still under the watching list of WHO for this TB. However, 1/3 of our estimated TB cases is still missing, and the death rate is lower down to only 23 out of 100,000 population in 2022, and that reported in WHO Global TB report in 2023. Funding for TB response is still very much depending on donor, while the funding gap is estimated between 50 to 60%. So this is what we are doing to support the national response to ensure we can achieve the national target. We do from a TB screening through snowball approach, where we deploying, where we supporting people with TB, experienced TB to come on board. We train them to support their peer, and this is the way that they can increase yield compared to other modality. We bring the machine down to community where the community are through what we call active case finding, where the community can do radiology and also do a rapid molecular test through a gen expert. We also work and we try to find people at where they are, even those that they are in the congregated setting, and support them to access services. We celebrate World TB Day to increase public awareness about TB and confirm that TB is still the disease, is still a communicable disease and still killing people. So we need to localize TB to ensure that we can, have a TB free in the community. We also try to include the support to national program to make sure that data report should be online, digital, so that we can get a timely intervention. And we also support the national TB program to have the demonstration of how the sputum collection should be made to get quality and to support quality sputum tests. For MDR TB, we support the national program to provide home-based care across the country. Currently, we are working in across all provinces. We have 11 treatment sites, and we deploy our nurse and our community health worker to work alongside with treatment center as well as with our health service provider at the lower level. And here, this is just some picture of our active case finding, where we bring X-ray machine and expert machine down to community, and we also introduce our intervention to the embassy that support us, U.S. Embassy, and we have ambassador visit, and we also invite local government to see how this should be rolling out in other area as well, to ensure that community where they are still can access TB services. And this is just only some activity concerning to community mobilization and patient care, where we work alongside with peer support group, supported by the Stop TB, and we promote anti-stigma discrimination, and we increase the development of national network of people with TB, so they the one that can provide support, including treatment follow-up, treatment adherence, and as well as support their peer in terms of issue concerning to mental health, for example. We also train our community with the support of Stop TB through Challenge Facility for Civil Society to have CLM through the use of digital mobile phone, to report the case, and also how this case should be linked to health service provision and reaching a service provider in a timely manner. And this is a quarterly peer support group and network of people experiencing TB at community where they support each other. And we introduce a One Impact CLM tool for the community. So I think this is the last slide, just only showing you the collaboration that we have, not just with health service provider, but we're also working with the local government to ensure that TB is still in high priority list in their local development. And because, like I said, the resource for TB response still depending on donor. So how this could be integrated into the local development plan of the sub-national government. Just share with you, this is our HIV/AIDS program for the last 3 years that's supported by the Global Fund. We contribute about 53% of national HIV response, and we every year we test almost 50,000 people in those 9 provinces that we work, and we found about 1,000 plus people with positive HIV confirmation. And from year to year, the number of tests is always increased, and number of people who test positive also increase. For TB, we contribute about 9% out of the 32,000 people report a TB during the year. And every year we screen about 160,000 people, and about 2,841, or about 66% of these people who notify all TB form are bacteriologically confirmed, tested. Yeah. And in addition to that, we support finding people who are the close contact of people with TB to come on board. And every year, about 3,000 people who are the close contact enroll into treatment for TPT. And this is just an example of how we work. You can see from this picture, every year, for example, in 2023, the total case that notified through our program is about 2,841. Among those, 55% are male and 45% are female. But if you look at the pulmonary TB, 60% of this male population are with pulmonary TB, but only 40% are female. So this means that we need to ensure how can we increase screening among men rather than among women, because they're the one who still continue to be the hidden population, or the one that still cannot come on board, while the women still have very high number come for screening, but the yield is still compared to men is still lower. So in conclusion, anti-AIDS and TB is not a dream, but we need investment. But investment have to make sure that this go down to community to make community lead on and sustain, including the implementation of CLM. We require a paradigm shift by moving AIDS and TB from medical line approach to person-centered to people-centered, what Dr. Pola just mentioned. And we need to ensure that ending AIDS and TB they have to move beyond health, because both HIV and TB are also associated to many social determinants that require multi-sectoral partnership, collaboration, and response. And last but not least, we require integrated resource and services for its long-run sustainability and achieving universal health coverage if we really want to end TB and HIV. We must mobilize and continue working together to build an equitable global health system that center human rights and human life for both HIV and TB response. Thank you very much.
Thank you so much, Ashok, for your wonderful presentation, and you highlighted. Yes, you highlighted the Cambodia's interventions on TB and HIV. It's really wonderful. Thank you so much once again. And moving forward, I would like to call K. Lakshmi Priya, Director of Cheyutha, India. You are most welcome, and over to you, K. Lakshmi Priya.
Hello, good morning, everybody. Thank you for the opportunity given to me. So I could like to like to talk about the women and the who are HIV positive and also who are also having the HIV TB. So myself, Lakshmi Priya, I'm a project working as a project director in Hyderabad, Telangana state, and whereas we see that TB itself is most stigma discriminated still today, and where the women who are unable to access for the proper treatment, proper diagnosis, and which leads a lot of complications in the families. So when it comes to an HIV positive, there are the more prone for getting this HIV infection. TB infection, and during the treatment process only, most of them are defaulted from TB treatment, madam. As being a community member, and I'm been observing the problems, the issues faced by the women and the children, like the TB treatment is the most challenging for them, as they have to take their antiretroviral treatment. They also have to take TB treatment. Since when they are taking the TB treatment, they are been losing their livelihood, madam, where they have not given support for medicines treatment. They need lot of nutrition support also. So during these 6 months also, the women will be facing hardship, and the children also will be facing hardship, and they don't have proper food, and the medicine will become more toxic to them, and mostly they will decide that they will not take for this treatment. But in our organization, what we do, we motivate them, we tell them that they have to complete their TB treatment, because that TB treatment will help them to get cured and take antiretroviral treatment so that they can keep healthy. So in the cases of the women and children, we will provide them ongoing counseling, nutrition support, some financial aid for the children and the women, so that it will be helpful for the women to get back to their livelihood, and take care of themselves and their children also, madam. Hello?
Yes, Lakshmi. Yeah.
Yeah, ma'am, this is the thing we are facing as a woman community based, the women and children in our organization, madam.
Yes, thank you, K. Priya, for your insights. Yes, nutrition support is very important while treating the tuberculosis patient. Yes, very important. Thank you so much for your insightful views. Yes. Moving forward, I would like to call NEPHAK Ray, Specialist Counselor and Support Officer, MPLUS Foundation, Thailand. Over to you. Is there NEPHAK Ray?
Oh, hello. Can you see me? I'm here.
Yes.
All right.
Yes,
I
over
have
to
to
you,
share
sir.
the screen. Yeah.
Thank you, Ray, for joining us, and for all of us who know Ray and MPLUS Foundation. They have really led from the front in demonstrating that communities can make a huge difference in delivering services for people with HIV and other key populations. So thanks a lot, Ray, and also to the whole MPLUS Foundation team. Thank you. Over to you.
Thank you so much, Bobby. Okay, my name is Ray Nataka Lahacharan Sumat from MPLUS Chiang Mai, Thailand. So I'm going to talk really quick about what we do as a CSOs in Thailand. Start with the background of MPLUS. Back to 2003, we established of MPLUS. During that time, for 8 years, MPLUS advocate knowledge about men who have sex with men, and also we receive funding from the local government, Agency Office of Disease Prevention and Control Region 1. And we also funding from international organizations such as USAID, GA, Global Fund, American Jewish World Service. And then MPLUS keep improvement our service since 2003. Then next 8 years later, we registered as the MPLUS Foundation in 2011, and which enhanced our opportunity to access diverse funding. And then next 5 years, we start to use model as a key population-led health service. We call KPLHS. Between 2011 2016, MPLUS concentrate on outreach activities and refer clients to hospital for HIV testing. And also the referral process reveal a gap, and it's a 7 days wait back to like years ago. So 2016, right after that, MPLUS implement key population-led health service model, and the model offers HIV testing. So we're able to provide PrEP, ART, medication referral, and adherence support, all provided by certificate, or we call certified lay providers. And then next year, in 2017, MPLUS registered as a NHSO, National Health Security Office Board, a Thai government health service player to receive reimbursement for services such as HIV prevention, testing, or even treatment, social controlling approach. Until now, the social contracting HIV testing fee in 2019, we have able to do social contracting HIV based on the model until up to 2023. Last year, we able to register as a MPLUS polyclinic, which means we able to do one-stop service for HIV tests, STI treatment, because we have a doctor who specific and have knowledge for on HIV, and also we do have STI doctors, and also every Friday we also do have a psychologist from the psychiatry hospital be on Friday to not just support the physical health and also support their mental health as well. So if you look at the map, the MPLUS Chiang Mai is like on the top, and the service integration of MPLUS Foundation overview of the model. So our vision, all LGBTQ community, even like young key population, are able to access for the healthcare service basic needs such as HIV, STI, reproductive health, and social service that they need, and also have to be equal with their right as well. So MPLUS also have a mission to focuses on providing the sexual health on human rights to the LGBTQ people, and also provide people-centered health service in sexual health, social protection, and human rights support in an effort of develop equality and equity into society. If you look at the geography, the population serve approach, we also cause a client center or people center of service, and also you don't classify it as if you are come from other countries or you come as a refugee or undocumented, you're welcome to get the service in MPLUS as well. MPLUS right now we have five offices based in the main city of north of Thailand, in Chiang Mai, Chiang Rai, Pisanurok, Nakhon Ratchasima, and also coming soon in Bangkok. And the orange area is mobile clinic area. That's MPLUS also reach out to people who has some sort of like obstacle to travel to the clinic. So we try to close the gap and able to like reach them out and get HIV and basic consult needs about STI and also general thing about their sexual health. Same as well, our target population, it's men who have sex with men, transgender people, young key population, PL-HIV, people living with HIV, entertainment workers for all gender. We also focus on people who are injecting drug or using drug by using the harm reduction program and also leading to the abstinence. We also provide them about pre-screening for health check and also mental health support as well. So the integrate and people-centered service delivery, we do reach, recruit, counseling, test, treat, retrain, and prevention. So for our prevention, part of that is also retain clients to come back and get tests every 3 months. And also, we do have an outreach staff to reach them out. Either can be verbally or verbally as well, to the social media or meet in person. And also for the recruit partner network testing, we also providing providing the services, and also if the client is positive, be able to prescribe send the ART right away in the same day. But it's also still depend on the clients that they are ready or not. If they're not ready, you're not gonna push them to take it because we still maintain on people-centered service. But we still provide educational and literacy about if you're able to take the medication as soon as possible, it will be better for you. We also provide same-day PrEP, PEP, and also we do pre-screening for hepatitis B, C as well. For substance use and chemsex assessments, we also provide using an anti-conversation therapy and also using harm reduction to abstinence. For the counseling, right after when client walk into the clinic, I forgot to tell you that you have to like pre-screening for tuberculosis and also COVID-19, which is like still going on again in Chiang Mai area. And also we do pre-screening for monkeypox as well. So when the client asks for the reception for the service that they need and they meet, we do have 6 counseling rooms. We also provide mental health screening, gender affirming care, screening for stigma and discrimination rights and violations. And when we talk about like physical health, we also provide an HIV, including HIV viral, CD4, and also be able to test for creatinine, EGFR, ALT test. And also, if the client is test positive right now, we have to send the client to the hospital nearby us, which is like 5 minutes away. But still, we can do send the ART with our clients, and sometimes clients not ready to travel out from the clinic and they want to be here for a while to get more support. So we're not going to get like X-ray screening before they take medication. For treatment, our clients who never test positive, either can be HIV, sexual transmission. We do treatment right away because, as I said before, we do have a doctor who are able to treatment from what they need. And also it's really close the gap between the clinic and also for the client's timing, as we're able to do one-stop service and treatment on the same day. if the client cannot come back for the return, or they probably like the schedule is not matched, we also do telehealth service for them. And also we send a self-test to them. We consult them through the telehealth video, and then they send the result. After they submit the result back, then we will prescribe for PrEP medication as a retained client. For care department, we just not, send them and make sure that they take medication. We follow up them every 3 days. How do they feel, and also for the side effect. And also we do every 7 days. Until after that, we make it a bigger time, 3 months, and then 6 months, the client is able to come back as a return to test for or STI screening, and also can test for HIV viral loads as well. And we still follow up with people who living with HIV until they stabilize, but at least 1 year we have to follow up. What is to prevent the community, and also therefore the LGBT community and the key population? This is also part of prevention, because we're able to prevent the time for them, be able to prevent it of talking beside sexual health. And also be able to provide condoms and lubricants, a safety net, and also harm reduction services as well. So this part is going to be quick. Our performance last year in 2023, we able to reach about 25,300 people, and 23,200 people came to the clinic and able to receive the testing services. 326 test positive, confirmed, and also about 1,100 HIV negative. We provide PrEP medication. We also give them more literacy about sexual education. And also, we give them out the booklet and keep in touch with the line official. So if they have any question, or if they change their mind, they can contact to us in every single way. Either it can be in social medias, or on website, or to application. For HIV positive, receive antiviral. We test positive for 336. But why the number is 296? Because some people, they're not ready to get treatment yet. They need some more time. And also, some other clients, they prefer to get treated by themselves. And some of them too, they just want to keep themselves privately as a confidential. So they probably like go to the private hospital, or they like find a way to get. But we're not just like, if they want to go with their own thing, we still ask them to like, if it's okay, if it can follow up, and also we give them the QR code and contact numbers. If they change their mind, they can contact us anytime. So this is the way, like, if you use technology and also providing ways of to like reach out to the staff of clinic, it also can support them with their sexual questions. And also, if they want to like some sort of like specific emergency health, we also able to provide with them as well. For the key principle to tell the people center, We based on a facilitate community-based, community-led self-care, which is from the demedicalized, different step, different offer by lay provider or to healthcare worker has shifted. And also we do differentiated, example like adapting that when, where, who, what, based on client-centered approach. And also for nice to have, forward through must have for it. Finding less complex ways to deliver care to promote increased access and lower cost while retaining efficiency and quality. So now I'm going to go to the tuberculosis situation in and operation in Thailand from the collective TB operation result. So the service unit throughout the country in 2023, the total location was 1,200. There were both new and current tuberculosis patients. For both Thai people and non-Thai people, there were almost like 79,000 cases registered for treatment. And the number of tuberculosis patient age 65 and over was almost 22,000. This is like almost like 30%. About twice as many TB patients were males, which is almost like 54,000, and female 25,000. This group of tuberculosis patients, and what follows said were 5,467 cases of HIV infected. Some people who are living with HIV, the percentage is almost 18%, still high. So we are really concerned about that again, because like back 2 years ago, we focused on HIV and TB, and then like time change and year change, it's turned to like HIV, STI, HIV, and hepatitis. But don't forget, if you want to ending AIDS in 2030, we need to, not to just like forget about the TB as well. As for the success rate of the TB treatment for the new and recurring TB patient who are receiving treatment in 2022, the treatment was successful, which is 80%. And then recent of the treatment was not successful, almost 10% was death, and also 5.6% from missing medication. And for drug-resistant TB patient in last year, there were 886 cases registered for MDR and also RRTB treatment, 56 cases of pre-XDR TB, and also 6 cases for Dr. TB. So what implies also, we're talking about HIV and tuberculosis again. So we actually prepared months ago with the current, because of the current situation in Chiang Mai province has highest number of people who infected HIV in Thailand. According to the data last year, we approximately able to find new case finding 750 cases. And people who live in remote area have difficulty to come to get a treatment, and also in some hospital in the remote area for the HIV clinic, they don't open every day. They just sometimes like once a week or twice a month. In additional mechanism need to expand access to HIV testing and treatment service, sexually transmitted disease and tuberculosis. Why the reason is necessary for MPLUS? Delay access to HIV testing and treatment services. Of course, we all know it's effective control for AIDS and tuberculosis. People in remote areas should receive equal access to HIV testing and treatment. And this project will help expand access to HIV testing, services, STI and TB and treatment. So this project will help diagnose HIV faster, affect treatment and quality of life to infect other people. And it's also reduce stigmatized and also a gap of discrimination as well. But the faster they get treatment, the better viral will be suppressed. And also the target to expand access to HIV testing and STIs, TB treatment in Chiang Mai, everywhere. It's increased the number. So we want to figure out how we can able to, instead of like they have to go to do chest X-ray in the hospital, and also be able to do online counseling to the doctor as well too. And we do have a counselor over there. So what the activity provide one mobile car. We are going to provide one portable X-ray device with one digital X-ray image receiver, training public health officials on the use of mobile vehicle and portable X-ray equipment, provide free HIV testing as we do to the public, main target group, and the program group in Chiang Mai province and remote area. And also, if people who doesn't have any document or they came here as a refugee or migrant, and they want to get to do some sort of like sexual health, we also provide them as well. And people who are aged under 25 years old, we still considering as a young key population. So we won't charge them. This is also make MPLUS really stand out because it's also release anxiety for the people who live in lower income, and also most of young key population, they still think testing, treatment, that they have still to pay. For service to provide treatment for people who live with HIV as soon as before after diagnosis, and raise awareness about HIV/AIDS, sexually transmitted disease, and tuberculosis. So this is all the end about MPLUS presentation in Chiang Mai. I think right now we're able to close the last gap to able to provide them the ARTs and the treatment. Especially, we want to end AIDS by 2030. Or gender, or race, or human beings either can be from other country, or even though undocumented, they deserve to get treatment as we set a goal to end AIDS by 2030. And also, if you have equipment that can be, accessible and movable and travelable, small and quick, that's even better to end AIDS by 2030. And also it will give a positive vibe to reduce for stigmatized and discrimination when people they don't know status and don't have money to get into HIV treatment. So that when they know status, they can get treatment and less transmit to other people. This is the end of present from MPLUS Thailand. Thank you so much.
Thank you. Thank you so much, NEPHAK. It's detailed information you presented here. Thank you so much. Yes, as you said, people-centered service is very crucial in treatment and diagnosis of TB and HIV. Yes. Thank you so much once again. And moving forward, I would like to call Max Yashwinder from Pahal. Over to you.
Thank you, Kalpana. Thank you, Bobby. And thank you, everyone, for having me here. I'm going to share my screen and discuss the details. Can you all see my screen?
Yes, yes.
Perfect.
Please go ahead.
Yeah. So I'm from India and I'm from organization Pahal Foundation, which is working in Delhi in one of the largest states, Uttar Pradesh, and one of the very high burden states of Punjab and Haryana. So today I'm going to talk about HIV, TB, and intersection of key population and the service delivery, with regard to HIV and tuberculosis. We'll try to cover following things, which say that what are the unique risk factors, what are the existing interventions, what are the innovative approaches which can improve screening, treatment, and prevention services for our vulnerable groups. So this is more or less is going to be more community perspective, because I think the previous speakers have covered a lot about TB, the medical part, and everything. So now if we talk about the populations, which I'm going to talk about, my own group, which is MSM and transgenders. So they are at a higher risk of both TB and HIV. In India, if you say per se, the HIV prevalence is only 2.22%, which is relatively much lesser as compared to many African countries. But there is a catch. Now, catch is if you see Sankalak report, which is the annual report of NACO, which is our National AIDS Control Organization. So its 5th edition, which has come on December 2023, it is highlighting that states like Punjab, which is a border state, actually having 11.62% prevalence of HIV among MSM. Condom usage, as per the same report, is only 55%. So it's a clear case, where you see that the HIV prevalence is much higher. The condom usage is nearly half of that. And with this, we really cannot achieve the 2030 elimination goals. You can see the table at the bottom, which is highlighting that, a lot of intersectionality also exists within the populations. For example, among MSM in Punjab, 14.6% also reported of using needle or syringe, which means they are also into injectable practices. So these are the issues which are which we need to actually think through when we design the interventions. Now, what are the limitations with regard to engagement with TB? So per se, the design of TB program is such that it's very medicalized. How to kind of screen the TB, this treatment, this regimen, etc., etc. But in the national program, you don't see anywhere where they talk about, focus on the communities. When I say communities here, not only MSM, transgender, or high-risk communities or PLHIV, but other TB communities as well. For example, migrant workers, migrant women. So these communities are not in the focus of focus in the sense, I mean, they are in the focus only from medical point of view, but not in community engagement. I think that is a major flaw, which become a hurdle where, people don't see the kind of, reception by the program as it's seen in case of HIV, where communities have delivered a wonderful job. Second, I think issue is public health service delivery model, because for my populations, it's always less accessible for the key population due to stigma, socio-legal challenges. But entire TB treatment and everything, you have to be into the public health only to access the treatment. Now, intersectionality is another challenge, because we only see individuals, okay, you are now TB infected, you are my population, you are HIV infected, transgender, okay, you set into that box. I think we need to come out of those boxes. We need to see human being, and we need to consider that, yes, people do have intersectionality. There are people who maybe, identifying themselves as transgenders, who are into sex work, who are also into stimulant use, who are living in a very kind of unhygienic conditions. So we have to consider all these factors. Only then we can kind of, go into a very comprehensive treatment or comprehensive solution to the problem. Next point is very important. I think it's not to my community, it's for all of us. Climate change is a major challenge which we are facing, and India per se, climate change, the air pollution, if you see the reports, ladies and gentlemen, you will find that most of the year, our AQIs are much above the dangerous level, which led to your compromised lungs. Eventually, when your lungs are compromised, you are into high-risk groups. any opportunistic infection, be it TB or will actually attack you. So we are actually heading towards a disaster. It's kind of a crashing thing which is happening because all these factors are adding on and on to the thing, which will eventually compromise our lungs, will reduce our immunity, and we'll be more prone to TB, and not TB, all other infections, respiratory diseases which are there. Last, I think the movement building, which remains a challenge with the TB community, because in HIV we have seen a very strong movement, but that somewhere I think is lacking. Even in the existing structures of GFATM, for example, CLM, for TB, there is no such arrangement. Even in the CCM, the representation of the communities who are affected by the community directly, I have seen across, South Asia region, is very limited. Moving next, what are the opportunities for us? Now, India, for example, we have existing NACO, which is the National AIDS Control Organization, which provide the targeted intervention. These are focused on key populations, MSM, transgenders, people who use drugs, female sex workers. So under this, a very community-specific outreach is made, and there are peer educators who provide support and who provide the service delivery. Now, we go to specific areas where, high-risk population is there, where, for example, cruising areas, or there are DIC and community centers are there. Now, what they do provide kind of, STI screening and treatment services within the facility. They do provide HIV screening, which is community-based within the site of TI, and they do HIV counseling and testing services. But here, if you see, the services related to tuberculosis so far is not actively integrated. Now, this is a very, great opportunity for us, where we see that you have already a concentrated population, at least a section of population, which needs, of course, larger attention and care. You can provide the direct service delivery, and you can leverage the existing platform of the targeted intervention to do the service delivery. Within service delivery, I also strongly believe, it's not me, I mean our communities believe, that we need to have leverage the technology. For example, we need to provide option to the people that not only you have to go to a public health facility, there are like one-stop centers, there are like, telemedicine platforms which are there. So I think we are moving towards a very technology savvy era, and we need to, I think, explore all these opportunities which can reduce the burden on the communities to go to a public health facility just to initiate the treatment, just for screening, etc., etc. Internet-based outreach, I think, which we say virtual outreach, India is having a very good penetration of internet. I think we need to go and explore this as well, where we can kind of, provide outreach services which talk about, it is actually the new era, I would say, where we're reaching to the unreached population, because in classical TI at a physical site, you have only limited number of people whom you can reach and provide services. But if you go on internet, you can actually, reach to a wider range of population who were never part of the existing intervention. So providing them innovative communication, the IEC material, highlighting the need for TB, need for even hepatitis, need for, HPV. And then this is the demand generation part, which I think we need to kind of, talk about. Now, innovative tools and technologies are also present, because you see that we are talking about the long-acting ARVs, we are talking about PrEP, and also the long-acting PrEP, CABLA is there. A combination of medicines can be provided, maybe self-testing kits can be provided. Why, ladies and gentlemen, we are able to kind of, fight so strongly with COVID? Because we worked on demand generation very strongly along with the supply side. I think these two things we need to work on this part as well. So when I say, demand side, so we need to kind of, provide kind of, sensitization to the community, so that there is a demand. Now, to fulfill this demand, we need to kind of provide facilities at the doorstep, which may include the innovations, going to providing more and more self-testing, which will actually help to increase the uptake of HIV services, and of course in case of TB services. it will eventually result that people lead to early diagnosis of HIV and TB, which will lead to proper initiation of treatment, and the better health outcomes is overall we can achieve with this. Long-acting ARVs, for example, because we know that within this classical population, there is one population which is already having a comorbidity. For example, is HIV positive and might, more suspected to TB. And there is a population who is HIV negative. We may need to kind of, go for long-acting ARV so that, we can reach to the sustained response, against the viral load with long-acting ARVs. And of course, the PrEP, I think I have already discussed that, that is the need of an hour. And of course, having more technology where we can have the combination strategies to address, HIV, TB, kind of together. And I think long-acting PrEP is a magical thing, which if we give, at least we can help to kind of prevent new infections of HIV and eventually the TB. I think conclusion, I would say only few things that maybe we need to engage with it's more for TB program. We need to engage with the communities. We need to engage with community networks, community CPOs. We need to sensitize them, and we need to adopt a very innovative service delivery, so that we can reach a very sustainable engagement and a sustainable response, which will lead to fulfilling our elimination goals of 2030. So with this, I'm taking a pause. If there are any questions, I'm more than happy to answer. Thank you.
Thank you. Thank you so much, Yashwinder. You have presented particularly a particular community engagement. It's wow, it's wonderful interventions you have done. Thank you so much once again. And I would like to call Firman Rekat Peduli, Indonesia, for her remarks. His remarks.
Hi, can you hear my voice? Hello, can you hear my voice?
Yes, yes, you are audible.
Okay, thank you. Okay, hi everyone. I'm Firman from Rekat Peduli, Indonesia. And I'm from Indonesia, especially our working areas in East Java province in Indonesia. Let me share my screen. Can you all see my screen sharing?
Yes, we can see. Please go.
Okay. So, Rekat Peduli Indonesia started on June 23, 2014 with a group of drug-resistant TB survivors in Surabaya city. Their aim was to support and empower those affected by drug-resistant TB through mutual aid and advocacy for better healthcare services. We are survivor organization under the POP-TB Indonesia. It is a network survivor organization in Indonesia. And our community evolved into Yayasan Rekat Peduli Indonesia, officially established under the Ministry of Law and Human Rights. Today, Rekat comprises 27 members, including survivors and individuals impacted by DRTB, who actively participate in its activities and initiatives. Rekat focuses on raising awareness about DRTB, supporting patients, and improving access to quality healthcare. Our foundation also emphasizes community empowerment through education, training, and capacity building programs for DRTB patients and their families. The goal is to enhance treatment outcomes, reduce TB-related stigma, and create a supportive community where DRTB patients can access the resources and support they need to manage their condition effectively. Today, I look forward to sharing with you our innovative strategies and impactful outcomes in pursuit of this vital public health goal. So in 2023, there are approximately 10.6 million TB cases worldwide with 824,000 underscore the need for more effective collaborative TB management strategies. Joint efforts across sectors are essentials for improving case detection, treatment, and prevention in Indonesia. Currently, the support for the implementation of TPT in Indonesia in particular is very qualified. If previously we had some issues about the logistics, this year the government's commitment to drug procurement has been more than sufficient. Although in some areas there are still some issues, but have been handled regularly. For example, in East Java, our working areas has achieved a significant number in TPT administrations with a total of 18,000 people from 2023 to 2024. And Rekat also provides assistance to DRTB patients under the Surabaya City Health Office, and we only received funding in 2021, and through the CFCS 10 Stop TB partnership, until now we regularly receive the CFCS 11 and CFCS 12. In addition to active case finding, we also provide nutritional support and psychosocial support. Many people with TB are unemployed and malnourished, resulting in a high rate of loss to follow-up. Rekat also provides social support, as taking TPT medication can cause side effects like dizziness and nausea, which often discourage people from continuing TPT for the required duration. We also collaborate with local healthcare providers to ensure accurate information and resources are available. Through these initiatives, we aim to empower individuals to protect themselves and their loved one from TB, fostering a supportive environment for TB prevention and treatment, ultimately contributing to the reduction of TB cases in Indonesia. Here are some of the activities we have carried out in Indonesia, especially in our working area in East Java province. Since 2016, peer educators, they are from the drug-resistant TB survivors, have been supporting drug-resistant TB patients at 34 community health centers and 2 hospitals in Surabaya. This program aims to provide emotional and practical support, helping patients understand and follow treatment protocols and reducing the stigma often associated with this disease. The supports includes clear information about the importance of treatment adherence, strategies for managing medication side effects, and moral encouragement to motivate patients to complete their therapy. So far, we have supported a total of 350 patients, with 172 of them are still undergoing for treatment. And Rekat also collaborates with multiple organizations such as Atsuka, Seribu Senyum, Lentera Yoga, Simsa Uner, Human Initiative, and Ultimo International School to provide essential nutritional support to DRTB patients. This collaborative efforts aims to alleviate the nutritional challenges faced by these patients during their treatment. The support includes distributing nutritional packages comprising milk, grocery essentials, and ready-to-eat meals. Through these initiatives, Rekat has successfully distributed a total of 2,900 nutritional packages to DRTB patients. And then next, we have advocacy for the home renovation program. We advocating for the patient housing renovation program is crucial effort at Rekat. Working with the health department, we advocate to the social service department for renovating homes of patients living in unsuitable conditions. This advocacy aims to improve living conditions and create a better environment for recovery among vulnerable individuals. So far, our efforts have successfully renovated 3 homes of patients in urgent need. This renovation is not only address immediate health and safety concerns, but also improve the overall well-being of the patients and their families. So next we have skill training for making salted eggs. Rekat has organized skill training for making salted eggs in 3 cities, in Surabaya, Sidoarjo, and Gresik City. This training is specifically aimed at DR TB patients and survivors, with the goal of empowering them to start their own business and establish small and medium-sized enterprises after completing their treatment. The training provides not only technical skills in making salted eggs, but also covers aspects of marketing and small business management, enabling participants to run their business more effectively and sustainably. In Surabaya, participants successfully sold 1,300 salted eggs, and in Gresik City, they can sold about 5,250 salted eggs, and in Sidoarjo City, they have sold about 150 salted eggs. And then we have batik making skills training. So this batik making skill training is held in 2 districts, Sidoarjo and Gresik, and is specifically targeted at patients and survivors of TB, of DRTB. During the training, participants learn both basic and advanced techniques in batik making, as well as receive knowledge on business aspects such as marketing, business management, and financial management. Additionally, training serves as a form of rehabilitative therapy, offering participants a create outlet and helping them regain self-confidence that may have been lost during their long battle with DRTB. And we also involved in the multi-sector forum for the acceleration of TB elimination in Surabaya City. So since early January 2022, Rekat has actively participated in Surabaya's multi-sector forum for accelerating TB elimination, partnering with Yayasan KNCV Indonesia or through the TB Mandiri program. Rekat has secured significant support, including a $700 contribution from MedQuest company for oxygen and wheelchairs, crucial for enhancing patients' quality of life during recovery. And then Otimo, an international cooking school, provides bi-monthly food packages to drug-resistant TB patients, distributing about 1,000 packages of food to date. And Rekat is also involved in Koswara, advocating for a special regional regulation on TB to bolster management efforts based on Presidential Decree number 67. These initiatives aim to create a healthier, TB-free environment in Surabaya through integrated resources and strong partnerships, improving community well-being and alleviating disease burdens. And next, we also have the CLM mobile app support for TB. So the CLM mobile app Lapor TBC powered by One Impact is our program with CFCS 11 and 12. We are supported by Stop TB Partnership. So This application enables TB patients and communities to report issues relating to TB care and treatment, ensuring their voices are heard and acted upon. By providing a platform for real-time feedback, Lapor TBC enhance transparency and accountability in TB services. Users can report challenges such as medication shortage, stigma, and service quality issues directly through the app. The data collected helps healthcare providers and policymakers address these issues promptly, improving TB care delivery. Additionally, the app offers educational resources and support, empowering patients with the knowledge needed to manage their condition effectively. Through these features, Lapor TBC foster a more responsive and patient-centered approach to TB control. This is the last presentation for me. I'd like to mention that the Yayasan Rekat Peduli Indonesia has accomplished a lot more than what I've covered here today. Due to time limitation, I've highlighted the key points. I hope to have another chance in the future to share more about our achievement. Thank you for your attention and see you.
Yes, thank you, Firman, for your time and wonderful presentation. Yes, now time to listen TB people perspectives. For that, I would like to call Mona Balani, India HIV/AIDS Alliance, NCPI Plus, TB People India. Over to you, Mona.
Hi, good morning. Hello, can you hear my voice?
Yes, yes, you are audible.
Hello. Okay. So, good morning, all. And first of all, thank you for CNS to providing this global platform and our National TB Division, Central TB Division, and NACO and Government of India, where all officials are representing the country perspective at this global platform. So thank you very much, and thank you for all my TB and HIV community for providing that experience in the field to present here today. So as we all know, like today we are talking about the 100 approaches through the community voices. So I am sharing some slides. Bobby, can you give me the access to share my slides here?
Yes, Mona, do you have it? Thanks.
My slides are visible.
Yes, Mona, yes.
Okay, so once again, I'm re-echoing the message that day we give up, the day we will die. So I think that message for all of us. And we are listening since early morning. Too many government partners, too many government agencies, civil society representation, and community partners and researchers, doctors. They are presenting their all objective to eliminate the TB and HIV. So I'm not going to present that context again and again. So as we all know, like we need to eliminate TB, and what we do as a TB People India. So we are the coalition of people who are having the experience and had the experience of TB and affected communities among the TB people and their families. So we are having the access to mobilize the communities from the grassroots level. So we empower the communities through the community mobilization in the field. We are doing the facilitation to strengthen their capacities to build the networks and building the partnership. We are also doing the treatment advocacy at the national and regional level and the global platforms to enhance the advanced treatment technologies, tools, and diagnosis facility and access of the treatment. We are also supporting the community voices for the TB, elimination and HIV elimination as well to end AIDS, which has the global target to end AIDS by 2030, and to eliminate TB as soon as we can. Because I'm not saying that fixed year which are announced by the central government, but still we are far away to eliminate the TB by 2025. So we are also supporting the community voices to represent all the level from the grassroots to the national level in the meaningful involvement and engagement of the communities who are living with HIV, affected by HIV, and who are having and had TB as well. We are also facilitating the technical guidance and support to build up the local community support system through the state level network, district level networks among PLHIV communities, and to provide the platform to the TB communities at the district forums, state forums, as well as national working groups and national forums. We are promoting the coordination with the Government of India, with the government programs and public-private partners, and we are enhancing the networking among the community networks as well. And we are also working with the joint hands at all levels with the Government of India and implementing program agencies as well. So what are the facilities we are having? We can just have a look at a glance, like what are the key facilities we are having. In spite of that, what we need at the national and global level as a community voices. So we are having the free treatment, we are having the community-based screening and TB screening for all members who are affected and who are on the risk for HIV and TB. And we also have the free diagnosis and treatment for the both disease in the country. We are having the public and private facilities for the both disease to diagnose and treat, and have the better counseling, treatment preparedness, and social protection linkages, social security linkages services. We are having these facilities for the both diseases as well. We are also having the incentive-based approaches under the TB program linked with the TB treatment and supporting care and services follow-up post-treatment as well as ongoing treatment people living with HIV as well as for the TB. We are having the partnership with the sectorial departments, ministries in both disease because HIV, since long they are integrated and they are working with the different ministries and departments. Similarly, we are also having that approach in TB as well. We are having the anti-TB drugs, ART drugs for free availability and committed by the governments, like under the Health for All objective and national target we have decided, and our government has already committed under the SDG goal. We are having the IC strategies under the TB program with the good involvement of the celebrities and ideals and corporates. We are using the information and technology platform to strengthen our planning and implementation in both programs. And we are also having the integration strategies with the National Health Response for HIV as well as for TB. But other health department also we are facilitating the integration. So this is again undergoing for the TB and HIV, both diseases. So what we need to reach out the 100 targets. So 100% people needs to know about their status of TB as well as for HIV. 100% people need to put on the treatment facilities while they came to know they are having the active TB, they are having the HIV infection in their bodies. Along with HIV, we need to approach for STI also because we need to eliminate STI, RTI also with the HIV targets as a global and national level. And 100% people who are on the treatment, they need to be cured after the treatment adherence for the TB. And for HIV and STI, they have to adhere and they have to retain for lifelong treatment for HIV. So what we need for that, we need self-testing facilities for HIV, STI, and hepatitis under the HIV era. We need the demand generation for the post-exposure prophylaxis and the pre-exposure prophylaxis. We need elimination for cervical cancer. Cervical cancer among the women living with HIV and high-risk group people. We need sexual reproductive health services for all high-risk group people and PLHIV as well, and for their families. We need demand generation among the PLHIV for advanced disease. And sorry, we need the demand generation for the family planning among the PLHIVs. And we need access for the long-acting methods among the PLHIV and their family members. We need to create awareness more and more for the HIV/AIDS Act. Awareness as well as implementation at all levels through the systematic grievance redressal mechanism among the communities as well as among the different departments of the societies. So we also need the triple elimination strategies need to enhance at all level for the community, by the community, and led by the community. And we also need to focus on the advanced diseases. Those diseases among the PLHIV need to timely identify through the advanced diagnosis, through the linkages with the accessible treatment facilities among the PLHIV and their families. And what we need for TB to reach out the 100. So as we know, like there are the facility of the screening, but still we need a wide scale up for the screening with the new tools and the new projects, because we have seen like at national level we are doing several projects for several intervention as pilot with support of Stop TB partners, UNAIDS, USEA, WHO. So many projects are there, but still they are having the pilot-based approach. So we need their wider scale up to see a significant change towards the elimination of TB screening and testing for the active TB cases. We need effectively engage the communities at each level, because what we have seen, like at national level, the people and leaders who are mainly active, they can involve meaningfully. But the down level, when we saw the treatment challenges, we saw the diagnosis challenges, we saw the supplies challenges, where we need effectively and meaningful involvement of the community voices towards the TB response. And we need, like again, I already shared, I'm not repeating that screening thing. We need to promote the universal access and ensuring the upfront availability of the DST and IGRA, which so many team members here present already those issues very emerging and concerning. We need a tailor-made approach that need to define the vulnerability of the for the TB, because still we are seeing like there are set of population where we are reaching for the screening and testing. There are so many high risk vulnerable groups, like people who are from the transgender communities, people who are living by the high risk behavior in the very close setting, people who are in the prison. Already we are doing so many intervention with them, but still we need tailor-made approach and gender responsiveness in this tailor-made approach again. So if we see the gender segregation among the service access, that is again need to define and very focusfully need to implement. Excuse me. So again, in TB, people-centric approach, we need with the right-based approach, by considering the human right approach and access in the TB preventive services as well as other health support for the TB communities and susceptible generation for the TB. So we need full-fledged prevention services to enhance and ensure the TB preventive services among the family members of PLHIV and high-risk group people who are living in the close settings. We need to uptake and enhance and demand generation for the TB preventive therapies in the children, in the aging people, and we have to provide the access to timely availability of TB preventive services and treatment without any interruption. TB community also need the latest technologies to screen and diagnosis for TB. As my colleagues also mentioned earlier, we need community-led monitoring intervention, very rapid manner. They need to implement in very rapid manner. We need to capacitate the TB communities to do and to use the CLM tools in the National TB program. And we have to strengthened by the investing in the communities to develop the local community support system. And we need to provide the support and resources to enhance and strengthen the community system support at each level, because we are seeing some of state forums are very active, but in compare of that, there are so many challenging population among the TB people who are not having the access to that community platform. So we need to enhance and strengthen the community support system at the local level, and we need to have the bottom to top approach for the strengthening the community system. So these all are my asks and wish list to reach out the 100 targets for the TB and HIV. If I missed out something here, you can ask the queries in the chat box and give your recommendation. If you have any question, also you can ask in the chat box. Again, I am echoing this message: the day we give up is the day we die. So we are hopeful while we are together, we can eliminate TB and we can end AIDS. Thank you so much.
Thank you, Mona Madam. You have highlighted very important point. I noticed awareness. Yes, we have to invest on awareness, because when we talk about the TB and HIV, there is still huge stigma. That's why media can play a crucial role to minimize the stigma on HIV and TB. Saying this, thank you so much once again. I would like to call Rajesh Didia, leads TB people Nepal. Over to you, Rajesh.
Can I interrupt here, Kalpana? I think
yes, madam.
TB people Nepal are not there. Maybe if they join later, we will invite them to speak. But they are not online as yet. So,
okay.
Yes. So
what about the Samir Thapa Chetri?
No, they are not there. No, none of them are there right now. So thank you very much, Kalpana, for being there and conducting and sharing this session. We are really grateful to you for that. Thank you very much. And now we move on to the next session. I take over from Kalpana at this stage.
Thank you. Over to you, madam.
Thank you
all.
Thank you.
It's my great privilege to be here chairing the session. Thank you all. Thank you, speakers, and thank you, participants. Thank you so much.
Now, welcome to the session on reality check on ending tuberculosis among people living with HIV. Again, we are emphasizing on the 100 for TB and HIV both. Find 100% of people with TB and HIV, offer them effective treatment, and stop further spread of both. I invite Dr. B.B. Rivari to please do the honors of chairing this session. Dr. Rivari is former regional advisor for viral hepatitis, HIV, and STIs at Southeast Asia Regional Office of WHO. He is former associate professor, Department of Internal Medicine at RML Hospital, New Delhi. He led the ART program at India's National AIDS Control Organization for 14 long years, steering it to the world's second largest ART program after South Africa. Currently, Dr. Rivari is a visiting professor at Institute of Liver and Biliary Science, Delhi, and an honorary clinical professor at Division of Global Health, University of Washington. Welcome, sir, and over to you to steer this session forward.
Good morning, everyone. Thank you, Shobha, for the nice introduction, and Bobby for giving me this opportunity to chair this important session in this AIDS 2024 affiliated independent event. I think this is a very opt target that has been given, 100, the title that has been given. Why I say so? Because TB remains the leading cause of death among PLHIV. Even in 2022, it accounted for 30% of all AIDS-related deaths in the world. And these 200,000 deaths represented 15% of all TB deaths. We all know in this learned audience that PLHIV are 15 to 20 times more likely to develop active TB disease than people without HIV. If we see even on ART, PLHIV are 3 times more likely to die during TB treatment, and they also continue to suffer disproportionately from this preventable and curable disease. In addition to early access to ART, high quality TB screening, expanded use of TB preventive treatment, they are critical interventions to ensure that people with HIV receive timely treatment for TB disease or TB infection to prevent this. In this session, we are going to listen to experts from different fields, including experts from WHO, community, and people living with HIV. How can we really reach to 100? And we will have their varying thoughts, and it would be a great opportunity for us to listen to that and have an opinion from the experts. And I was just listening to the previous session also. That also was a very good presentation from Mona Balani also. So we move on to the agenda, and I would like to request the first speaker, Dr. Ishwar Gilada. He's a Governing Council member of International AIDS Society, President Emeritus of AIDS Society of India, part of AIDS 2024 Organizing Committee, and a very dear friend. Over to Dr. Gilada for your keynote address.
Thank you very much, Dr. Rewari. It's good to see a lot of known faces, and thanks to this kind of system of webinar, where otherwise if we don't meet, we can at least meet here on screen. But the flip side is that because of such seminars, we don't meet face to face so often. So it is a flip side, but we have to stay with this kind of flip side. And that is a gift of COVID to all of us, that we have to go with this kind of system only. Let me share the screen. If I move from here, okay, it's a full screen. Is the screen visible fully? And I'll just go to next slide so that I see if it is moving or not. Is it next
Yes,
slide?
sir. Yes, it's moving.
Okay. So basically, I would like to just update people on TB in PL-HIV. Will we be able to end it by 2030? TB as a presenting feature in HIV before being detected. TB also has an iris in PL-HIV who have latent TB, and also as a result of test and treat policy. TB reactivation or reinfection in PL-HIV on failing regimen. TB can be seen in PL-HIV as seen in non-HIV due to aging with HIV. TB can be in good immunity and bad immunity. TB can be DRTB or drug-resistant TB, and TB as extrapulmonary TB. Targets are good to activize the machinery and set the efforts in full swing. So even if we may not end TB by 2030, we would have made a great progress in that direction. My answer is a mixed basket, and sometimes people may say that I am a little bit pessimistic, but I will justify what I'm saying. In outline, I would like to cover changing trend in the age of population, co-infection and comorbidities in HIV. How is TB HIV different from standalone TB? When is it right time to initiate ART? Other concerns, that is drug-drug interaction, iris, and adherence, latent TB infection, and TB prophylaxis. Considerations before ART, even in test and treat era. Beating stigma with holistic care and celebrations, and conclusion and take-home message. So what is common in HIV and TB? Both are immunological disorders. Both are chronic diseases. Though HIV is a lifelong condition, TB isn't. Stigma, there is a stigma of sexuality in HIV. There is a stigma of contagion in tuberculosis. Both require lasting commitment from caregivers as well as persons who have HIV and TB, and we need good adherence. Both have challenges related to managing DR, that is drug-resistant or multi-drug resistant cases. Both are under free rollout. Effectively, 90% of the patients get free treatment. However, there are some differences. When you talk about tuberculosis on one hand and HIV on the other hand, tuberculosis is caused by a bacteria and HIV is caused by a virus. Tuberculosis is 0% preventable, though whatever efforts you do, you cannot prevent somebody's cough who is having tuberculosis, but 100% curable. HIV is 100% preventable, but 0% curable. Though we have been talking about cure research, etc., but we are not very close to cure of HIV. Tuberculosis is the least glamorous because only lower middle income countries gets the most brunt. HIV has been highly glamorous because rich countries were affected first. Tuberculosis, after over a century of existence, only 12 to 13 molecules are there, and out of which only 2 are new molecules. In HIV, within 36 or 37 or 42 years, HIV has 25 molecules and over 30 in pipeline. Tuberculosis piggybacks in most HIV patients, but HIV may not do so in tuberculosis patients. Despite such contradictions, they coexist and they ruin the human being. The importance to TB has come only after HIV, and that is a good side of HIV. So when you talk about how TB can come in natural history of HIV before starting ART, you can see that when the CD4 graph goes down, viral load goes up. At some point of time, particularly point of intersection is caused around 200 CD4 count, and then tuberculosis and PCP pneumonia comes. But TB can come in good immunity and it can come in bad immunity. And if patient is on treatment, then it can be after treatment failure. So actually, when you talk about treatment failures, we can detect any kind of failure much earlier. But by and large, human beings wait for a clinical failure. And clinical failure is the third in order. The first will be a virological failure, second will be immunological failure, and third will be clinical failure. By the time it is clinically failing, it may be 2 to 3 years down the line. So when person is put on a good treatment, good regimen, and currently most of the people in the country are on TLD regimen, where the medication started, after that the viral load goes down. There are different ways to look at viral load. There can be different techniques by which it is either below 50 or below 34 copies or below 20. But nowadays there is also a trend to look at below 20 also as a TND, target not detected, not a single virus in a that 1 ml of blood, 1 ml of plasma. So when and how that fail, no one knows. We know that dolutegravir is a robust drug. It may pull on for 10 to 15 years, but some people may fail, and therefore we need to monitor. So when we look at people who are surviving with HIV, as me, Dr. Ivorian, and a couple of us who have been in the field of HIV for more than 3 decades, we initially never knew ourselves that we can pull on the patient for decades. So we used to give them a 5-year national plan, like national plan. We used to tell people, prepare for your next 5 years. After 5 years, people will come back and say, sir, mera 5 saal to ho gaya, abhi kya karna hai? Next 5 years. But now we can see that with HIV and robust treatment, the HIV positive person, even if diagnosed at around 20 or 25, can live as much as HIV negative person. So in India, average age at birth is 71 for male, 73 for female, and even with HIV, we can pull that patient to that level. And sometimes we have seen a patient with HIV on good treatment, good follow-up survives longer than a patient without HIV among the same family, for example, a spouse or brother or relatives. So there has been a division of at what age people are there of the National AIDS Control Program. And they realize that the age group above 50 plus is increasing day by day. So we are facing with an aging population, even with HIV and on ART. And at our own clinic, we have looked at how many people are there. So in HIV 50 plus kind of age, there are people who are diagnosed late, and that is around 28%. There are new infections around 17%, in the 55 which are growing with HIV. So this new infection, we are allowing it to happen because when we talk about HIV, we talk about only young population. We never thought and we never think that even older people are indulging in sexual activity. They are indulging in more often sometimes than the young people. So we need to look at this aspect and the diagnosing late, because we don't even suspect at that age person can get HIV, and therefore we delay. Tuberculosis, the most common opportunistic infection in HIV, and when they are together, they are double trouble, and I will show you how they are double trouble. So TB is a leading cause and death globally in HIV patient, because when we talk globally, we talk mainly about the developing country population. So tuberculosis and HIV associated tuberculosis, you can see how many deaths are there which are estimated because of TB in HIV. So when we're talking about HIV and TB, and we try to put a graph or try to put covering each other, then there's a TB, then there's MDR TB, then there's a TB and HIV. And we can have 4 sets of people. One is with the TB with HIV, one is the MDR TB with HIV, one is a TB with MDR HIV, and there can be a 4th set which is MDR TB with MDR HIV. Again, in that there could be communicable tuberculosis, which is a respiratory tuberculosis or lung tuberculosis, and by cough the person can spread tuberculosis with a MDR. And it can be non-communicable, which is a mostly extrapulmonary, and that is difficult to communicate to other people. So at least for public health, that is a good tuberculosis. So when we talk about India has the highest TB burden and the 3rd highest HIV burden, we have prevalence is around 40%, lifetime risk is around 5 to 10%, 10% per year in HIV, incidence is around 28 lakhs per year, 87,000 are HIV infected, last year it was 69,000. 15% of the incident TB and 25% of the TB deaths have HIV. MDR TB twice as common with HIV than non-HIV, and mortality in HIV and TB is equal to twice that of the HIV alone. So how is TB and HIV different from standalone TB? The tuberculosis diagnosis is very tricky in HIV patient. Rapid clinical deterioration is there. A typical presentation, you see almost 15 to 30% people have a normal X-ray. Sputum negative, despite having tuberculosis, and subclinical tuberculosis. There is the extrapulmonary tuberculosis chance in 40 to 80% versus 10 to 20% in HIV negative people. So if you see this kind of mirror image, on one hand there is a tuberculosis lymph node, on the other hand there is a PGL. And there are many number of practitioners, even 35 years after the first cases were diagnosed, where they will continue to poke in this kind of PGL for checking whether there is a FNAC positive for tuberculosis. There are imaging features. There can be typical fibrocavitation pattern. It can be typical fibrosis pattern involving the right hemithorax. You can also see typical fibrocavitation pattern with upper lobe involvement in a CT. Chest radiograph, which shows as a and CT in 2 different patients, a typical pattern of lower consolidation and hilar lymphadenopathy. We can also see loculated neural effusion, and where there is a diagnostic dilemma, whether there is a tuberculosis or carcinoma or cancer. This is the endobronchial cavitatory, and it presents as a predominant upper lobe involvement. It can be miliary pattern with mottling seen in a severely immunocompromised patient, what we see commonly in HIV. It can be one lung is totally gone, and there's a roll of lobectomy, but there are hardly any surgeons who are available to do lobectomy, even thick of the tuberculosis hospitals. The problem is also MDR TB post treatment, and we see that there's a radiological worsening despite clinical improvement. So we have to always back up our clinical improvement with radiological improvement also. Then the MDR TB and MDR HIV patient, which is a major challenge. DST takes more than 6 weeks for the reports. Hardly any prognostic markers are there, and there is also polypharmacy where people will come back with diarrhea, vomiting, nausea. There is a pericardial effusion, mediastinal lymphadenopathy. I'm showing this slide because to show you that there is tuberculosis is available everywhere inside the body. So we have seen this kind of hepatomegaly, and we just do FNAC and find out it is teeming with AB bacilli. The person coming with a swollen hand and where you have a fungating kind of mass, it can be cancer, it can be tuberculosis. A biopsy takes much expensive for the patient, but we empirically treated after 5 months of ATT, the patient is okay. So how best we can utilize the diagnostic assays available to us? There's the X-ray and CT scan, and CT scan is suspected pulmonary tuberculosis cases who have normal or non-specific abnormalities on X-ray chest. So sometimes if you have a clinical patient, X-ray seems to be normal, ESR is high, and you can also do CT scan and you find that you missed that finding in X-ray. The sputum microscopy detects around less than 50% of TB cases. MGIT sensitivity nearly 100% in sputum smear positive, and more than 95% is sputum smear negative. Gene expert sensitivity is around 70 to 95%, specificity is around more than 95%, and cannot be used for follow-up because even if in a treated patient, cured patient, it will keep on showing positive. Line probe says INH and RMP second line LPA is available. Urinary lamp is a point of care assay. It takes only 25 minutes. With disseminated tuberculosis, less than the CD4 100 count, seriously irrespective of CD4, high sensitivity with low CD4 count. So when you talk about array of diagnostic assays available, we have radiology where X-ray and CT scan is there. Detection of bacteria, we have smear, microscopy, and culture. By molecular assays, we have gene expert and line probe assay. We are in antigen detection, we have TB lab. But when you look at comparing a gene expert or CBNAT or TrueNAT, we have increase in case detection. This is fantastic. It's more than 45% cases are increased because of well detection. Indication for second line DST indicates bacillary load, no value in monitoring response, and its sensitivity is around 95% and specificity also around 95%. So when we talk about lab, urinary lab, this is a 30-minute assay. No training is required. No equipment is required. No biosafety precautions required. No, it's a low cost and easy sampling. So when you talk about CD4 and tuberculosis, CD4 goes down, tuberculosis comes up. And somehow in the program, the importance to tuberculosis has gone away, CD4 has gone away. They are not doing CD4. So change in CD4 will count associated risk of TB in an individual from a time of seroconversion during HIV progression and after initiation of ART. And a meta-analysis of cohort studies reported a 67% reduction in the incidence of tuberculosis in patients who have ART. So there's a right time to initiate ART. This is an integrated and sequential approach. Integrated arm is there, sequential arm is there. We need to decide when to start. In the next table, I'll show you which is the best way to start ART in tuberculosis, despite the test and treat era. So when CD4 count is below 50, there's a malnutrition, wasting, organ dysfunction. ART initiation in relation to anti-TB drug within 2 weeks of ATT. More than 50 CD4 count, up to 8 weeks after initiation. CNS tuberculosis delayed for first 8 weeks of ATT regardless of CD4 count. And drug-resistant tuberculosis 2 to 4 weeks after initiation of second-line medication. So what drugs to choose in ATT and ART and what are the concerns? So there's a drug-drug interaction, there's iris, pill burden, and adherence goes down, and overlapping toxicities. So when we talk about drug-drug interaction, there are NRTIs and NRTIs, protease inhibitor, integrase inhibitor, and what can be given except TAF, everything can be given. And earlier we used to think that with dolutegravir, double dose of dolutegravir is required when there's a patient is on rifampicin. But now our study shows that it is not required. Double dose is not required. And enfortumab we don't have, so we do not even talk about it. So when we look at paradoxical worsening of symptoms and signs despite immunological improvement, and that is iris. So that is sometimes paradoxical TB iris and sometimes unmasking tuberculosis. If you have been unable to diagnose tuberculosis because at the initiation of ART, we don't do at many places no X-ray and CT chest is far. Immune reconstitution or iris is possible in 11 to 45% of patients within 60 days of ART. This is a predictor of iris. What is the predictor? Low baseline CD4 count, low hemoglobin, low weight. Even if you have not done the CD4 count, at least low weight and low hemoglobin has to be looked into. Earlier ART initiation after ATT, extrapulmonary focus, disseminated tuberculosis, and we have to rule out MDR resistant TB, lymphoma or any other opportunistic infection before starting ART, and decline of viral load. So when guidelines are there for tuberculosis preventive therapy, we have to rule out tuberculosis prior to treating latent tuberculosis cases. So it's the 6 to 9 months of daily isoniazid. 3 HR, that is the rifampicin and INH, or 6 months of INH. That is the standard therapy. But now recently, 3 HP, that is the rifampicin INH, which is to be given either once daily for a month, which is approved in our last meeting with the treatment committee of NACO, or it can be given once a week for 12 doses. Till today, it is not available. They say that it has been done. We called up a couple of ART centers, it is not provided. The problem with this is that there is only one company in the world which is making this drug. We are providing to 92 countries in the world, and that is happening for the last 4 years, but Indians are not getting it. So it is very simple saying, Diye tale andhera. So when we again try to capture, we need to have an active case finding, and these are the ways to find cases. We need to look at iris, and we need to avoid iris because sometimes people may die of iris rather than the tuberculosis or HIV itself. All HIV patients to be treated with LTBI, and that is required only once. Once the CD4 count goes up and patient is stable, we don't need second time TB treatment therapy. Integrated ART within 2 to 8 weeks of ATT initiation. TLE, TLD, all OD doses are good enough, and we have to strengthen the strategies to increase adherence. And the strategies can be different, but we need to take a help of community for that. So basically, STI, TB, HIV, all have stigma, and we need to stop stigma, and we have to also stop infection. It is only not important to stop infection. We need to stop stigma. We have miles to go before we sleep. So when we look at prevention of opportunistic infection, tuberculosis can be prevented to some extent. PCP, toxoplasma, they also can be prevented, and these are the guidelines. So beyond drug, we need to look at quality of life. There should be easy prescriptions. We should avoid polypharmacy, polypathy, and window shopping. We have to also see that adherence to medicine is there. You have to involve family, caregiver, or support group. Mental health and sexual health both should be seen. These are the most neglected aspect in our healthcare. Avoiding multiple health visits, so comprehensive healthcare. So for tuberculosis and HIV, they can visit together simultaneously. Stop addictions, and if possible, if not possible, then reduce it. Healthy lifestyle, exercise, yoga, nutrition, positive thinking, helping others, and it will come back to you. That kind of phenomena to be taught to patients. We can see this. We had a very good cultural program, and a couple of times we had that, where family, friends, well-wishers, caregivers are on one platform, and with the theme, ye Jeevan hai. This Jeevan ka yahi hai rang roop. So when everybody is together, no one knows who is patient. Nowadays, we cannot make out who is the patient. Then second thing we started was celebrating 25 years of the patient care at our clinic. So any patient who is following for 25 years, and when the patient comes next, we cut his cake, and we have a talk from that patient, we have a talk from other people, and this is going on, and we have at least once a week or twice a week this kind of celebration going on in the clinic. So what do PL-HIV expect? They expect low cost, they expect single tablet regimen, they expect less adverse drug reaction, they expect no food restriction, they expect good survival, they expect small size or palatable tablets, they expect no physiological, pathological restriction, no new disease condition, no tuberculosis, build up and maintain good immunity. So they expect all this. What do physicians expect? Give better survival to PL-HIV so that they can visit them again and bring other patients too. In any case, physicians do not want to lose their own patients. No emergencies from the patient management, no ADR or drug ADRs, less ADRs, newer molecules and combo all the time. Otherwise, it will become just mechanical to deliver the drugs, as is happening in most of the ART centers. That only TLD, there's nothing else. To maintain, to remain consistent in approach, rapid turnaround time is very important in healthcare. Ease in diagnosing and monitoring comorbidities, and when people with HIV is on co-medication. Mechanism for age-related monitoring should be there, incorporated everywhere. What is the strength of private practitioners? We are non-judgmental, non-discriminatory. Rapport and good communication helps ensure adherence, long-term commitment. Many of us are there in the care for last 3 decades, and we call ourselves also long-term survivors in this field. Caring pediatric to geriatric, knowledge, specialized, abreast with the current development, open to quick adaptation. Even after this talk, they don't need to have a circular from government to change anything. Adverse effects and co-infection management, including TB and DRTB, welfare of patients, rapid turnaround time with point of care, new and bold initiatives, innovation, transgressing into practice, like 3-in-1 combo, which is FDC suggested by private practitioners, now become a gift to the rest of the world. And we learned this from anti-TB treatment, where 3 and 4 drugs were combined together. ARVs, dose reduction, that is efavirenz 400 and others, all different combination combos available to so quick correction and switch is possible. Even for discrimination, you can see on the right hand, on the left hand, we went to fight the Dominic D'Souza's release from jail, who was kept in a TB sanatorium in Goa in 1989. And we put pressure on the member of parliaments. The bill was introduced, and in 1991, I was invited to the Joint Parliamentary Committee. It took almost 27 years from there to have the bill. Now the bill is there. Bill has become an act, which is called HIV/AIDS Act 2017. But from there on till 24, in 7 years, there is not a single prosecution. So there are laws, there are acts, but they become toothless because community doesn't act. And we talk about HIV undetectable is HIV untransmittable. And we also say that when is untransmittable, life is fully predictable, but except tuberculosis. So we need to look at tuberculosis even for expecting the life after treatment. Unison Medicare came into being in 1995, and this is one of the first clinics in the private sector for HIV and infectious diseases, and that has come up and lived for 30 years. And we look at almost all the aspects. We have support group, we have clinical diagnosis management, we have counseling, pre-test, post-test, crisis counseling, we have laboratory pathology and everything. Quickest turnaround time, less than 3 hours. We have an abstract which will be presented at the International Conference in AIDS 24 on that. Radiology, X-ray, sonography. We have a tie-up for CT and MRI also, where it can be done within an hour's time after appointment. Specialized tests are there, like pulmonary function, ECG, colposcopy, and cervical swabs are done. We have minor procedures which can be done, like electrocautery and FNACs, and adult vaccination, in-house pharmacy, and support group. So training and research is a kind of part of our program, and we have a total ethical approach, no commission practice for last 30 years, gender unbiased care, and turnaround time, as I already spoke, is less than 3 hours. So when a lot of facilities are made available, the wish list also gets modified. In 1980s, they were talking about a mere death sentence. Deaths made headlines everywhere. First death, second death.
Dr. Gilada, you may like to wind up?
2 minutes, just not more than 2 minutes.
Thank you.
So blame game was there. Often we used to be to do terminator counseling. कि आप मरने वाले, मरने का इंतजार करो, planning करो. 1990s, we give us few days. Let me put my house in order, attend event. We started telling, make 5 years plan. 2000s, ART prolonged lives, prevented deaths, prevented infections. Hope got more wheels. In 2010s, marriages, restarting sex, having children, child's marriage, normalization of pandemic, and confidence growth. And now 2020s, we talk about quality of life. Can I see my grandchildren's marriages? And HIV is better than diabetes. So what can we assure people with HIV? Full life with life expectancy at birth, no HIV-related hospitalization, no HIV transmission, can marry both HIV positive and positive negative, can have a child, that too HIV negative. And these are major challenges which will remain, and we, all of us, need to address them. Urinary lamb is not available for routine use. This is only for research. We have been shouting for last 5 years from rooftop. Rifampicin IN is not available in program despite approval, and it may be made available in program right now because they are procuring, but not outside. Test and treat strategy ignores latent tuberculosis, possibility of iris, and sometimes fatal. Majority of private hospitals do not admit TB patients, and especially sputum positive cases. Diagnostic challenges for extrapulmonary TB remains undiagnosed for long time. Effective coordination between departments, though they are under the same ministry. People with higher vulnerability are the most neglected. Viral load availability of reports are long. It takes almost 6 months to get report available. PL-HIV and filling regimen will continue same and get tuberculosis. TB can come in good immunity and bad immunity, but we need to treat both. And NCPI has to emulate Central TB Division for Public-Private Partnership, and that can be another lecture. So thank you very much for patient hearing. I'm sorry if I have exceeded a couple of minutes in my talk. Thank you.
Thank you, Dr. Gilada. That was an excellent talk. No, you just finished in time. This was an excellent talk on conjoined twins. You focused on best utilization of available assays and need to bring in LAM as additional easy-to-use tool, initiate ART as soon as possible after ATT, preferably within 2 weeks. A word of caution also you used on use of TAF in PLHIV on ATT, doubling the dose of DTG for 2 weeks after stopping ATT, and many other things you highlighted like use of simple TPT 1 HP. How can we bring it in and expand it to scale given the challenge of availability? And also you highlighted some challenges in the end that need to be addressed to reach our target. And very rightly said, private sector significantly in TB elimination. Thank you for that wonderful talk. So we move on to the next talk, that is by keynote address by Dr. Suvanand Sahu. Suvanand Sahu has got extensive experience of working in TB for almost 25 to 30 years. He has worked extensively in India, in WHO India, WHO headquarters in the TB department, and now is Deputy Executive Director of Stop TB Partnership. Dr. Sahu, over to you.
Thank you, Dr. Rewari. I hope you can hear me and you can see me.
Yes,
I'm
loud and clear, and we can see you.
Okay, great. And great to see you, Dr. Rewari, and great to hear Dr. Gilada after a long time. I'm trying to share my screen. Are you able to see my screen?
Yes, sir.
And is it in the presentation mode?
Yeah, we can see the
Okay,
screen.
great. So I will talk here from a global perspective, and in the next 20 minutes or so, I will just quickly take you through 3 things. One is where are we in terms of ending TB? What needs to be done to accelerate it? And the third one, I think very important for this audience and this meeting, is what can we do to end TB earlier in people living with HIV? So just to reflect on it, the enormity of the problem we are dealing with, this disease has been there for centuries with human beings and has claimed 1 billion lives, not million, 1 billion lives in the past 200 years. It is an airborne infection, and we saw how another airborne infection, the COVID-19 pandemic, impacted human beings. We also need to understand that out of the global population of 7 billion or so, 2 billion, not million, 2 billion are already infected with Mycobacteria tuberculosis. And they always carry a risk, a lifetime risk of getting into active TB disease. But not all of them will get active TB disease. And we have some tools to prevent and reduce the risk of these people. And I will talk about it a little bit later. In 2022, WHO estimated that 10 million people got sick with active TB disease, and of them, 1.3 million sadly died. This is a huge mortality rate, 13%, much more than what you have seen even in the COVID pandemic. We must also recognize that over 600,000 of them were people living with HIV who developed TB in 2022, and 167,000 of them died due to TB. And as Dr. Gilada presented, TB is a common cause, the most common cause in most countries of people dying due to of people living with HIV dying. TB is the most common cause. TB affects all countries, but it is concentrated in 30 high TB burden countries, which represent 80% of the more than 80% of the global TB burden. TB is also a huge antimicrobial resistance issue. I'm mentioning this because in a few months' time, the UN General Assembly will discuss one full day on antimicrobial resistance in a high-level meeting. More than 400,000 people each year develop what we call as rifampicin resistance or multi-drug resistant TB, which is rifampicin and isoniazid resistant TB. And 160,000 of them die due to drug-resistant TB. There are other forms of drug-resistant TB, which are even bigger numbers, but I will not talk because the focus of this discussion is not that. But just to remind all of us that TB is a huge, huge problem and has been there for so many years with us. Now, if you look at HIV as a key driver of the TB epidemic, I wanted to present here some data that WHO publishes regularly every year through some estimates. WHO focuses on the 5 key risk factors globally that drive the TB epidemic. And these are undernutrition, smoking, HIV, diabetes, alcohol. Look here at the global picture. Undernutrition is a risk factor for TB and actually attributes for more cases of TB than HIV at the global level. The number of people who develop TB and who are attributed to undernutrition as a cause is much, much higher. HIV, although, is important because it comes within the top 5 risk factors. But look at the right side of the slide. The role of HIV varies quite a lot across the globe. And you see a country in Southern Africa, I've taken, for example, South Africa, and a country in Asia, the big difference there. Sometimes we talk about it in generality, but huge differences. Look at the gray bar here. The TB cases attributable to HIV in South Africa by far exceeds all other risk factors. But in Pakistan, it's a small factor there. So the context is very important, and we have to tailor the response also to the context. Now, coming to people ask, where are we in terms of the progress on TB? On the left side, you see the TB incidence and the TB deaths. These are numbers, not rates per 100,000. So from 2015 onwards, because this is the Sustainable Development Goal era after 2015, there has been a decline in TB incidence and also in TB mortality. However, during the COVID pandemic, because of undetected TB, we saw we saw actually a reversal of that downward trend, both in incidence and in mortality. And I will talk a little bit more about it when I talk about what needs to be done to end TB. But note here on the right side that the proportion of TB cases and deaths occurring in people living with HIV has declined over the last several years. In 2015, it used to be 10% of TB. 10% of TB was in PL-HIV, and 23% of TB deaths was in PL-HIV. In 2022, it is down to 6% and 13%. So that's a good progress. Faster progress in people living with HIV than the general population. Are we on track to end TB? No, because the global target is to reduce TB incidence, and this is rate per 100,000 incidents, and the TB deaths, the numbers of TB deaths. These were targets set for the Sustainable Development Goals: 90% reduction in TB deaths, 80% reduction in TB incidence rate. This line you see here, the red line, is in 2030 where we have to reach. This continuous line is where we have reached so far, and assuming that because the COVID pandemic is over and there has been good response from TB programs, if we project this same decline forward, we are not meeting this red target there. So there is a big gap here, and I will come back to this. But just note here that the progress is there, but not sufficient, and we are not on track to end TB. Last year in 2023, in the UN General Assembly in September, there was a high-level meeting which noted this progress. the slow progress on TB. It issued a political declaration, which is endorsed by all member states of the UN. We feel that this political declaration is a bold one. It has some numerical target, unlike some of the other high-level meetings that have happened in the past on TB as well as many other diseases. This was a bold political declaration, and the targets are quite bold. There are also some non-numerical targets. I just wanted to highlight one thing for this audience, that the world has committed to provide 45 million people with TB preventive treatment, and 15 million of them are in people living with HIV. And this is for the period 2023 to 2027. I will come back to it. From Stop TB Partnership, we have disaggregated these global targets, because global targets cannot be achieved unless each country achieves their own share of the target. And in this publication, we have put there for each country the estimated target or the global share of the target by year from 2023 to 2027. You are encouraged to have a look at it and see your country's target. This, we believe, should help in planning, but also will help in monitoring and accountability. Now, coming back to this, how can we end TB? Because we are currently off track. We have done some modeling for the global plan to end TB, and I encourage you to look at the document. I will not present everything in detail here, but this is just an infographic that I would like to present here to attract our attention to some of the things that are needed, which are currently not happening. But if we make it happen, we can end TB. So this is the TB incidence per 100,000 population that we saw. And if you continue business as usual, this is the dotted line we will see, and we will not reach the target here. So we need to bend this line down to reach the target. You see the green dotted line there. That's where we need to be. What are the heavyweight interventions? There's not time enough to talk about everything that we need to do, but I wanted to highlight a few heavyweight interventions. Imagine people hanging on to it and dragging it down. First is we have to find and treat all people with TB. We currently are missing 3 million people globally every year who are not diagnosed and treated. But is it enough? No. We need to diagnose them early, and I will come back to this early factor in a later slide. We are diagnosing many of them quite late, and by that time they would have transmitted to their contacts. So it's not helping in reducing incidence dramatically. Now, is that enough? Just early diagnosis and putting people on treatment? No, we will need some other things. We know that there is a big pool of people who are latently infected. I presented that 2 billion people globally. We have an excellent tool, a therapeutic tool, which can reduce their risk of getting to active disease by over 60%, and in some cases up to 90%. But it has been underused. So TB preventive treatment, or TPT, is very important. This is a tool that has been in the past underutilized, and we need to do more on it. Next, nutrition, very important. I presented to you globally the number of cases of TB attributed to nutrition is huge, 1 in 5 to 1 in 4. And in countries like India, it is even higher. The Russian clinical trial that was done and published recently shows very clearly that if you provide nutrition to contacts of people with TB, you can reduce the TB incidence up to 42% in just 2 years' time. We don't have a more impactful intervention than that. So nutrition is very important. Finally, there is a lot of work happening on vaccines. There are currently six new candidate vaccines in phase 3 clinical research, and we should soon expect a vaccine, and that will do the last that should impact on the last phase once it is available. Now, we also looked at how our country is doing. So out of the 30 countries that I presented, which bear the 80% of the global TB burden, we looked at how countries are declining incidence in their respective countries. We found that, and remember, we are halfway down, 7 years done and 7 years to go. This is data up to 2022. We found that 18 TB high burden countries have reduced TB incidence and some of them quite dramatically. You can see there are some countries reaching up to 20 to 50% decline in just 7 years. So this proves that, yes, it is possible to end TB, but we need to do that in all countries and most of the high TB burden countries. Now, I wanted to also present why we are more hopeful that we can end TB, because today we are not working with the tools that we were working with in the past several years. First, a few examples. There are many, but for time constraint, a few examples here. X-ray screening is an excellent tool to diagnose TB as a screening tool. We all know that. However, X-ray machines in the past have been not accessible. They are in a big hospital. People have to travel there. The throughput is less. Radiologists are often not available to give an immediate report on it. Today, that has changed. Ultra-portable X-rays are there, which can do X-rays in peripheral health institutions in the community as well. And large-scale X-ray is possible because the throughput is very high. These X-rays are being read by artificial intelligence, and we have proved that artificial intelligence is currently developed to such an extent in reading of X-ray as a screening tool for TB that it is outperforming trained radiologists. And it gives you a result within few seconds, usually less than 30 seconds. That then helps you to do a bacteriology test to confirm TB. So that's the kind of thing that is developing. More are coming. We have digital tools that can detect cough, not only the frequency, but the character of cough, and predict and tell you whether you need a further test for diagnosis of TB. And there are also non-sputum based tests in the pipeline that are coming. I wanted to highlight here also that there are rapid molecular tests that can currently do DST in 2 hours' time. We have GeneXpert, but we also have TrueNat approved by WHO, which is an Indian product. And I know that it is being scaled up in India as well as many other countries. There are also more in the pipeline. The second thing on treatment, drug-resistant TB treatment used to be complex. Needed hospitalization, injections, toxic drugs, 18 months to 24 months of treatment. Now it is down to 6 months. 6 months of 3 to 4 drugs. That's the first line treatment. 4 drugs for 6 months. That's the kind of, with new drugs, with bedaquiline, with protonamide, and combination with linezolid or fluoroquinolone, you can treat with 6 months duration only. And this regimen is called BPAL or BPAL-M regimen, recommended by WHO. Unfortunately, in a few countries, it's getting scaled up everywhere. In a few countries, this is not yet available. I understand that in India also it is not available. I would request all advocates to make it accessible to people all over the world. It reduces the pill burden. It reduces the cost of treatment dramatically. And more shorter regimens are coming in the future. A possibility of even long-acting injections and 1 month treatment. The TPT, which is relevant to this group, is down from 6 months or 180 doses that people used to take of isoniazid. Now it is down to 1 month of rifampicin and isoniazid, and or 12 weekly doses of isoniazid and rifampicin. I was hearing Dr. Gilada speak. This is plentifully available. If countries want it, they can request global drug facility from their national TB programs, and the global drug facility will be happy to supply it. I'm saying this because global drug facility is part of Stop TB Partnership, my organization. So we would be very happy to work with countries to do it. But I know that there are some policy barriers which is preventing this the access to these drugs. And currently, rifampicin is being made by more than one manufacturer. In the past, it used to be one manufacturer. So this is available and should be accessible to patients. And finally, vaccines are coming. As I said, 6 of them in the phase 3 clinical trials, at least 2 of them being trialed also in India. So we should see some results out of it and some use of that. Now, coming to the last part of my presentation on what are the actions required to end TB in people living with HIV. Now, you saw that TB is declining faster in people living with HIV, both TB incidence and TB mortality, than the general population. So we should be more ambitious here and try to end TB in PL-HIV earlier than in the general population. I would propose 4 things here. Number 1, we need to close the gap in diagnosis of TB in people living with HIV. Number 2, we need to close the gap in TB preventive treatment for people living with HIV. That's the prevention part. Number 3 is the funding part. The funding for TB screening and TPT for people living with HIV should come from the HIV budgets. I'm not sure how many HIV responses in countries are planning this and how many have funding for this. But this is an important thing, and I will come to the reason why. And the 4th one, very important, we need to bring down the rates of TB dramatically in settings where they are very high. And this is possible. We know that we have the tools, but it requires a comprehensive approach. Just doing piecemeal will not happen. And I will come to a little bit more detail on one of the slides. So I have 1 or maybe 2 slides for each of them, and I'll quickly go through them. The closing of the gap in diagnosis of TB in PL-HIV is very important. There are 2 kinds of gap, and I think we have to remember both are very important. Number 1, there is undiagnosed TB. We are not diagnosing all the TB in people living with HIV. We need to do more for that. But number 2, very important, amongst those who are getting diagnosed for TB, no point in diagnosing them late. You can save the individual's life, but it will not have an impact on transmission, and also the outcome of treatment may not be as good. So early diagnosis is very important. We need to screen. In the past, we were afraid of screening. We were doing only testing for people who come at a late stage, report to health facilities, but screening outside of the health facility is very important. And testing is very important. Look at the slide on the right side there. The top one is the gap. This is the estimated incidence of TB in PL-HIV, and this is what is being reported by countries as notified. There's a gap here. This gap is reducing, but we have to eliminate this gap. But look at this graph on the right bottom here. These are prevalence surveys. Each bar is a prevalence survey done for a number of years over several countries. You can see them here. And what it shows is the proportion of TB that were detected in prevalence survey who were bacteriologically positive and who did not report symptoms. The median was 50%. You look across the world or Asia or Africa, median was 50% and across the countries. So a lot of TB is out there where people do not report symptoms. We need to find them, and that's the reason we need to use modern screening tools. We need to screen, and test people. And be aware of what is subclinical TB. And this is something that maybe everybody is not aware. We always thought that it's a 2-stage situation, a latent TB and active TB. No, there is now a 3rd category in between called subclinical TB. I encourage you to read this publication. This came from a Delphi study, but a group of experts that met globally. I was part of it. So that's why I'm highlighting this, and more work will be done on this by WHO and other partners. Note here that subclinical TB, as you can see here, also transmits. There could be infectious as well as non-infectious variety of subclinical TB. X-ray is a good tool to identify subclinical TB, which are particularly infectious. That means X-ray positive, symptom negative, and positive by GeneXpert or TrueNat. That's the infectious variety of subclinical TB. But in the future, more research is happening on how do we get a biomarker that can detect subclinical TB. So just wanted to highlight that we need to diagnose and treat TB early. Second, we need to close the gap on the TB preventive treatment for PL-HIV. We know there is a tool, It is not fully utilized. We need to initiate this in all eligible people living with HIV. And there is a target. So this is a great thing for advocacy and for country level policy. Countries have agreed to together reach 45 million people, and 10 million of them are 15 million of them are people living with HIV. And we need to use short course regimen, no role of using, no use of doing a long course regimen here. But the good news is the 2018 UNHLM target was actually reached. So we can do it. And this is a bolder target, but we can do it. The funding part is very important because we have seen that post-COVID, there has been great momentum in TB responses. Here you can see the case notification that dropped for TB during the COVID pandemic. But you can see in 2022, the world actually notified more people than ever before. This means the best access to diagnosis that we had. And we estimate that 2023, the data is not published by WHO, but our provisional data shows it will be even higher. So there is a great momentum. But the problem is the graph here. The UNHLM 2023 agreed to actually committed to get $22 billion per annum for TB response. And currently WHO reports less than $6 billion. So there is a funding gap. And we feel that the funding gap may be a bottleneck. And for people living with HIV programs need to plan to fund at least that part of screening TB and giving TPT to TB in people living with HIV. And the final one, as I said, if TB is high in any setting, people living with HIV are there, they will get it. We need to support the TB response with advocacy, with whatever that is possible through using the HIV networks of advocacy and the program to see that we have a comprehensive program, and we call it Search, Treat, Prevent. If you do piecemeal, it will not bring down TB. There are plenty of experiences on this, and but I will not have time to go into it. So I will leave it at that. Finally, to end, let us be reminded the famous words of Nelson Mandela. We can't fight AIDS unless we do much more to fight TB as well. Thank you for the opportunity.
Thank you, Dr. Sahu. That was a very enlightening talk. Particularly, like me, many other people must have listened to the latest targets and updates. It was really concerning to note that 1 in 3 DP patients among PLHIV are still missing for care. But it was good to know at the same time that TB incidence mortality are declining faster among PLHIV. Just to bring to your information that 1 HP has been agreed to by NACO and TB program in India, and office memorandum for the same has been issued. And there are certain quantities of drugs already available with the TB program, and more are being ordered. But you rightly pointed out on underutilized tool like undiagnosed TB, late diagnosed TB, 55% of people globally getting TPT, nutritional supplementation, particularly to contracts that you highlighted. It was also very interesting to note the exciting innovations like ultra-portable X-ray with AIs for large-scale community screening, simple shorter regimen for TB, like 1 month you mentioned in future, DRTB 4 to 5 months, 5 candidate vaccines in phase 3, and some non-sputum tests. I think with these innovations and our efforts, we will be able to bend the curve, and the 4 actions proposed by you towards the end are really crux for this 100 initiatives from community. Thank you very much for your talk. So we move on to the next talk, and that is by Dr. Kamal Kishore Chopra, who is a Pharma Director of New Delhi TB Center. Dr. Kamal Kishore, over to you.
Thank you, Dr. Nirali, for the introduction. I have no presentation, but I will be discussing about the case detection of TB among HIV and HIV among TB patients who are notified in the program, especially concerning to Indian perspective. So, as has been pointed out, only half of the patients of tuberculosis associated with HIV are diagnosed in any country. Same is the situation in India. But in Indian program, from the NACO, the programs is that there should be 4 symptom screening of every client who's coming to ART for taking drugs or coming from the ICTC center for detection of HIV infection. These 4 symptom criteria is very important, and these 4 symptoms are important for screening of the person for if there is any tuberculosis among HIV patients. So at all the visits, and it is said that if a patient is on ART, on every visit that patient should be screened with the 4 symptoms criteria. But there is there's one point more that in HIV, most of the times, rather 40 to 50% times, it is the extrapulmonary tuberculosis, and 4 symptom criteria they pertain to pulmonary tuberculosis. So in daily, what we are doing whenever we are conducting a screening in any vulnerable population, so we are taking care of extrapulmonary symptoms also, and most of them are either lump, which represents lymph node, lump in the neck or axilla or groin, and the second is if there is any gibbous, because port spine is another condition which is prevalent. So if presence of gibbous, any lump, and if there is a pain chest. So in these, they should be added to the 4 symptom criteria whenever we are screening HIV patient living with HIV or clients coming to ICTC center for detection of HIV. So, by that we can not only detect tuberculosis, pulmonary, but extrapulmonary also. Second point is we have to detect infection also, because infection is the stage when person has come in contact with tubercle baseline, but symptoms are not there and disease is not there. So detection of tuberculosis infection in any HIV patient is very important, because if we give TB preventive treatment, which is now the part of that part of our national program, we can prevent progress of infection to that disease. There are 2 tests to detect infection. One is a tuberculin test by Monto technique, which we are doing, and second is the IGRA. In Indian perspective, IGRA is a bit costly, being not used in the program because of the cost factor. And regarding tuberculin test, there is a point that this tuberculin, not specific tuberculin, standardized tuberculin is not available nowadays. Only synthesized is available, which is not reliable. Indian scientists have developed CyTB. CyTB is a new tuberculin which has been developed by India, that has been tested and approved by the ICMR and adopted in the program. Shortly, it will be available in the field also. It is given in the same concentration like 0.1 ml. It is given intradermal. Bleeding is done after 48 to 72 hours, similar like the tuberculin test, but it is more sensitive. Sensitivity is same as the IGRA because it is using same 2 specific antigen which are in the test in the IGRA. The only difference in CyTB test is the cutoff value in this is 5 millimeter instead of 10 millimeter in the tuberculin test. But in India, because of India is a high burden TB country, there are more chances of tuberculosis in HIV, PL-HIV cases. It is said that 70% of PL-HIV in their lifetime, they develop tuberculosis. And 50% of the HIV infection, they are dying because of the opportunity infection or complication because of the tuberculosis. So what we have done in India, we are just treating all PL-HIV for 6 months with 6H, and now the latest recommendation is 1HV to decrease the duration. So all PL-HIVs are given a course of TPT in their lifetime that is given for 6 months with INH till now, but recently 1HV regimen has been introduced in the program, as Dr. Ivorian has mentioned, and shortly we will be getting this regimen. NEPHAK is now available in India. But by decreasing the duration to 1 month, the compliance will increase. And second important thing is it is a single window service. So whenever a patient is coming to any ART center, when a PL-HIV coming to ART center to collect drugs, person is screened with 4 symptoms screening criteria by pharmacist, by medical officer, even by the nurse who is dispensing the drugs. So on every visit, symptomatic screening is done so as to detect the cases at the earliest. And the second step is if a person is positive on the screening, 4 symptom screening is positive, immediately NAT test is done. That is the molecular test is done, which is more reliable give results within short period, and patient will start to TPT or tuberculosis based on the results. And all the ART centers in Delhi, they have been co-located with one of the diagnostic center for tuberculosis, and the emphasis is on to provide CBNet machine to ART center itself so that they become self-sufficient and can get tested. Regarding if the patient CBNet is positive and patient is case of tuberculosis, anti-TB treatment is started. As we are doing molecular tests, we can know patient is either suffering of drug sensitive or drug resistant treatment. And based on the results, treatment is started. Drug sensitive treatment is available for 6 months. Drug resistant treatment for TB is available for 9 to 11 months. Short even people regimen will be recommended. It will also be of 6 months duration. The moment person is detected with tuberculosis, either drug sensitive or drug resistant, treatment is provided from the same ART clinic. We say it is a single window service. At single window service, there is screening for tuberculosis, then there is a test for detect infection, and if symptomatic is positive or symptom criteria is positive, immediately molecular tests are done and results are available, and the patient is started on tuberculosis treatment. ATT is also given from the ART center. So at single window service, both diagnosis of infection and disease are done, and also the treatment for TPT as well as for the TB drug, TB disease that is given from the same ART clinic. Now, this is one side of the story. Persons who are in the PL-HIV or in the ART center or ICT center. Second group of persons are TB patients who are notified in the program. They are also susceptible for HIV infection. So it is a recommendation in Indian National TB program that any person who is notified for tuberculosis treatment, that person should get. That person is advised to get. This is not compulsory, but person is advised to get HIV test done initially at the start of treatment, if not possible, anytime during the start of the treatment. So this is a cross referral. This referral is from the TB side to the ART setups for getting HIV test done. In daily context, if we see more than 95% of our TB patient, notified TB patient, they know their HIV status. Based on their HIV status, they are referred for ART treatment and they are given ART treatment along with the anti-TB drugs so that the treatment outcome is good in cases of TB and HIV co-infected person. Second is active case finding is also done in India, as has been highlighted by previous speakers. We are using handheld X-ray machines in vulnerable population for detecting tuberculosis. And in vulnerable population, most of the time in HIV testing is also. When in active case finding of tuberculosis, whenever a session is done in the field, we usually do in vulnerable population like homeless population, prison inmates, IV drug users, female sex workers. So in that case, if we detect tuberculosis, immediately patient is referred to HIV testing, or sometimes HIV testing is being done by some NGOs in any settings, vulnerable population, where the prevalence of HIV is more. So by 3 methods, we are detecting HIV and tuberculosis. First, in the ART centers, 4x4 symptoms, screening criteria. Then all notified TB patients, they are referred to ICTC center for detection of HIV infection. Third, while doing active case finding, which is very important and very strongly recommended nowadays in Indian program, in vulnerable population, we are doing active case finding, and similarly, at the same setting, even HIV testing. So by 3 types, case detection of HIV among TB or TB among HIV, these things are done. In the next lecture, Dr. Vishal will be discussing about the treatment strategy which we are following in our lecture. Thank you. This is all from my side.
Thank you, Dr. Chopra, for that enlightening talk and sharing your experience in basically cross-diagnosis, detecting TB among HIV and HIV among TB. So we move on to the next talk because we are already on time. So we have next speaker, Dr. BONELA, who is Director of Respiratory and Sleep Medicine, Medanta Hospital, and Project Director, Mission TB Free Haryana and Mission TB Free India. Dr. Datta, please.
Thank you very much, sir. Thank you to Shobha ma'am and Bobby for this invite. And it's a pleasure to be here among so many luminaries. I'll just share screen. I hope it's visible.
Yes, ma'am.
Okay. Strides in TB HIV care by a private hospital in PPP model. Now, I'll be very honest that our work has been around TB, but as Dr. Sahu's slide pointed out, that TB will boost HIV diagnosis and diagnosis of HIV, vice versa will boost TB diagnosis. So our work has been in TB diagnosis, and it's a very unique model because it's driven by a private hospital and by clinicians, which I am a respiratory doctor myself. So I'll take you through a pictorial representation of the work we have done over the last 10 years. So 2015 was launch of the public-private partnership under the umbrella of Call to Action, a TB-free India. And this was a movement started by Central TB Division, USAID, and the Union. At that point, they were drawing in very key influencers, and amongst that, the private hospital I work in, and the founder of that, Dr. Naresh Trehan. So this is the hospital I work in. It's in Delhi, NCR, in the city called Gurugram. And this is Dr. Naresh Trehan, the founder of this. And it was launched with a big bang with the Chief Minister of the state of Haryana, Mr. ML Khattar, erstwhile, no longer. And then Mr. Amitabh Bachchan, who is a national figure and has been the ambassador for numerous health projects of the government. For polio, for example, and then for TB as well. And then he helped us launch this. Now, I'll take you through the technology journey we've done, and I'll then tell you about the work specifically that was that we did in the state of Haryana. So the technology journey, we started with an X-ray van in a district, Rewari, which is adjacent to where we are. So this is a big X-ray van which has a digital X-ray in it. And the digital X-ray, and obviously we had access immediately to the X-ray film, and the district TB officer with whom we worked closely would then make the diagnosis. Now the van was, I'll just go back. It was on a timetabled manner. It would go from primary healthcare center to the next in that particular district 1 day a week. And this timetable was made by the district TB officer. And this was the age of smear positive and smear negative. And whoever was smear negative would be collected by the district team and brought to the PHC where we would get the van and do the X-rays. And then the decision for who was actually active TB, active pulmonary TB, would be taken by the district TB officer. We ran this for 7 months. We screened some 350 patients, and 30% of the X-rays looked abnormal. And of course, we know very well that not all will be active TB, but several out of those would be active TB based on the clinical situation. In 2018, we added a Gene Expert Edge on the van. Now, this was a single module machine, and therefore, obviously, it still took a good 2 hours for one test to come positive. But nonetheless, it kind of boosted the program significantly because we now had point of care testing and point of care diagnosis, and the patient could be started on treatment immediately. Then come to 2022, we then instituted Cure AI, and this again helped a lot because in the peripheries, in the district, it is difficult for the medical officers to report the X-rays, and our department, on top of our clinical work, we were trying our best to keep up with reporting the X-rays. And when AI was proven to be as good as or better than human interpretation, for us, our program certainly got a big boost. And then finally, the ultra portable, we launched in March this year, ultra portable with a bike, which was given by one of the other corporate partners. And so this is in one of the rural settings we go to, and this is like an empty plot of land. Beg your pardon. And then this is how one can set it up and start doing X-rays. And that's all you need, not even a medical center. So this was we started with the big van, as you saw, then we came down to a more medium-sized, like an ambulance-sized van, and then just a simple car to carry the ultra portable in one case and the expert or TrueNAT in the other. And then now even this is an option, the mini mobile, just a two-wheeler. And this is probably not so appropriate for rural areas where distances are huge and the bike is not the appropriate thing. But for inner city, I think this may be a very good option. Now, the key things to point out, this entire work done has been part of the corporate social responsibility funds, which is CSR is now a mandate for all corporates in India, as we are all well aware. And we are also part of the corporate TB pledge, which was launched by the USAID Central TB Division Union. And we were the first platinum member in April 2019, which was given to corporates who were not only doing the work, but also drawing in other corporates to join in. So this is an important source of funds, which we now understand. And these were our partners, just to show, this was, of course, a very initial, when we had these two vans and, and later, this was not really used as a van, and these two later weren't either. But with time, we managed to rope in so many other corporates and public sector undertakings like Wright, RJ Corp, Hero, who have all been responsible for giving us vans, and the others for giving us equipment within the vans. And then the entire running cost is, of course, Medanta hospitals. So this is so within the umbrella of public-private partnerships, we also had smaller private-private partnerships. And this is the current 6 vans we have, out of which 4 are in the state of Haryana. 1 is operating in Delhi, where we are working closely with Dr. K.K. Chopra, who just gave the talk. And 1 has gone to Lucknow, where it is working again in a similar manner through the Medanta hospital. Now, so this is the journey we've had, and what exactly have we done? So I'll take you through the 3 key projects. One is the main one in the state of Haryana for the last 10 years. For the last 4 years, just pre-COVID, we started in Delhi, and then the one in Lucknow is more recent, and I'm not presenting that. And then a DRTB center that we started in the private hospital. So this is the state of Haryana, 22 districts, 30 million population. And this is how we have expanded. You can see from the maps how we started with the simple pilot in 2014, then we launched it in 2015. And over the years, we have essentially spanned across all the districts. And in 2021, even this one, which is not yet colored, but we have covered that as well. All 22 districts have been covered in a cyclical manner where we keep looping around. We diagnose, we move out. So we station ourselves in one district for a 6 to 8 week period. We go through all the PHCs, one cycle, and then we move on, and then we come back again 6 months later. So at that time, of course, now we have 6, all 22 districts. 50,000 patients have been screened in this duration, and 6,000 patients have been diagnosed and started on treatment. And as we know that all patients with TB are tested for HIV, and Haryana, the rate is not high, it's 0.45 per 100,000. And so every TB patient would have been tested for HIV, diagnosed, and accordingly started on treatment. So that is the way that we have tied in with the HIV program as well. So these are just snapshots from where the van goes and in the districts and works very closely with the district team. And very remote areas where there is no access, and the van can reach their park and stay there for a few hours and screen all the individuals there. So this is just to give a sense of the work. Then we also launched an adopted district TB program, wherein these same corporate partners, we assigned districts to them to provide vans and other support while we ran the program. Now, I've named very many, not all worked out, but many did, and that is good, and we keep trying to push this forward. Now, I'll briefly take you through a very effective research collaboration with UCL that we did, which was based in the sub-centers. Now, this is of active case finding. And as we know now, the focus is, when we say elimination, we need active case finding going door to door and literally, pulling the person out. So the blue are the control sub-centers, red are the intervention sub-centers in a district called Karnal. And the idea was to get to establish an effective methodology for ACF, which, as you know, does not exist till date. Now, we started, this is a trial to inform optimal period interval and intensity. And this is a very stable agricultural rural population. So screening door to door, we, Medanta employed community health workers from the community, youth, who would team up with the ASHA worker, who is the government's grassroots healthcare worker, and go door to door and essentially identify patients with symptoms. So we still had symptoms at the start of the algorithm. And that is the recommended guidelines. And now we are looking at other methods because we know that we are missing many asymptomatic. And then this is the subcenter. Subcenter is a primary healthcare center that serves a population of 5,000 to 10,000. And our van would be there, and within the van, we'd do the X-ray for those who had been identified in the door-to-door screening. Now, this is the cascade, and 300,000 patients, over that, individuals had been screened, of who 2%, 7,000 had been referred, and then they underwent chest X-ray with AI interpretation, CB-NAT, then the positives, and some clinically diagnosed. So 244 were eventually notified and started on DOTS, and their contact tracing was further done. So this was a very comprehensive, end-to-end work that we did. And of course, we focus on diagnostics because the state and the national program has a very robust system for treatment. Now, a few things to highlight. In all these programs, we see that women don't often turn up, but in this, 52% were women who turned up, and this is because the distance, the subcenter is the correct spot or point of intervention because it's within a kilometer. Most of the people, 88% of the people lived within a kilometer of the subcenter, so they could just walk across. Otherwise, in the districts, the distances are vast and conveyance is often not there. And so these were two, very key points for us. I'm just highlighting the, significant ones. And then if you look at this, this was the control subcenters the year before the intervention and the year of the intervention in the same period of time, and there was no change. Whereas in the intervention, this is before the intervention, and this is during the intervention with the RCT, the active case finding, we tripled the case notification. So what is important to understand is that we massively increased case detection, but we screened only 2% with X-ray. So, very clearly from the prevalence survey, we know that we are missing many of the asymptomatics. So so what do we do now? Do we trial tongue swabs, mass X-rays for certain categories of people? And again, women, as I said. So it's a very key point. This cluster RCT has been funded by CSR funds. So this is serious research that we did with the collaboration with UCL, with Central TB Division, with the state, NTEP, etc. But what is key to note is that, we don't have to wait for big grants. CSR can fund something like this. Now coming to, after Haryana, we come to Delhi. Now in Delhi, we have worked closely with some civil society partners and with Dr. K.K. Chopra from the NDTB Center. And then UCL as well have helped us tie in with them, TBAI and state NTP. Now, this is Yamuna Pushta, which is where we first started our program. This is a beautiful bird's eye view. This is where there are some, a lot of the homeless people are there and some shelters are there for the homeless people. So the active case finding was done by CES and Humana, diagnosis, chest X-ray by us. Then the molecular diagnosis was done by NDTB Center, treatment by state NTP, and recovery shelters by the civil society partners. So these are just some screen snapshots of there. A differentiated care model was used. And this is from the single homeless men, the Yamuna Pushta. The first time we did microbiologically confirmed, 6% positivity rate on microbiologically confirmed. And when we added clinically diagnosed, between 7 to 10%, so staggeringly high. And we have been very well supported. I mean, we have supported, in fact, with our X-ray, Dr. Chopra's phenomenal work along with the civil society partners, because he personally sees all the X-rays and reports them. And then we have also now started adding AI. So we now plan to take this forward with Ultra Portable and TrueNAT. Now, just another thing to point out that we are forming, in the midst of forming a consortium called the Key Affected Population Partnership. All stakeholders, the government, FIND, Union, UCL, Medanta, etc., and many more. We are just working towards it, a framework which addresses every aspect of medical and social needs for the key affected population, which can include the homeless, prisoners, sex workers, IVDUs, and others, for India, even those in the slums. And algorithms are being developed for a comprehensive medical care for all of these. And this is work in progress, and we will be keeping you posted on it, the partners that we already have. And then finally, to wrap up, the DRTB clinic. Now, Medanta as a private hospital started a DR-TB center with the support of the Central TB Division and the state. The idea was to be able to provide the latest drugs for DR-TB like bedaquiline, delaminid, for patients who need it, because many of our patients continue treatment with us. They don't go to the government center, and then we feel obliged to have the ability to provide them with this. And very kindly, the government assessed us and saw us fit to run such a center. We have around 25 patients, and they're ones who follow up with us, and they have access to the best care available, access to best regimen enabled by Central TB Division, WHO, and state, and it takes place in Medanta, a private hospital. So just the key things: a PPP model through CSR funded research, and CAP. And this is just a screenshot of I had been present for this global meeting on the working group on public-private mix for TB prevention and care. With that, I come to an end. Thank you very much.
Thank you, Dr. Zitta, for a wonderful experience that you have shared in terms of PPP model, how you have built up in terms of addition of point of care and gene expert testing in mobile van, Cure AI, and ultra portable X-rays, and how you have basically partnered with industries, number of industries. I saw you have partnered with under CSR to adopt a district program, and very effectively you demonstrated how can active case finding be done not only at sub-center level, but also among the homeless people, like you said, among the Yamuna Pushta, or maybe in the Bangla Sahib complex. So that is very important, that to demonstrate that this is very effective to increase detection, particularly among homeless population and others, which Dr. K.K. Chopra had also pointed out on the need for the same in his talk. Thank you for sharing that experience. I'm pretty sure this can be replicated further in HIV also. Having worked in HIV for many years, I know the PPP model in HIV has been limited to just 12 or 13 centers that were established in the beginning. And we have very little partnership in terms of which can be expanded further in HIV care also. Because unless you extend that to HIV care also, you will be still missing on TB among PLHIV. So moving ahead in this session, I would like to request Dr. Vishal Khanna, the District TB Officer, Delhi, and other experts from LNJP Hospital for their talk. Over.
Good morning, everyone. I'm Dr. Vishal Khanna. I'm the District Tuberculosis Officer and the District AIDS Control Officer. Actually, I'll be just taking how is this program run at the ground level and how this program is run at the district level. So first of all, what did the government do? They combined the two posts of District Tuberculosis Officer and District AIDS Control Officer to a single person, so that there is no question of any interaction between the two departments. And hence, I am looking as D2 and in DACO. So in my setup, I am in Lok Nayak Hospital with attached Maulana Azad Medical College and the Lok Nayak Hospital. I have an ART center located in Lok Nayak Hospital at the 6th floor. And myself, I'm at the chest clinic, which is the ground floor of the same building. So any patient, at present, there are about 32 alive patients on ART in the ART center of Maulana Azad Medical College. And since inception 2004, they have almost put about more than 12,000 patients on ART. So any patient who is diagnosed with 4S is come positive, the patient has a green card made. All the patients carry a green card, and they are directly sent to me, to my unit at the chest clinic. I also have a facility of getting X-ray done with the help of Director Dr. K.K. Chopra. He's just adjoining. And if needed, we do a X-ray chest and we get the film immediately. And I also have a CV machine, and we put upfront a CV NAT and get the report in 2 hours. And therefore, we do not lose any patient. So any patient who is 4S screening positive gets its X-ray and a NAT test done within 2 to 3 hours. Since the patients are traveling from long, most of the patients are outside, belong outside daily, and therefore by this approach, we are not losing these patients. If the patient comes out to be microbiologically confirmed TB, or if he's diagnosed with clinically tuberculosis, the patient is again sent back to the 6th floor. We have already intended tuberculosis medicine to the ART center, so that his ATT is started. And subsequently, when the patient comes for his subsequent visits to collect his ART medicine, the ATT is also given from the same window. Hence, there is a single window approach, and the patient does not have to travel or does not have to approach the different OPDs or the offices to get his ATT or ART. And both the ART and ATT this patient gets at the single visit from the ART center. So what the good practices I have done, the patient gets the diagnosis on the same day, the patient gets the report of the diagnosis on the same day, and if a diagnosis of tuberculosis, maybe a microbiologically or a clinical, the patient gets the medicine on the same day. And by doing so, we are not losing the patient at all. The second part, the DBT part, the direct benefit transfer of such patient. In the subsequent visit, we request the patient to bring in the bank accounts, or the patient can, if possible, the WhatsApp the bank account, and the DBT is also given to all the patients of this ART center from the office of the district tuberculosis officer, Loknayak Hospital, irrespective of the residence of the patient. So patient living in Agra who is getting ART from Delhi and is tuberculosis positive and using ATT is also given DBT from my office. The third part what we will look about is we also supply the TB preventive therapy drugs for the HIV patients, and we see that there is an uninterrupted supply of these drugs to the ART center. Hence, we are taking care about the diagnosis part, we are taking care about the treatment part, and we are also taking care about the DBT part at the single window approach, and the patient does not have to travel. Thank you, sir.
Thank you, Dr. Khanna, for sharing some of the initiatives that are being done by you as District TB AIDS Control Officer. And the same day ART initiation, DBT to all patients from ART center at LNJP, even when they are from outside the Delhi. So that is very heartening to note that. Do we have more speakers from your side, Dr. Khanna?
We do not have speaking. This was just how are we implementing the program at the ground level, sir. At the level.
Yeah. No, that is very important to know. And I personally know that how these TB and HIV program has been coordinating it. I visited the center many times. So this is one of the kind of model centers that is being functioning there. Thank you for that, your inputs. So we have a speaker, Manoj Pardesi. Manoj, are you there?
Yes, he's there, sir.
Yes, Doctor. Yes, Doctor.
Welcome, Manoj. We'd like to have your inputs. The community perspectives basically on 100, which is more aspirational than 95 we have been talking always.
I agree. So one thing I'm really happy to see these targets, because what we achieve in HIV, we always kept like 2x5, then test and treat. So this target has helped us in at least nearing to the goal. And I'm really happy to see that in TB, such kind of targets are taken. Especially we also implement TB program, and I know a little bit like some ground level issues also in the TB program, and then plus systematical issues also. So one thing I really like about the TB intervention is the 100% HIV test for the people, those who detect TB from TB side. And that's a very kind of good intervention, and it's a very good successful model also. And for that, we really appreciate for both TB HIV program both. At the ground, when it comes to the end user, and there actually the problem lies, like and there actually the targets of 100. So each person who is having TB should detect first, and that is one big barrier. Then after detection, educating about the treatment and completion of treatment is another biggest barrier. And in those both areas, like the role of community, how we can ensure that still the TB program is lots of top to bottom approach. Like doctor will do it, or you have to come here and do it. So those are the things which is seems like a barriers in the TB intervention. There are some operational barriers like supply chain management, which is actually it's very difficult to somebody motivate and motivate them to come to the like ensure the 100% adherence. And suddenly when you see like there are not much like availability of the consumables at the ground or the medicines at the ground, then we lose that connections. And then once to build connection, it takes a huge time, but you lose connections to rebuild. It's a big issue which we are facing. So there are lots of plus points. One of the plus point of the TB program is very deep rooted at grassroots level. What is missing, which we are seeing and we can offer and contribute, is the engagement of the people living with HIV in the TB program. Because we are one of the most vulnerable population or key population till the end of our life. We have a risk of getting TB. The moment our immune system goes down, we have a risk. So the risk of acquiring TB is consistently with us. It's not that, okay, I am taking TPT now and tomorrow it will be, no, I don't have a risk of TB. So if our engagement is like HIV, if TB is our biggest this thing, so how best we can offer a package of HIV and TB and contribute from our end to the entire TB response in this 100 response. That is something like TB program needs to think and start involving. TB program also started creating some district level networks and community engagement. But don't think that it is something additional limb. Unless and until you make it as a part of body, creating something additional limb or extra limb will not help to the program. So sit like we have people, TB HIV coordination is very big, very good intervention. So can we sit together and actually think like how to make people living with HIV as a part of the body, not as an additional limb. And I will end here for this. And thank you, CNS, for giving this opportunity. Thank you, Dr. Rewadi. It's always a pleasure to see you and talk to you. Thank you, sir.
Thank you, Manoj. You rightly pointed out treatment literacy remains a very important part for any care, whether it is HIV care or TB, and community engagement is crucial to adherence and completion of the treatment. We have seen this from the HIV program, how the treatment literacy programs by community have been helpful in increasing the adherence over time. I fully agree with you, and we will have further discussion on this. How can functional coordination with HIV networks and TB program can be strengthened so that they are part and parcel and not a additional support? Hari Singh will have question answer at the end. You have raised your hand. So we move on to the next speaker, who is Prabodh Bhamal, Executive Director of Union for Southeast Asia Trust. Over to you, Mr. Bhamal.
He's not there, Dr. Rewari. He was
fine.
unable to come. So we move on to the next. You can move
So
on
we
to the
move
next
on
one.
to Jahangeer Alam.
Yes, yes.
Yeah. Humana, Jahangeer Awan from Humana People to People. Over to you.
Yes, thank you so much. And good morning to all. Let me share my screen first. Sorry. So today I'll share my experience of lead project working with the urban marginalized population in 4 metropolitan city of India. Before that, I would like to introduce Humana People to People India. So it has started 1998 and currently working in 16 states of India and reaching out 121 districts, more than 10,000 villages and cities and 3 million people. And we are implementing 100+ projects with more than 70 partners, which includes state governments, private corporations, and international funding agencies. Our key areas are education, health, environment, community development, and livelihood. Our areas in health are HIV/AIDS, where we are working since 2011, tuberculosis, diabetes, women and child health. And we have started to work to focus on urban marginalized people from 2016 in Delhi and Mumbai city. So our project name is LEAD, which means leveraging, engaging, and advocating to disrupt TB transmission among homeless, migratory, and urban slum population in metropolitan city. So as there has been challenge to reaching out urban marginalized population for TB program, but during last 1 year we have demonstrated a model how to address this challenge, which improved the TB notification, decline in loss to follow-up and mortality rate, improved treatment adherence and outcomes among marginalized population. Also, we have demonstrated how to engage more stakeholders and partners to improve overall support for the urbanized people with TB. So let's see how we did it during our demonstrations. So yeah, we have reached out more than 6 lakh people in these 4 metropolitan cities and identified more than about 20,000 presumptive cases. So we had a team of 129 field staff where we have trained them well, and we have motivated to work in the field, and we have made a plan to reach this community in a systematic and flexible way, where team has to reach as per their availability in the area. So sometimes they have to reach in early morning and late in the evening. Yeah, so we have leverage for the screening. We have leverage with some other private partners to engage CUF AI app in our as a screening methods. And also we have included one pilot to screen the people through mass X-ray screening. So this is the example for the leverage in LEAD project, that we have added a CUF AI in only one city. So this pilot we have done in only Delhi. So we have added CUF AI, and also we have added portable X-ray with AI readings. So overall, you can see here, so more than 6 lakh people we have screened, and also we have made the awareness among them. And here you can see that we have a higher number of presumptive cases in Delhi because of these our pilots which we have included. And as you all know that there is a challenge to test this urban marginalized people due to their mobile nature, poor health-seeking behavior, and hesitation to access public health facilities. But our project team addressed it well by intensive visit, accompanying them to health facilities, and engaged more stakeholders and partners to mobilize them and support them. So overall, we have tested 84%, which is quite a high number of testing among these urban marginalized population. So you can see here city-wise. And also we leverage with public and private sector for testing. So for X-ray, we have made the partnership with some private lab in our operational areas, where we made agreements with them to provide X-ray in subsidized rate. And overall, we have seen 68% we have facilitated X-ray from the private sector and 32% from the public sector. And we have we leverage with public sector for the sputum testing. So we send all the sputum to public sector, and they have tested with microscopy and molecular. Yeah, so overall 84%, which is also high. But yeah, so treating. So we have diagnosed more than 3,000 people with TB in all 4 cities. So as you know that this is an important part after notification and after diagnosis, because it's a challenge to keep them on treatment till the 6 months to these marginalized people. And we have made our model, or we have made our model to address or to strengthen this part in our lead project, where our field officer, they made some intensive visits from after diagnosis to cure. So it approx 40 visit they do to follow up them. And yeah, so during the treatment initiation, our field officer also make a joint treatment plan and ask their expected migration during the 6 month. So they also, if there is any expected migration plan, so they also note down their expected location. So yeah, and after initiation treatment, our field officer do regular follow-up visit till 15 days, and later on they do at a weekly basis. So it's a very effective model, and it's very effective approach to improve the adherence among this population. So yeah, yes. So here at the initial phase, you can see we have initiated more than 98% people on treatment. Yeah, so which is also contributing in 100, 100 and 100, which is the theme of this event. And this overall, our model working with marginalized population is contributing a lot to this 100, 100 and 100. And if we talk about, because our project is only for 1 year, so all people with TB, they have not completed their treatment, but some of them, they have completed their treatment, and most of are, they are on treatment. So because of our intensive follow-up strategy, they are on treatment, and we were able to keep them on treatment. So yeah, so 21% they have completed during our project period, and most of our, they are on they are adhering to their treatment, and very few, or you can say 3%, they have died, and 3% are lost to follow-up. As we have seen in our previous experience, that there are high mortality rate and high loss to follow-up among this urban marginalized population. But we have reduced in our this lead project as per our intensive follow-up strategies. And we also approach and to household contacts of identified or diagnosed people with TB. So overall, more than 7,000 people we have household contact we have screened, and some of them we have identified as a people with TB. So 43 out of which we have screened more than 7,000 people, they diagnosed with TB, and we have initiated 2,741 people on TB preventive treatment. So we work on prevention also in this project. And as Dr. Vishal Khanna said that all diagnosed people with TB, they also screen for HIV. So in this project, we also screen all our people with TB, which we have initiated on treatment for HIV, and out of 3,126, 30 people we have got as HIV reactive people, and all we have linked with ART centers, respective ART centers in Delhi, in four cities. Apart from lead, we are also working, we are also implementing some HIV projects in partnership with the state. Yeah, and we are targeting different high-risk groups, female sex worker, MSW, and IDUs. Here we are making them aware about the HIV, and we are providing them test, also treating them for HIV. So here we are making awareness, testing them, and for making them prevention. So as we do HIV screening for all our targeted high-risk groups in every 6 months, so we have identified 175 HIV reactive in all our 4 projects, and we have linked all people with HIV reactive to ART centers, and also we have screened for TB to all of them, and 6 out of 175 they are diagnosed with TB. So these are some photos from our field intervention where we are implementing cough against TB and doing screening in the field. So these are photos from our daily projects, and we are reaching people under flyover on the street. And here we are screening verbally based on comorbidity and TB symptoms. We are also reaching on footpath and temporary juggies. Yeah, so here we are screening with portable X-ray with the AI reading. So our field officer, they do thoroughly counseling before sputum collection and transportation. And after treatment initiation, they do the counseling. And as I said, every 15 days we do the follow-up visits. So we found our people with TB on footpath, railway station, under flyover. So most of people in Delhi we are working with, they belongs to homeless category, and other 3 cities they are mixed population, homeless, migratory population, and urban slum population. So if I conclude my presentation here, so there is a challenge to reach urban marginalized population, and during the last 1 year through LEAD project, we have demonstrated it and how to address. So now if we like to reach 100, we also have to reach this set of population in an effective way. So more hands need to adopt this model to create healthy and happy families. Thank you so much.
Thank you, Jahangeer Alam, for sharing this campaign, the lead, leveraging, engaging, and advocating to disrupt TB. I think that is a very apt kind of program that you have started, and it was interesting to see the experience, how you have moved out into the community, into the areas where the national program, TB program, may not be reaching out adequately, and you are very supplementing those activities in the areas which are to the people who are unreached. So in this session, we move on to the last talk. We know that Cote has demonstrated that it is possible to do a community-led same-day test and treat for hepatitis C among people who inject drugs, and that has been recognized globally as a model. So Rajkumar Nalikanta from Cote is going to share with us how can we utilize these lessons for TB and HIV coordination. Over to you, Rajkumar.
Thank you, Dr. Rewari. I will just share my next slide. How do I share my slide?
There is an icon at the bottom with the arrow up, share. If you see at the bottom line.
Okay.
Yeah. Kindly double click on that.
Yeah.
The one you selected, double click on that.
All my slides are visible now.
No, they're not. We can see your screen, but not the slides. Maybe
Not the
you
slide.
double click on the slides.
Yeah, I have double. Is it okay now?
No, I don't think we can see. Do we have slides with the organizers? Bobby, do you have slides?
Yes, sir, we have. So just give us a
Maybe
minute,
you
sir.
can share from your end.
Yes,
Okay,
yes, sir.
okay.
Just a second.
Yeah, we can see the slides now.
Okay.
Rajkumar, maybe you can go and ask for the next as you want to move further.
Yes, yes. Thank you so much. Thank you, everyone, for having me here. I'm pleased and honored to be invited to share our experience of how a community group contribute toward government effort of eliminating hepatitis by 2030. Though our experience is not directly related to TB or HIV, my talk will be completely different with whatever that was shared earlier. However, the purpose of why I am here today is to explore the feasibility of replicating the lesson learned from this model of same-day test and treat of hepatitis C to the context of tuberculosis and HIV. Next, please. To give you a background about our organization, CON stands for Community Network for Empowerment. This is a drug users-led network of 11 community-based organizations of people who use drugs based in Manipur, India, and it was established in 2011. Since 2014, we have been working on hepatitis C with range of activity from awareness building to providing free diagnosis and treatment, working with the government and developing different models, including in prisons. We also develop policy document which includes standard operating procedure on hepatitis C. We do provide uninterrupted hepatitis C service during COVID restrictions. We have also been involved in the state level and national level advocacy activity to improve and avail quality hepatitis C services. When we were working on all this, Government of India had also started implementation of national program in 2019. Testing and treatment are available for free through this national program. However, uptake of hepatitis C screening, diagnosis, and treatment is very poor, largely due to the lengthy pre-treatment process. So we developed this model of same-day test and treat of hepatitis C among PIWIT as a replicable model. Next, please. To give you a further background, a little bit on the prevalence of the infection. It is very high among people who inject drug. We have around 65% hepatitis C prevalence based on our own work that we have done. Hepatitis B prevalence is among people is around 10.8%, whereas co-infection of hepatitis B and C is approximately 4.8%. Next, please. Next. Next. Okay. Going on to how we have done this in terms of the method that we are involved. We work with the drug treatment center targeting people who are undergoing drug treatment in the rehab center. We provide on-site rapid diagnostic testing for hepatitis C antibody, hepatitis B surface antigen, and HIV. People who were negative are counseled on prevention of hepatitis C and hepatitis B vaccination. Among those who are hepatitis B negative, following the WHO rapid regimen dose of 0, 7, and 21 days. The blood sample for those participants tested hepatitis C antibody positive are collected and they were transported to Bavina Diagnostic, where hepatitis C RNA test is done using TrueNet Mol Bio. Those participants who were RNA positive confirmed were initiated treatment on the same day with the advice from the doctor at the Jawaharlal Nehru Institute of Medical Science Hospital as per the guideline of the national program. We provide support to the participant during the whole process until they are tested for SDR tests. Next, please. All the participants were male because the drug treatment center that we approached were all male. Out of 643 individuals we approached, 540 of them are eligible as per the criteria that we set, of which 523 were participant and screened for hepatitis C, B, and HIV tests. During this, what we observed was among 523 individuals, 45.5% of them were hepatitis C antibody reactive, 2.9% were positive to both hepatitis C antibody and hepatitis B surface antigen. 1.7% had only hepatitis B surface antigen positive, 0.8% were HIV positive. Another 0.8% had both hepatitis C antibody and HIV reactive. 0.4% had all the three viruses positive, and another 0.2% had hepatitis B and HIV positive. Next, please. To summarize the above in terms of to make it clearer for everyone, we screened 523 people, of which 49.5% were hepatitis C antibody reactive. 100% of them undertook hepatitis C RNA test on the same day, and 64.45% of them were confirmed to be RNA positive. Out of this 167, 99.4% of the people were initiated treatment on the same day. Out of those eligible for SBR test, 95.8 of them had undergone SBR test, of which 88.7 have active SBR 12 week. Next, please. In terms of the time that you are involved in the process, starting from screening till the initiation of treatment, the median time that was taken was around 6 hours, 49 minutes, with the minimum time recorded as 4 hours and 36 minutes, and maximum time recorded as 12 hours and 18 minutes. Here, I would like to note that we can decrease this minimum and maximum time to at least by another 40 to 50%. This time, the median time was longer because we used only one extractor. If we utilize 2 PEP extractor of the MolBio machine, then the median time would have come down to at least 50%. There was a limitation in terms of the availability of the infrastructures that made the median time a bit longer. Next, please. To conclude, the success of this model was built on the existing national program, which offered free hepatitis C treatment. The peer support that CON provided helped recipients of care navigate the care pathway very easily. This community-led initiative where partnering was done with existing institutions can provide high quality, quick, and comprehensive care. The equipment that we used was TrueNet MolBio. It is the same machine that is also being used for confirmation of TB. Since the process of TB diagnosis using this machine takes around 90 minutes, therefore, if we can properly utilize the facility available, completion of diagnosis and initiation of treatment for tuberculosis can be enabled on the same day or maybe within few hours. But we need the system. We need system to be in place. We already have the tools. Once the system is in place, this model is replicable in other contexts, including tuberculosis, hepatitis B, and HIV as well. Next. So the remaining slide is the photograph of the process involved in our initiative. Since the photograph are not in sequence as per the process involved, let me just explain you one by one. The photograph on the top left is for the pre-screening. During pre-screening, what we counsel them on the benefit and importance of early diagnosis and early treatment of hepatitis C. We also collect the details of the patient, including their consent for taking part. And the next photograph on the right top is the photo for blood sample collections. We are collecting blood to conduct on-site rapid diagnostic, as well as for the RNA test and baseline test. And the next photograph is the doctor giving the medicine to the patient. And the last photograph on the bottom right is the testing kit showing positive or negative results for hepatitis C. Next. And the first picture is of our volunteer handing over the blood sample to the laboratory. And the second picture is for the hepatitis B vaccination among those who are tested negative. And the last picture is the patient taking his first dose medicine at the model treatment center itself. Thank you so much.
Thank you very much. And before we take up a few questions and comments, I would like to thank Dr. Rivari for guiding this marathon session in such a stately and seasoned manner. We are truly grateful to you, sir. And I also thank NCPI Plus India, Humana People to People India, and AIDS Society of India for being co-hosts for today's AIDS 2024 affiliated event. Since we have a little time, I would first like to read out a few compliments. There have been many compliments from the audience for the excellent presentations in this session. And then we'll take up a few questions as well. There is a comment from Precious Nikono from Malawi. It says it's heartbreaking to think that in Malawi, many people are still suffering from HIV and TB, often in silence and alone. The stigma and shame surrounding these diseases can be overwhelming, causing many to hide their status and go without treatment. Let us come together to raise awareness, reduce stigma, and offer support to those affected. Let us show them they are not alone and that we care. Let's make a difference, one life at a time. And yes, we do care. And that is what presentations of many speakers have actually indicated. There is a comment from Dr. Sanya that after the Thailand presentation, which was made earlier today, of community-led initiatives and Humana People to People India presentation and Dr. Chopra's presentation, as well as Dr. Bornali's work with those difficult to reach communities, this is another strong example. He's talking of the cone example, the community-led monitoring and same day test and treatment for people using drugs for HCV. So many lessons we have here for TB and HIV and viral load testing in people with HIV. Hari Singh had a question. Hari Singh has raised his hand. Hari Singh is a very well-known HIV activist and advocate. Yes, Hari Singh, please go ahead. Yes, please ask your question. Please unmute yourself and ask your question.
I think Hari Singh had posted the question in the chat. Okay,
Yeah.
we can hear you now. Okay.
Yes, but
thank you so much.
yeah.
Thank you so much. Good morning, all of you. My name is Hari Singh. I am Vice Chair of Global Alliance for Human Rights. It's a PLHIV network, and I'm also OST counselor working for injecting drug users. I want to tell you all of them a single window treatment and testing is very important to those who are taking injections and other opioids. If someone found HIV positive, I do, and with TB also and Hep C also. So single window roof is very important for testing treatment and other testing treatments. So it's very important. So if NACO or someone can do a pilot project on that, that's very good. And I think it's very helpful to those who are injecting drug users. It's very helpful if someone arrange this kind of pilot project. Thank you.
Hari Singh, you may be aware
Yes, sir.
that TB and HIV drugs, ART drugs, are available as a single window service in all ART centers. Now, coming to people who inject drugs, there have been pilots already in Mizoram and also in Chandigarh and three other places, along with YRG Care, where YRG Care and NACO has partnered basically to provide HIV testing and ART services at the OST sites itself. So there are some experience that we can learn from there and expand this to further to centers where we have more people coming with injecting drug use.
हाँ सर, हम वी आर डूइंग इलेक्टेड पार्टनर्स, हम इलेक्टेड पार्टनर्स के ऊपर काम कर रहे हैं कि जो लोग इलेक्टेड पार्टनर्स हैं, आईडू का पार्टनर है या PLHIV का पार्टनर है, उसके ऊपर अभी हमने पीछे समय में काफी काम किया और ये इसका एक बहुत अच्छा फीडबैक आया है कि वो टेस्टिंग के लिए नहीं आ रहा था। जो पार्टनर है, चाहे वो आईडू का पार्टनर है, फीमेल का, ART वाले का, तो उससे एक बहुत अच्छा एक मैसेज गया है। ये बहुत अच्छा इनिशिएटिव था हमारा, जो पूरा नेशनल था। और टीबी के लिए बहुत जरूरी है कि एक तो हमें टूल्स बहुत की कमी है, जैसे मास्क अवेलेबल नहीं है और सिम्टोमेटिक हम देख लेते हैं, इफ समवन फाउंड 15 डेज कफिंग तो उसको हम लिंक टू द टीबी सेंटर कर देते हैं। लेकिन सिंगल विंडो रूफ पे ही अगर टेस्टिंग ट्रीटमेंट अवेलेबल हो जाएगी तो वो बहुत जरूरी है, क्योंकि आईडीयूज LFU बहुत ज्यादा बढ़ गया है, तो वो ART LFU भी बढ़ गया है और TB LFU भी बढ़ गया है। तो उसको रोकने के लिए सबसे अच्छा जो मैं समझता हूँ, एक पायलट प्रोजेक्ट किया जाए या इसको स्टार्ट किया जाए कि कम से कम एक जगह पर उसको इलाज मिल जाए। तो एक जगह पे इलाज मिलेगा, जांच मिलेगी, तो उसको बहुत फायदा होगा। तो ये मैं कहना चाह रहा था एक्चुअली। तो बहुत जरूरी है ये, इससे हमारे जो है LFU भी रुकेंगे और एक जगह पे इलाज मिल जाएगा, क्योंकि OST खाने तो रोज आ रहा है पेशेंट, तो जब OST खा रहा है तो वो ART भी वहीं खा लेगा, है ना। TB का ट्रीटमेंट भी एडेरेंस अच्छा आ जाएगा। तो ट्रीटमेंट एडेरेंस
I
इज
think
वेरी
your
इंपॉर्टेंट।
point, Hari Singh, your point is well taken. The single window service is always helpful, particularly for key population and people who inject drugs where the chances of getting LFU are higher. So your point is well taken that this could be one of the steps where it will be helpful to have single window
मोस्टली आर वर्किंग पीपल्स एंड लाइवलीहुड भी डिस्टर्ब नहीं होगा, क्योंकि हर व्यक्ति का लाइवलीहुड जीने का अब एक राइट है कि अपना लाइवलीहुड के लिए जाए। तो हमारे पास पेशेंट दवाई खाते हैं, अपने काम पे चले जाते हैं, तो ये बहुत जरूरी है कि हम
Thank
किसी का
you.
वर्क प्लेस
Thank you
को
for your
सफर ना होने
input.
दें।
Maria Iqbal, you have a comment or I see your hand is raised.
Sure.
Please introduce yourself. Maria Iqbal Shah.
ओके सर, बस यही मैं कहना चाह रहा था कि ये
Thank
एक
you.
बहुत
Thank you.
इंपॉर्टेंट। थैंक यू सर, थैंक यू सो मच।
Yeah, thank you so much, sir. So this is Maria Iqbal Shah from Pakistan, and I'm currently a core member at YPR Asia Pacific. So my question was related to the AI tools, which has been used by several institutes. So I'm just curious about the accuracy part, like how they are ensuring accuracy in early diagnostics of tuberculosis. So yeah, if they could share the specificity or sensitivity of this AI tool, that would be great. Yeah.
So can one of the experts answer more on AI? Dr. Sahu is there? Or maybe Dr. Vishal Khanna, any of the TB experts?
Yes, Dr. Rivari, I can.
Yeah, please.
I can address that.
Yeah.
So the AI is used for many things in TB. But I think you are referring to the AI used in reading chest X-ray radiography, So there, chest X-ray is not a diagnostic test for TB. We have to be very clear. It is a screening test. So when you apply a screening test and a diagnostic test, which is a follow-on test, you need to be sure that the screening test has high sensitivity, may not be very high specificity. That means those who are screened as negative should be true negative because you don't have follow-up with them. Those who are positive, you then subject them to a bacteriology test like GeneXpert or TrueNat. So chest X-ray read by the artificial intelligence is highly sensitive, and WHO has looked at the data and has given recommendations that AI reading can be used as a replacement for radiologist reading if the X-ray is being used for the purpose of screening for TB, not diagnosis of TB. We don't recommend X-ray alone to be a diagnostic for TB. As a screening test, it is very good. It also allows you to have high throughput and immediate results. So it has a lot of benefits there. Thank you.
Thank you
Thank
so
you.
much.
Thank you.
There now.
Anyone else who wants to ask a question? We have a question from Dr. Prasad for Dr. Gilada. Dr. Prasad wants to know the role of presumptive TB in HIV spread. Can any one of the presenters respond to that?
Maybe Dr. Gilada is not there. Dr. Sahu,
Yes,
you
yes.
can respond.
Dr. Sahu, yes. Yeah.
Dr. Sahu or
I don't understand the question well. Maybe if Dr. Prasad is there,
Yes.
can elaborate. Dr. Prasad, can you elaborate? Because presumptive TB is people who have symptoms, not necessarily TB. Do you mean that group? And
We don't see Dr. Prasad.
Yeah, sir, we don't see it. We will connect Dr. Prasad over email and maybe we can resolve the issues.
Yeah, can I just intervene, Dr. Ruby Bansal?
Yes, please do.
Yeah, I think the question is how to diagnose the presumptive TB in the HIV patients, or basically because every HIV, I mean, this is a two-way approach. Every HIV positive patient, we should diagnose we should look for the symptoms and for the tuberculosis. So it is very important thing for each and every HIV positive patient should be look for the tuberculosis. So presumptive means we have the 4S symptoms, and if there are 4S symptoms, we follow with the sputum. If there is a sputum, if there is no sputum, we look for the chest X-ray and the other extra pulmonary tuberculosis, so lymph nodes, etc. So there is and if it is a question about the latent TB, so latent TB is very difficult to diagnose, especially in the HIV, because no test is specific and sensitive to in HIV positive patient to diagnose the latent TB. So, but we should keep an eye on all the HIV positive patient for the tuberculosis. That is for sure.
Yeah, we recommend that on every contact, there should be a 4-symptom screening, whether it is in the health facility or it is in the community. On every contact with PLHIV, 4-symptom screen should be done.
Yes,
basically.
it is, and it is being done everywhere, I think, in the government ART center and in the private, because everyone is looking for that.
Yeah. Okay. Any more questions in the chat box, or anyone wants to ask question can raise your hand?
Yes. Nalinikanta wants to ask a question. Please go ahead.
Thank you. Thank you. See, the question that I'm going to raise may be clinically, medically, and ethically wrong from the perspective of the medical fraternity, but as a as one of the drug users representative for my better understanding, I would just like to ask one question to all the respected doctors present here. See, recently, among 3 members of our network, when there was, we have come across a lot of problem in trying to diagnose TB, especially this, what you call that extrapulmonary TB. See, the symptom that they have was fever and ascites. And the treating doctor keep on assessing on, liver cirrhosis related things. And finally, I will mention the name of that respective doctor. I contact Dr. Amit Goyal from NCPI. He was the one who advised us to start TB treatment, and now the patient is getting better. So my question is, both the patient were negative while doing their TB test in GeneXpert as well as TrueNet. So my question is, in such case, are we going to depend to the treating doctor, or are there any specific tests like to diagnose extrapulmonary TB among these high-risk populations? Do you get my question, Dr. Rewari?
Yeah.
Yes.
And Dr. Sahu, would you like to answer the question? diagnosis for extrapulmonary tuberculosis beyond, obviously beyond the usually available ultrasound or maybe the FNAC and all that? Over.
Yeah, the conclusive diagnosis can be made if fine needle aspiration or a biopsy can be taken of whichever organ has been involved in the extrapulmonary TB. I know that this is often not possible because you need some surgical intervention for extrapulmonary TB. But wherever it is possible, our first effort should be to get a tissue or a fluid or something, and then test bacteriologically with GeneXpert or TrueNat. If it is not possible, then other imaging techniques have to be used, and then a combination of imaging and clinical features need to diagnose TB. We need to put into the list all the differential diagnoses for TB, but it is very important to include TB as one of them and look for TB. I think that is the very important thing. I think in a high TB setting like in India where you work, TB should be one of the top differential diagnosis for any such prolonged fever or any abdominal fluid collection and so on. Thank you.
Sir, can I make a comment, Dr. Rewadi?
Yes, Dr. V. Go ahead.
Yeah, it is. I mean, just very well said by Dr. Sahu. But it is a vice versa approach also, because even recently I have a patient in the ART. He has been started on the basis of the CT scans, the tuberculosis treatment, presumptive TB. I mean treatment. But within 10 days, the patient landed up into the hospital with the hepatitis, jaundice, very severe hyperbilirubinemia. And when we test, we did the way we have to do it is the bronchoscopy, and in the bronchoscopy it was clearly we got this JC virus positive. So PCP was positive, but the tuberculosis was the negative. So we need to be very, very cautious, as very well told by the Dr. Sahu, ki all the differential diagnosis, all the opportunistic infection we should keep in the mind. Basically, because in view of deficiency of the test in the government center, there was sometimes we are missing or over treating. So that is just my take.
I agree with you. Presumptive treatment based on clinical criteria is sometimes there is no other option than going for that.
Yeah.
But yes, we do maybe over treating or may also be missing some of the other diagnoses. Yes. We really need to keep that in mind whenever we start a presumptive treatment or what we used to call a therapeutic trial earlier. Mr. Joginder, you can have your question. I see your hand raised. Joginder Upadhyay. You can unmute yourself now.
Hello, sir. Hello. Hello.
Yeah. Yeah, please go ahead. We can hear you.
Myself Jogendra Upadhyay, and GAP organization, Gujarat AIDS Awareness and Prevention Unit. We implemented Shramik Shakshamta project partnership with the ILO and GSEX, Gujarat State Aid Control Society, jointly project under UBRAP. In the 5 districts of Gujarat, with the unorganized sector and informal sector laborers, we screened HIV and TB at the workplace through the community-based screening program. In our project,
we can hear you.
In our project, we the benefit is the 0.31% positivity rate, and hello.
We can hear you. We can hear you.
Okay, and mostly the 96% are detected asymptomatic, and we refer to the ART center for the ART treatment, and we done the index testing beyond the HIV. We jointed government labor scheme. This is a success story of this our project, And my suggestion is for this is this is the in the only one state we do, but the another state we under the UBRAF and under the other schemes we started a lot of covered our labor force, because our 36% population engaged in the labor job. Okay.
Thank you, Joginder, for sharing your experience basically on the workplace interventions that you have carried out under the project.
Dr. Riwari, I wanted to make a comment on what Yoginder said. I think you are also referring to the unorganized labor sector. And this is important because the organized labor sector has a way of accessing healthcare. The unorganized sector, unfortunately, very often doesn't have access to healthcare. I wanted to flag one other issue which probably has been ignored so far and needs more attention. This is the whole issue of unorganized labor working in industries which are dust generating industry, stone crushers, building, this kind of industry. They get exposed to dust and slowly their lungs develops a kind of dust related lung disease called silicosis. And silicosis is a risk factor for TB. This has been ignored in many parts of the world. This has been, I must say, very nicely acted upon in Southern Africa. There is a project on TB. It is called the Regional Project on TB and Mining. They have detected a lot of such cases. And also they are now taking steps how to detect silicosis early and give them TPT and remove them from the dust environment, which reduces TB. Many such people also, because of the nature of migration and all, are exposed to high risk of HIV. I just wanted to flag that as something that has not been acted upon in most parts of the world.
Thank you, Dr. Sahu, for that very important input. We don't see any questions in the box. Shobha, you're saying something?
No, I'm just seconding you that we can't see any more questions there. Just some comments. That is all. So I want to thank you once again, Dr. Riwari, repeating what I had said earlier, for guiding this marathon session in such a seasoned manner. We're really, truly grateful to you, sir. And thanks for being there for all this while. And now we have a presentation from Dr. Samantha Tinsay, a municipal health officer of Bantayan Municipality, Cebu, Philippines, who has been doing pioneering work in reaching the very, very hard to reach populations. And I think it is very much in line with what we have been talking about. So many of the unreached, like the health services are not able to reach them. They are not unreached, but health services are unreached for them. So this is a presentation by her.
Okay, surely. It would be interesting to see what is happening in other countries also.
Presentation is entitled Best Practices in Paradise, HIV and TB Situation in Bantayan Island, Cebu. Bantayan Island is located in the northernmost tip of Cebu province, which is in the Visayan region in the middle of the Philippines. Bantayan Island is a beautiful island paradise filled with white sand beaches, crystal clear blue waters, and the best seafood that you can imagine. And this is the place I've been calling home for the past 3 years. As you can imagine, transportation can be rough, where we get around mostly on these boats called pump boats or catamarans. There are some realities in paradise, however, and HIV is one of them. The HIV situation in the Philippines is like so. In the past decade, the Philippines has gained notoriety as the country with the fastest growing HIV epidemic in the Western Pacific region. while the overall trends of HIV and AIDS deaths are declining globally, an increase in new cases was reported to the HIV/AIDS and ART Registry of the Philippines. And between 2012 to 2023, there was a 418% increase in incidence of HIV. This chart that was seen in a study last year shows the declining trend of HIV globally in green. And in red, you can see the increased incidence of HIV infections in the Philippines with a 418% noted increase. This study, these charts were done by UNAIDS HIV estimates, and you can see there is a significant increase in incidence of HIV. And as you can see here, Cebu City, and Cebu in particular, has a higher rate of people who inject drugs, and that is one of the leading causes of HIV here in Cebu province. So there is an information gap. So amid a growing epidemic of HIV/AIDS in the Philippines, the percentage of Filipino youth, however, who are aware of HIV or AIDS has declined to its lowest level since 1994. As you can see in the chart on the right side, the top right side, the awareness of the youth has gone down from 95% all the way down to 75%. So some 35% of young people also did not believe that a person can reduce the risk of getting HIV infection by using a condom during sex, contrary to the evidence that shows that consistent condom use is very effective against HIV transmission. So this was done in a local study here in the Philippines, and the awareness of the youth and their knowledge of HIV and AIDS transmission was not as high as those in other countries. So all in all, only 19% or 1 in 5 Filipino youth has comprehensive knowledge of HIV and its transmission. So how do we bridge this information gap? Unsaon man ni? Or what do we do? Here are some things that we should do. One is to reach the unreached, to go to the places where usually healthcare workers don't go. So these pictures show our healthcare workers, our nurses, barangay health workers, and our midwives and other staff going by pump boat to other islets within Bantayan Archipelago. So Bantayan has the 6th highest cases in Cebu province, trailing behind places like Liloan, Minglanilian, Naga, Danao, and Consolacion, which are all surrounding Cebu City, and Mandaue City, which are the tri-cities in Cebu province. Bantayan is the only one that's remote, but surprisingly has a lot of cases, probably because we have a high number of tourists in the island and also a lot of people who come and go, so transmission can be rampant. This is just a tip of the iceberg, however, as we've only started screening in the past 2 years. So HIV in Bantayan, Cebu. So prior to 2022, HIV testing in Bantayan was limited, first of all, due to the COVID-19 pandemic, and second of all, due to the stigma in the community, because the Catholic Church is such a big cultural heritage in Bantayan Island. A lot of these testings, talking about sex, all of this is very taboo. And HIV testing only started when I started working in Bantayan around early. So I started in November 2021, and we started testing regularly in January 2022. So it became a routine practice for the RHU to screen all pregnant mothers, persons deprived of liberty or those in the jail, and patients in the National Tuberculosis Program. So we do like a one-stop approach for our TB patients as well. And we go inside the jails and test those who are in prison, and obviously pregnant mothers before they become admitted in our birthing home. This unfortunately was not a practice before, and it only started when I started working in Bantayan. So from 2023 to 2024, Bantayan recorded 12 new HIV cases, and unfortunately out of those 12, 2 died due to complications of AIDS. So these, one of them was only 22 years old, and he died from CMV. He had AIDS, first of all. He had complications of blindness from CMV retinitis and some other issues such as pulmonary TB. He was also co-infected with syphilis. And then the other young man who was in his late 30s also succumbed to AIDS, and he died of complications as well. And unfortunately, these two were from our rural or further out islet barangays, which is about 1 to 2 hours away from Bantayan proper. So how do we bridge this information gap? So first of all, we go in and we educate and empower our island's youth. So, and you can see in these pictures here, our rural health nurses were going in there to the schools, high schools, junior high schools, and even universities, and educating the youth on what HIV is, what are STIs, what is HIV transmission, and how we can go about preventing and avoiding it. So again, knowledge is power. And by us doing this, by getting involved with the youth, it shows that the youth are important and that they are seen and that they should also have the knowledge available to them. So another thing that we started doing is breaking the stigma in our island community by having local celebrities, such as a local beauty pageant winner, engage in testing services. So we incorporated this with with the Vicente Soto Memorial Medical Center, or the government tertiary hospital in Cebu City, where we did a mass screening of about 300 people and provided free ART, free condoms, and free PrEP to those who needed it the most. So we engaged the local community, and we also had local celebrities and politicians get involved to break the stigma of testing in our local community. As you can see, we have our beautiful Bantayanon LGBTQA+ community members here with their free PrEP and condoms. So this was a very successful event, and hopefully we can have many more of this as well. Another thing that we regularly do now is the screening and advocating for the disenfranchised, especially those in the district jail. So we do regular or quarterly HIV and tuberculosis screening in the jails, as well as their checkups, because just because somebody made a mistake doesn't mean they don't deserve checkups like everyone else. So they deserve the same kind of treatment as the general population. And I'm just so happy to say that no one has tested positive for HIV during the screenings, but for tuberculosis, yes, and they've started their treatments for that as well. Another thing that we're doing is mobilizing government agencies to action. As a municipal health officer, as a government employee of Bantayan Island, it was my responsibility to get not only the mayor, but also the local politicians, barangay captains, the Department of Education, and also other stakeholders involved in this fight against AIDS. So as you can see in these pictures, this is our regular local AIDS Council meeting, where we discuss our plans for the youth, our plans for the future, and our projects for our HIV and AIDS awareness, advocacies, and dealing with community members as well. First of all, to advocate for those who are living with HIV. Second of all, to break the stigma. And third of all, to make it a routine, everyday sort of laboratory test that people aren't scared to do. So this is how we mobilize government. So in the future, hopefully this can be cascaded down to the rest of the province. So how do we find the missing cases? So we've only seen the 12 HIV cases. Where are the other ones? How do we connect all of this together? So imagine us at 1 in the morning going on this dark pump boat ride, all because of case finding. So we were here doing our package of TB, HIV case finding in one of the remote islets, an hour and a half away from Bantayan proper. So this is how we incorporate a one-stop shop approach. So this is our approach to both tuberculosis and to HIV screening. So for TB, we use the Introducing New Tools project, as you can see here, the INTP. So the INTP is comprised of three major tools. We have the ultra portable X-ray by Fujifilm X-Air. We have the CAD4TB, which is the artificial intelligence by Delft Imaging. And then we have the MolBio TrueNat, or the RT-PCR, for the sputum samples as well. So this project started in September 2022 through partnership with the Stop TB Partnership and FHI 360 and USAID. So this was our pilot back in September. They called us. We literally had like a few days to decide, and I said, you know what, I don't care if it's typhoon season, we're gonna go for this, because we never know when we're gonna have this type of technology in our hands in a rural area. And now how's it going? So this was our last major case finding back in May 2024. So this was around a month and a half ago. So as you can see here, we incorporate the INTP tools here, but we acquired these tools through different ways. So in the first part, when we had the pilot with USAID, it was them who provided the tools. But this second time around, so we acquired the TrueNat, the X-Air, and then the Delft CAD4TB in November 2023 through letters to the Department of Health, since it was the X-ray was donated to them, and the AI as well. And also through thank you Gets Healthcare, and also through MolBio by providing the machines. And as you can see here, we do a one-stop shop approach where we do diagnosis, we do treatment right on the spot, as well as HIV testing, and we bundle it with other services such as our pap smear, our dental services, and our immunization program. So it's all in one, as well as free medicines and data encoding for our local health, local public insurance. So this is how we're going now. When we go into communities, we go in with all hands on deck, full force, complete services. So let's just go back to the data, okay? So I just wanted to show how accelerated our case finding has been using the new tools. So unfortunately, back in 2021, we had a very dismal case finding because of COVID. We had very strict restrictions here in the Philippines. And in 2022, when we had the INTP project come in September and October, so we only had this for about a month and a half, it accelerated our case finding. As you can see here, we had a total of 2,506 presumptive TB cases x-rayed. And out of those, 1,774 were from the ultra portable. But let's just fast forward to 2023. So we only had the ultra portable and the rest of the tools only for 1 month. So from January to October 2023, we were just using regular traditional x-rays. And then in November and December 2023, we were able to get back the new tools. So we were able to screen 1,001 more patients. So you can see it's an acceleration. Whereas here in 2024, you can see a sharp increase in our presumptive TB cases because we were able to use the tools from the get-go. Unfortunately, we had to return the ultra-portable X-ray in the beginning of June because we had to share it with other municipalities. So I was just so fortunate to be able to use it in our municipality for around 7 months. So now we're back to using traditional. Okay. So for presumptive TB cases, the Department of Health gave us a target of 1,544, and we've exceeded that over and above and beyond. So for TB case detection, again, we didn't do so well in 2021 because of the restrictions. 2022, we had 458 new cases, and I was a bit expecting that because we weren't really testing for a while, and so the cases were piling up, with a 96% case detection rate. In 2023, I'm not so happy with our case detection rate because it's only at 89%. We weren't able to accelerate as much because of the tools were only given at the end of the year, but it's okay because we still found 341 cases. And then now I'm so happy to say we're halfway through the year. We've already found 63% of our cases with a case detection of 63% with 242 cases. So I'm very happy about that. And hopefully it accelerates and we can hit our target of 386 cases or possibly more towards the end of the year. So how do we go about this case finding? How do we find missing cases? Not only do we use INTP, but we also leverage technology in rural islands. So as you can see here on the left side, it's my staff putting our Starlink up on the basketball court. The reason why we have to use the internet is because we are the only municipality. We were the first ones in Cebu province to use electronic health records that does direct billing to our social insurance system called PhilHealth. And that money is able to come back to us and we can be able to give better healthcare services to our constituents. So this island, as you see here, we all have laptops. This is in the middle of nowhere. It's actually in between two different provinces, but it's still part of Bantayan Island. It's about 2.5 hours away from the main island. So next, we also had some logistical issues, but we kept going. So this, unfortunately for us, we are slaves to the high tide. What does that mean? As you can see here, if it's low tide, we have to walk towards the boats. Because if the tide is too low, the boats cannot go across to the other islets. And as you can see here, we were lugging around, I guess this is worth like 9 or 10 million pesos, Philippine pesos worth of supplies around the island. So we had to walk maybe around 1.5 kilometers around to look for the portion of the island with the highest tide so we can go back home. And unfortunately for us, since we were running late because we had so many consultations, we almost capsized. We're all laughing here because we thought, oh, this is so fun. We're getting wet. But then like after an hour of this, we were so scared and we wanted to go home. And there was already a search and rescue team by the mayor looking for us. You know what? Again, when USAID says we want to do this project in the middle of typhoon season, you don't say no, you just go for it and pray and see what's gonna happen. And I have no regrets. Because as you can see here, our case notification rate in 2022 skyrocketed to 517. In 2023, not bad. I mean, it's 388.57, which is above the national baseline. And currently, as of June 30th, we're at 275 for a TB case notification. And hopefully we can get over and above the 2023 CNR. So again, we bridged this information gap with service delivery. Because back then, before my time, this was not a routine thing. Maybe because now we have like younger staff who are willing to go out in the field. To be honest, I like field work more than sitting in an office. So for me, this is something that I love. This is my passion. And it also became the passion of some of my staff. We were able to hire new and younger staff. And as you can see here, I just want to show respect I always do this in all the presentation. I just want to show love and respect to the lady sitting on my left, or depends where you're seeing it, in the black right there in the boat on the left side. That's Ma'am Lalaine, and she is instrumental to our HIV and TB program as our chief medtech. Unfortunately, she passed away soon after the INTP project. But I just want to show lots of respect for her, because without her wanting to push through with these projects, none of this would be possible. Where we are now is not possible without her. So I just wanted to acknowledge her and just remember her throughout this time. So again, service delivery is great, but you also have to have a heart when you're doing it. When we serve, we also serve those who are disenfranchised, people in jails, people who are bedridden. As you can see here on the right, this was a patient with Pott's disease or TB of the bone who we had to debride and go to her house. We had to gain the trust of the community to find the missing cases. So for a TB success rate, fortunately, we're above 90% since the beginning. So I'm very happy about that, and I'm praying that we hit 98, 99%, hopefully 100% in 2024. So when we find missing cases, we're not just looking at numbers here, we're also saving lives. We're saving one life, one barangay, one city, one country at a time. And this is my favorite patient. I always talk about him because I'm just so proud of where he's come from. So this is a case of Joseph. Again, this is taken with his consent. Joseph is now 27 years old, and this photo on the left was taken when he was around 24, 25 years old. He was bedridden, he was covered in sores. To be honest, he was just waiting to die. But because of our local barangay health workers who dedicated their lives to serving the community, we were able to home visit him and do the tests by the bedside. And then we found out, unfortunately, that he had Pott's disease or TB of the bone. But we were able to get him to a tertiary hospital at Vicente Soto. We were able to link him up with a nutritionist, a care team. And so this is him now on the right. This picture was taken, I think, just a couple months ago. Now he can walk again. He can swim, he can fish with his father again. He can have life again. And he just told me he has a girlfriend now, so I'm very happy for him. In Tagalog, we say, sana all, or how do you explain that? I wish it all for everyone. So I'm really happy for him. And again, when we find the missing cases, we are dealing with human lives. We are dealing with real people, real stories. And this is what you should capture in your heart today. We're not just thinking about numbers, accomplishments, data. We are looking at individual stories, individual lives. And this is why what we do is important. I would like to thank our partners, the Stop TB Partnership, USAID, FHI 360, Fujifilm, Delft Imaging Mobile, Gets Healthcare, Municipality Bantayan, the Department of Health, and the Bantayan Rural Health Unit. Madamo nga salamat sa inyong tanan. You can scan this QR code for our Facebook page, facebook.com/bantayanhealth. My name is Dr. Samantha Tinse. You can reach me at samanthatinse@gmail.com. And thank you so much for allowing this opportunity to share my story. Thank you.
Well, that was an amazing piece of work in a country where the HIV infection is still rising, new infection, where the 35% of people don't believe in condoms, young people particularly. And this work in a rural island using the digital technology, AI and other thing was immense work. And we really appreciate this kind of work. And this kind of work really offer opportunities and also offer hope for the people who are living with TB but are undiagnosed. There are people working for them outside the national programs, outside the NGOs, individual programs, people working with homeless and other. So these kind of things definitely offer a hope that we'll be able to reach out to our targets. So we still have 5-7 minutes, 6 minutes. So maybe some short comments, or should I summarize some points? Or anyone wants to have quick 2-3 comments before we close? I don't see anyone. So I think we had a very useful session where we listened from the experts from WHO, Stop TB Partnership, from the national program, and from the community, from the NGOs, AIDS Society people. We had community representative from National Coalition of People Living with HIV, experience from HCV. So which was a wide range of speakers, very well brought together by the organizers. And I would like to thank Shobha and also thank Bobby for giving me this opportunity. I think what we have learned basically is that we have to really look into early diagnosis, reaching out to those who have missed their diagnosis. How do we ensure that we don't miss out even one person? How do we utilize full array of available assays? We have a number of tools, but many tools are still at the pilot stage. We are talking of AI, but these are still being done in bits and pieces here and there. And the kind of mobile van that was shown to us by Dr. Datta, reaching out to community, I think these needs to be scaled up significantly. When we talk of ending AIDS or ending TB, I think we need to go into a mission mode. That mission mode kind of thing is already there. The programs are there, but how do we bring in everybody together where we have people in different sectors working with different people? That is more important. Focusing on timely treatment, completion of treatment, how do we engage community further? We have a lot of community organization working with HIV, but we have limited involvement in TB. Some type of HIV TB coordination is there, but how can we leverage them for, I'm not talking of even HIV TB, I'm thinking beyond that. When we are talking of ending HIV TB, we are also hepatitis also. If not, this is not in the purview of today's discussion, but we can utilize community in a broader way, ending communicable diseases. And how can we bring in a functional coordination with the government organizations? I know there is with HIV, there are good coordinations happening, but over the period, there has been decline in the funding. There has been some kind of, I will say, disengagement also. I'll use that word cautiously, but there has been disengagement at some levels, which we need to bring back. And everybody is committed. Everybody wants to do. We want to focus more on innovation. When we say, when I was in WHO, we had a mantra called SCIs, sustain, accelerate, innovate. We are constantly innovating. We saw some innovation examples from Dr. Sahu, what is in the pipeline. But how do we bring them in fast to scale? It's not to bring in, say we have something and we are not utilizing it fully. Of course, it requires funds, everything requires money. Like LAM, just an example, urine for LAM. It has been there in advanced HIV management protocol for a long time now. But it is still not approved in India, despite all efforts by MSF and other partners who have been working, NCPI, who have been working to bring it in. There are regulatory approvals, there are regulatory barriers which we need. So these things we need to bring in. Nutritional program has well been started by Government of India, and we listen from Dr. Khanna how this is being implemented as a DBT kind of engagement. So I think with these few words, I would like to end this session and hand over back to the organizers. Thank you very much.
Thank you very much, Dr. Ivorian. Thank you very much for your excellent comments. And it is very important. We are talking of technology improvements. We have the tools. But as we say, as I often say, that say we have a vaccine. Vaccine is a good example. But vaccine and vaccination, they are two different things. And unless you use that vaccine or that tool to reach the people for whom it is meant. So unless you vaccinate, vaccines can keep on lying in the box and boxes, and we saw that in the times of COVID also. And then the roadblocks. So the scientists do their work, the innovators do their work, but then to carry that job forward, to make that translate into what we say public health gains. And we have seen examples today how people are doing. And one thing which came across to me was there has to be that passion involved also in each one of us, that passion to save lives. Samantha has shown that she has been traveling over waters and over seas and through very, very bad weathers, hopping from one island to another and carrying that forward. So the tools are there. The tools are very much there, but using them in a proper manner and taking the health services to the people, I think that is the crux of the problem. And thank you very much, Dr. Ivari, for being there. And now we will move on to our next session. Thank you.
Thank you.
So now let us deliberate upon access to latest treatments and preventing drug resistance. And this is the topic of our next session. Our chairperson for this session is